and we have Dr. Bansi Sabu with us, who is the chair-elect of IDF Southeast Asia. And he planned this meeting along with our chair, Dr. A.K. Khan from Bangladesh, and chair-elect, immediate past chair, Dr. Shashank Joshi. So many congratulations for convening this meeting. And yesterday the meeting was attended very well. Before we start, would you like to say a couple of words, sir?
Yes. So thanks, Amit. Thank you all the speakers, all the faculty members who are joining from different parts of the world, particularly from our Southeast Asian countries. So I'm thanking them. At the same time, also I'm thanking all the delegates, because primarily our delegates, which we have planned for this meeting, is from Southeast Asia, and more than 7,000 delegates. I'm so happy to share with all of you that more than 7,000 delegates registered. What was more important, that we could get the doctors from Nepal and Myanmar and even Bhutan and Tibet, and the doctors from even Afghanistan, Pakistan, Sri Lanka, Maldives, Mauritius. So these are all Southeast Asian countries. There are more than 5,000 doctors from India. So that's a big number, but we all know that's a large country and with a lot of physicians. But many of them are very happy. I got a lot of messages yesterday and on my personal WhatsApp also in multiple groups. So people are very happy that this type of program, which is happening online. As we know that everyone can't attend the annual meeting of IDF, which is a large number of audience is coming, but still many of the doctors will not able to attend the meeting. So that was the idea which we have decided and coined during IDF only. We will have one meeting of learnings from IDF, either for dedicated only for India. But then when I was elected as a IDF chair-elect, we thought of why not to do it for Southeast Asia. I'm thanking Dr. Ajad Khan, who allowed me to do this as a learnings from IDF. And we decided that's 2-day program where primarily all the faculty members who were there already at IDF, and they have already talked on that same topic. So we requested them to talk. Few of them are not from the speaker list of IDF, but we just try to get everyone from different parts of the country, particularly from Southeast Asian countries. Few of them are some eminent speakers, also like we have taken Chantal and like ESD President, Kamlesh, and many of them are also there. So I'm sure those who have attended yesterday program and those who will be listening today, they all will be very happy, and there will be a lot of interaction like yesterday it was there with the panelists. Thank you, the chairpersons, because the chairpersons are also very, very important to moderate the session and keeping the time. But the best part is for online meeting, everything goes with right time. So 9:30, we all are starting, we all are meeting at 9:25, 9:15. So that's great. So now over to the Amit and Bharat for the session. Thank you.
Thank you, sir. Over to you, Bharat.
Thank you, Amit sir. First of all, a big thanks to Dr. Bansi Sabu sir for creating this out, because as he rightly said, many people even text me yesterday and they were very happy with what is actually being done, because IDF is not for everyone, and I think this learning will go with all the people who are around and who can watch it. 7,000 plus delegates yesterday. It's tremendous. So again, we are today with tremendous sessions today with our eminent speakers. For the first session, we have Dr. Usha Sriram ma'am with us today, and she is a very well-known figure. She is from Chennai, and she is President Indian Society of Bone and Mineral Research. She is a founder of DIVAS, and she has done tremendous work in the health of GDM, women's health and osteoporosis. And Madam will be talking about the low-hanging fruit in NCD prevention. So this is a very hot topic, and let us hear what Madam has to say about it. Over to you, ma'am. Thank you.
Thank you, Bharat. Thank you, Amit. And thank you, Banshi. A real pleasure to be with all of you this morning. And let me share my slides. I may have to go to the first slide. Okay. So this is the talk I gave during IDF in Lisbon. Very, very important topic, preconception care, something that is not addressed, but as people who take care of diabetes and take care of NCDs, I think if we address preconception care, this will be a big step in in prevention of non-communicable diseases. So I have no conflict of interest. Just to say that, we have to start thinking, redefining how we think of health using a life course lens. So how pregnancy, a window to future health, can impact the offspring and mothers, not just CVD risk, but pretty much a lot of the NCDs as well, as you can see from this slide. And why preconception care? Because you can see in utero programming dictates the life of a person, life and health of a person throughout. So it's very, very important. And you cannot suddenly get healthy during the pregnancy if you haven't entered the pregnancy in good health. And of course, there's all kinds of other things, social determinants of health and diet and lifestyle and other factors that also change the course of health of a person. So there are some controversies, something like, when we provide preconception care, are we medicalizing pregnancy? There's routine assessment of all women for diabetes, thyroid, and all that. And then who should offer preconception care? So preconception health as a key determinant of pregnancy success and next generation health, drawing on evidence across clinical, biological, social, and policy fields, and linking this to the fact that pregnancy is indeed a window to future chronic disease, and the fact that the first 9 months shapes the rest of his or her life. But what we need to do is have a sharper focus on preconception care by all. Now, so what is the aim of preconception care? It is the provision of biomedical, behavioral, and social health interventions to women and couples before conception occurs. It aims at improving health status and reducing behaviors and individual and environmental factors that could contribute to poor maternal and child health outcomes. Ultimate aim is improved maternal and child health outcomes in both the short term, because typically what's happening in pregnancy all across the globe, particularly in our part of the world, is we only look at pregnancy through that narrow lens of, is the baby going to be born healthy? That's all. We are not looking at mother's health or even the baby's health in the long term. So its ultimate aim is to improve maternal and child both in the short and the long term. How do you define this preconception period? It may vary from 3 months before conception, 1 or 2 years before the initiation of any unprotected sexual intercourse. So the Lancet says new definition. It is looking at multiple perspectives. It could be just biological, just days to weeks before embryo development. That's what typically happens when we prescribe, let's say, folic acid. For the individual, weeks to months before pregnancy, like when we provide preconception care, let's say, for a pre-GDM woman. But from a public health perspective, it's months to years, meaning a healthy girl becomes a healthy adolescent. Then she becomes a healthy mother who's during pregnancy. And then she gives birth to a healthy baby, and then the cycle goes on. So this is the definition of preconception care. So why do we need preconception? Most pregnancies are unplanned, meaning they are unintended, and even if they are intended, they are not planned. And women nowadays enter the pregnancy older, heavier, with more nutritional deficiencies, more metabolic problems, as environmental pollution, unhealthy behaviors, and greater mental stress. And then, of course, the first 8 weeks are critical for organogenesis, and the window starts to close, sometimes even before the first prenatal visit. Just to show you some statistics, you can see the unintended pregnancy rate. And if you take countries like ours, low and middle income countries, big chunk of our pregnancies are unintended. Then I mentioned that women are entering pregnancy with a lot of metabolic issues. This is the CARS data from India and Pakistan, and you can see the amount of pre-diabetes in women of reproductive age, something as high as some places 40%, 30 to 40%. So these are the women who will go on to get GDM. And then you look at studies from even places like the UK, where they, in the diet and nutrition survey, in women of reproductive age, they found they were either overweight or they were not taking fruit and vegetables, or they were current smokers or high risk of alcohol intake. And they took people in the US, they found a high amount of hypertension and then undiagnosed diabetes. And then, risky behaviors like this starts in the adolescent years and young adulthood. And just for definition, women of reproductive age is defined as 15 to 49. And then we also know whenever there is a periconceptional risk factor, look at the risk of future NCDs. Any of this on the left-hand side, you can see risk to offspring and long-term impact on mother and offspring. You can see that there is increased risk. So also interventions that start after the start of the pregnancy have not yielded the required results. As they say, the horse is out of the barn or the doors are closed. And then anything that we do after the pregnancy starts, it becomes kind of too little too late. And the developmental origin of adult disease, we know about that, has its origins in maternal health, be it nutrition, chronic disease, infection, smoking, mental health. And pregnancy is a window to future chronic disease, which I already mentioned. And just to give a corollary to that, women who enter the pregnancy healthy and who have a healthy pregnancy without any of those things like a PIH or a GDM or a preterm delivery or a low birth weight baby or multiple miscarriages, usually do not go on to developing diabetes or heart disease or cancer in the future. So that's also an important thing to keep in mind. So just to give you the evidence for those kind of things, interventions during pregnancy have not yielded big change in outcomes. And we also know about the Barker hypothesis and the developmental origin of health and disease. Here, I just want to add, even mental stress now is considered as a teratogen, that actually when the mother is stressed during pregnancy or preconception, she can go on to deliver a low birth weight baby or have preterm delivery, all of which sets up for future NCDs. So as you can see how pregnancy is becoming this low-hanging fruit, and very important concept I want to show how this whole pregnancy is a window to future chronic disease, not only just the one event. When you superimpose one on top of the other, the effect becomes additive. For example, a woman has gestational hypertension, also gives birth to a low birth weight baby, her chances of developing cardiovascular disease in the future are actually multiplied. The same thing happens for the other risk factors as well. And then the mother's birth weight increases her chances of future GDM, meaning if she's born a small baby, that girl goes on to developing GDM and obviously higher risk for later type 2 diabetes. Now, all of these things are good, but if we do preconception care, is the outcome improved? And the answer to that is a clear yes, is that if you put in these recommended changes that I'm going to talk about, the outcomes are better. And just want to show you this very nice slide where if the woman is overweight or obese, or she's not eating the 5-a-day fruit and vegetables or drinking alcohol, smoking, when you make the changes, some of them you have to make well ahead of time. Some things you can make, just a few months before starting the pregnancy. You can see what the outcome is much, much better. Now, coming to this last part, which is, how do we do it? This is from FIGO, Prevention of Non-Communicable Diseases by Intervention in the Preconception Period. This is a fantastic paper that I would encourage everyone to look at from 2020. So first, preconception care should be delivered in any clinical or hospital setting, regardless of the initial reason for a hospital visit, at either an inpatient or outpatient level. Hospital-based and community or home-based opportunistic preconception care is recommended. The woman may have come for something else. Use that as an opportunity to do preconception care. This includes visits for contraception, immunization, or child health service. And a universal approach to discussing good nutritional habit, risk of obesity, possible benefits of weight loss before pregnancy at every visit. So every visit, we should do the discussion. And then there are lots of missed opportunities. For example, failure to offer systematic advice and support regarding women's nutrition, weight, related lifestyle behaviors in their childbearing years is a missed opportunity for preventing the intergenerational cycles of obesity and non-communicable diseases. As there is poor public understanding of the need for pregnancy planning and preparation, each contact is an opportunity to engage women in the reproductive years about their health and understanding. I'm really looking forward to listening to Faria because this whole contraception is so important, especially to women with diabetes, so that they can, get the time needed to put in all the preconception things in place. This is a wonderful slide I wanted to show. This is called congenital heart disease. If you look at this slide, they talk about teenagers with congenital heart disease. That is the time. Timely counseling on contraception and pregnancy risks by the pediatric physician. Don't wait for adulthood as sexual activity may precede this. Very important point. And we know that in our parts of the world, women get married at a very young age, even in their teenage years. And of course, pre-pregnancy counseling provide multidisciplinary preconceptional advice. So if you look at this big picture, ideally preconceptional, no and or first trimester postnatal, it's and first trimester and postnatal visits. So very, very important that in the preconception, if you look at correcting anemia, checking for blood pressure, correcting that, making sure they're on the right medications, providing the right contraception, checking for diabetes, making sure there is adequate nutritional intake, folic acid, looking into mental stress. Because if they have mental stress, they're not going to have good antenatal care and not have good nutrition. So very important. And also I cannot stress the importance of testing for GDM in the first booking itself. And lastly, we must remember that postpartum care is actually preconception care for the next pregnancy. So this is a very important window that we are not looking at because this is what happens to women. With each pregnancy, there's gestational weight gain, which leads to fat mass, increased risk of GDM in the next pregnancy. And you see what GDM does, a tremendously increased risk, 10 to 11 times increased risk of type 2 diabetes in the future. So training of healthcare professionals, training, which is exactly what this kind of program is doing. Healthy conversation skills have to be done for our frontline health workers as well, general practitioners, pediatricians, and others. And nutrition, we cannot, stress the importance of nutrition. So here I would like to say that the FIGO nutrition checklist is a good way to start conversations. And Divas is launching soon an app called Be Ready, which is actually a preconception care program. And it's not just for pregnancy. Any preconception care actually makes women healthy, puts them on a healthy trajectory for life. Thank you so much.
Thank you, ma'am. I think you highlighted a very, very important concept of the preconception care and very aptly termed as a low-hanging fruit. I think this is something which is neglected and can be done easily if some attention is paid. Ma'am, we will have question and answers at the end of all the 4 talks. And now I will request to display the introductory slide of Dr. Faria. Dr. Faria is from Bangladesh. And she's again going to talk on a very, very important topic, that is the contraceptive choices and the recommendation for women in diabetes. Dr. Faria is an endocrinologist based in Bangladesh, and she's associate professor in Department of Endocrinology at BIRDM General Hospital, and she's also the vice president of the Bangladesh Endocrine Society. So welcome, Dr. Faria, and I will request you to please go ahead with your presentation.
Thank you, sir, for your kind introduction. And it is a great pleasure for me to be here as a speaker in this session. And I again welcome all the audience to my talk. And today my topic is contraceptive choices recommendations for women with diabetes. And in my today's talk, I like to highlight few points regarding the different methods available for women with diabetes, metabolic and general effects of some contraceptives, and how to choose the most suitable contraceptive and when to start the contraceptive care. And as we all know that there is a rise in global diabetes prevalence, and also there is a rise in the number of diabetic women of reproductive age, and reproductive health and contraception need careful consideration. And as we hear from Professor Usha Siram ma'am, that the contraception is an essential part of the preconception care also. So pre-pregnancy care is very much important, and unintended pregnancy with poor glycemic control at the time of conception increases the poor pregnancy outcome in the form of stillbirth, congenital malformations, and many others. So safe, effective contraception is the most important thing to minimize these complications. And adequate inter-pregnancy spacing and healthy mother and baby is also very much dependent on this proper pre-pregnancy care and proper contraception use. So the most important thing is empowering the woman to choose the right contraception, which actually helps a woman to increase their decision-making power and autonomy, enables to plan the professional development more efficiently, and helps to improve the balance between private and work life. But there are some barriers which prevents women to reach to the proper type of contraception, the cultural barriers, some myths, misconceptions, and stigmas that negatively impact the access to contraception. And that leads to unplanned pregnancies and many more bad pregnancy outcomes. So many things should be considered while choosing a method of contraception, considering age, type of diabetes, cardiovascular risk factor presence, some gynecological situations, some psychosocial context, and risk of sexually transmitted disease, and women's particular individualized idea for contraception. So the first part of my talk, the available contraceptive methods. And we have in most of the countries in this Southeast Asian region, there may be are available combination oral contraceptive pill, progesterone only pill, contraceptive patch, barrier method of contraception, contraceptive injectable contraceptive, implantable contraceptive, intrauterine devices, and hormone releasing system, also some natural method, sterilization, and emergency contraceptive should also be considered in this list. Now, one by one, the combined oral contraceptive, there are several generations it had passed, and finally the contraceptive used in the oral combination form is the lowest dose of estrogen and a progesterone. And the progesterone is also changed from its different variation from levonorgestrel to drospirenone and dilogest. And these are the most effective progesterones with very low side effects and the lowest dose of ethylene estradiol. And another thing that is changed from synthetic to the natural estrogen, that is had a better safety profile. And these are the very advantageous because they are very less side effects and less painful. There is no chance of menorrhagia or heavy periods. And disadvantage, there is increased chance of thromboembolism or vascular events, and missed doses are very much common, and contraceptive failure is common in these options if not properly followed. And in some cases, it is contraindicated if there is hypertriglyceridemia or any form of dyslipidemia, hypertension, nephropathy, proliferative retinopathy, and maculopathy, or the woman having diabetes duration more than 20 years. The progesterone-only contraception, it modifies the cervical mucosa and inhibits the implantation, and also in some form prevents the ovulation. It is available in two forms, oral and intrauterine devices, and the oral form is in the form of pill, and it is better than the combination pill because it prevents the penetration of the sperm to the making the mucus of the cervix thick, and it can be used easily in the breastfeeding lactating period and in aged women who have more than 35 years of age. And there is a less risk of thromboembolism and other effects than that of the combination pill. But there may be chance of irregular menstruation with this. And the progesterone-only intrauterine devices are very convenient because there is no requirement of the daily taking of the pills, and so there is less chance of missing of the pills. And disadvantages may be similar to the progesterone-only pill, and there is a maybe some period of, there is a very less chance of entry of this drug to the bloodstream. So there is a less chance of side effects. The contraceptive patches are easy to administer, and it's estrogen and progesterone hormones are combined here. And essentially, same type of contraception is given by it. And advantages, effective and easy to use, no day-to-day variation in the taking, and disadvantage because sometimes it is not very good option for women more than 35 years age or overweight women. An alternate method should be given for them. And the injectable contraceptives, progesterone only and slowly releases in the body and prevents the ovulation. And actually 8 to 12 weeks interval, the injection to be taken, and it is very effective. But the disadvantage, there may be a chance of irregular menstruation or heavy flow, or sometimes in the long period of amenorrhea. And another thing is the normal fertility after stopping this injectable contraceptive may vary from woman to woman, and it may take some time and not easily so much reversible within short period of time as that of the oral contraceptives. Emergency contraception, very much important for this diabetic woman, because various forms of emergency may happen, and this in the diabetic perspective, there is no contraindication of this taking this progesterone only contraceptive within 72 hours of the unprotected intercourse. And sometimes the copper elucidating the slow releasing IUDs, intrauterine devices, within 5 days of the unprotected intercourse, sometimes helpful in the emergency contraception also. And the contraceptive implants, it actually is implanted by local anesthesia, and for 3 years it is safe for any woman who wants the long-term contraception. Actually, the woman's having the family complete and no need of further planning of pregnancy is very good option for them. But amenorrhea and irregular menstruation sometimes a complaint, but which actually reverses and becomes normal throughout the period of time. So long-acting reversible contraception are good choices for a woman with diabetes, and they are in the form of injectable, the intrauterine devices, and the hormonal coils. And it is 20 times as effective in preventing pregnancy than the pill and the barrier methods. So in next part, the metabolic part and the effects of contraceptives. The estrogen may cause the increased production of triglyceride and HDL, leading to increased VLDL production. So there is an increased chance of dyslipidemia and atherogenicity in the estrogen users. And in the progesterone, there is also increase in triglyceride, and it also increases a little bit of insulin resistance. So there is a far less pronounced with the lower dose of modern preparations and formulations. And combined oral contraceptive will have minor or no effects on BMI, HOMA, insulin resistance, and glycemia. And the newer Dynogest and Cipeterone have most favorable metabolic profile than that of the levonorgestrone. And the last part is the how to choose the most suitable contraceptive for a woman. Which one to choose? We have so many options in our hand, and women with diabetes can choose the full range of options. And the injectable or patch are the best contraceptive, and other alternatives also. And the women who are 40 years of age or above have long-standing diabetes for more than 20 years, have combined OCP is generally not advised. And most suitable option may be progesterone-only contraception or intrauterine devices. For multiparous women with type 1 diabetes, intrauterine devices are the solution. And for the nulliparous woman, the combined oral contraception is the method of choice. And this is the WHO medical eligibility criteria for contraceptive use. While considering one method, we can categorize the contraceptive in this method. That method which can be used in any circumstances are categorized as 1. The generally used method are categorized as 2. And the method not usually recommended unless other are not eligible, that is 3. And the 4 is the category not to be used. Considering this category, all the formulations are categorized like this. The woman having history of gestational diabetes can be given any of the contraceptive, can be given the combined pill, the progesterone-only pill, the medroxyprogesterone acetate norethisterone pill, the implantable contraceptive, intrauterine devices, and the intrauterine systems. In the other types of diabetes, in the non-insulin dependent type 2 diabetic patients, anything can be used and can be used safely. But in patients having nephropathy, retinopathy, and neuropathy, and in that cases, the combined oral contraceptive pills are not a good option. And of course, for them, the intrauterine devices are the good options for them. So in summary, individualized and specialist contraceptive advice is very much important. One shoe does not fit for all, and every woman have the right to select their own contraceptive method as their feasibility. And contraceptive guidance need to be offered holistically, and a trusting relationship between the practitioners and the client is advocated. And women should be informed that all methods are available, including the long-acting reversible contraceptive method having higher efficacy. And as Madam was telling about the contraceptive care, actually they're part of the preconception care. It is important, very much important prior to pregnancy in women with diabetes, which can benefit the optimal pre-pregnancy weight gain, stabilize the glycemic control, ensure the safety of medication, and provide baseline levels for monitoring the renal and retinal functions. So it is necessary to make aware the fertility advice services available for both acute and primary care. That's all. Thank you all. Thanks for patience hearing.
Thank you, Dr. Faria. And this is one of the very, very important subject, the contraception in women with diabetes or history of diabetes or GDM. We will take the question and answers at the end of all the 4 talks. And now we have with us Dr. Manika from Sri Lanka. Welcome, Dr. Manika. I can also see Dr. Shahzada Salim joining here. Welcome, Dr. Salim.
Morning.
Let me just introduce Dr. Manika. Dr. Manika is a senior endocrinologist from Sri Lanka. He is working at National Hospital of Sri Lanka and is currently the president of Diabetes Association of Sri Lanka. He's also the past chair of Sri Lanka Diabetes Federation and the past vice president of Sri Lanka Medical Association. He has many accolades and awards to his credits and is involved in extensive research and writing. So welcome, Dr. Manika, and he is going to talk about diabetes and dementia. So over to you, Dr. Manika, please.
Thank you very much, Amit, for the kind words of introduction, and thank you very much for inviting me to speak today. And I'm trying to get the slides.
Are you able to share your screen?
No, that's what they say. Allow Zoom to share the screen. I always had a trouble in the morning also joining in. I got some help with the IT team. Is the IT team there? It says allow Zoom to...
Screen sharing is allowed, sir. You can share the screen by clicking on the green button.
I did it there. Then desk share. Allow Zoom to share your screen. Then it says open system preferences. Okay. So I think in your setting, Meg, can you help, please?
Sir, can you share your slides on WhatsApp to me? I'll share from my end.
WhatsApp. Okay, so until he gets it, I'll start the talk on because it's going to take time. How do I get it to? Can I email it quickly?
Yes, sir. You can mail it. Meg, write the email ID on the chat box. Meg? Hello?
Yes, sir.
Meg, just write the email ID on the chat box and Dr. Manika is sending the mail to you.
Yes, sure.
Meanwhile, Dr. Manika gets ready with his presentation.
Can we go with the other lecture, please? Can we do the 4th lecture and I'll join without wasting time? Is the other?
The 4th lecture is Dr. Sunil Gupta. I think he has not joined yet. He is insulin initiation titration.
What's your
meanwhile, we can have a couple of questions.
Yeah, take the questions, please. Yeah, I'm so sorry about.
No issue, sir. So, Dr. Faria, I would like to ask you, as you rightly pointed out, that many of the times we see in our clinical practice that as the pre-conception counseling is itself is a challenge. And in clinical practice, there is a tendency that the people don't go to the doctors for any kind of counseling, especially. and once only they come to know about the pregnancy, they'll end up. So the window of pre-conception care, as pointed out by the Dr. Usha Shriram, most of the time we always lose it. And so this is pre-conception counseling, and the contraception counseling is also happening in the pre-conception phase only. So how do you handle that problem, and what can be done to sensitize the population? Because we need to reach to the people that this is not simply pregnancy, this is pregnancy with diabetes. And it has implications not only on the current status of the health of the lady as well as the fetus, but also the future generation to come.
That is a very crucial issue, because not only the 3 months before the pregnancy, because at the time a woman of reproductive age diagnosed as a diabetes, I think that is the time from the very beginning start the preconception knowledge to be given, shared. In every visit, actually the woman having the reproductive age, as we are planning to follow up and carry the investigations in routine manner, in that case the education also regarding the preconception care and the contraceptive use, interpregnancy spacing, and the proper care of contraception, proper method for this particular patient should be educated to each and every woman in the reproductive age, especially from the period of 18 years to 35 years. Actually, almost yearly, there may be a knowledge sharing and the education protocol or the follow-up plan like this, that every woman of this age with diabetes should be educated at least once in a year about the whatever their family planning or marital status, but they should be educated each and every year, or if required, more frequently, and if possible.
So I think this is very important. You have highlighted that it is not just in the married women you have to take care. It is at every opportunity of counseling, right from the beginning, when the patient is in touch with you and you know that this patient can become pregnant in future. You have to sensitize the patient regarding the need of the contraception as well as the pre-conception care, as rightly pointed out by Dr. Usha Shriram also. Are you there, ma'am? Usha ma'am, are you there?
That is also help in knowledge sharing also, because many of the people may not visit the hospital regularly. But if one woman is educated in one locality, they may share their experiences or knowledge to other women also. That will also empower the other community in their rural areas or in like that.
And I think there is one more issue also, ma'am. What is happening is that the people who are actually treating diabetes, the diabetologists, physicians, endocrinologists, most of the time we are not that well versed about the contraception method, probably. And so most of the time it is left to the domain of the gynecology and the obstetrician that they will do the contraception part and they will advise regarding the counseling. So being an endocrinologist, I would just like to know that what though the choice is wide and it is up to the patient's own preferences, but particularly in patients with diabetes, you must be having your own experience that as per your own experience, which contraception method suits them the most, and in women already having diabetes.
Actually, oral contraceptive, the combination oral contraceptive actually is most widely used by most of the women. And sometimes they ask about the questions about the uncontrolled diabetes with these oral contraceptives. That is the issue they think about it. But according to me, there is chance of missed doses also. And the spotting and breakthrough bleeding and failure of the contraception is much more in the oral pills mostly. And in that case, for those women who are not so much educated about regularity of taking this, intrauterine devices are good options, but it cannot hamper the day-to-day oral pill taking and like this. Intrauterine devices, and it is reversible easily and movable at whatever the time. And in that case, the injectable and the patches are not so movable or reversible in every day. In that case, intrauterine devices are good option for them. And those who request the reversibility of contraception, in that case, oral pill is a good option.
Right. Also, ma'am, nowadays, many of our patients, they are on SGLT2 inhibitors also. And we know that sometimes there is a risk of genital infection. So particularly those patients who are using IUCDs and all, do you think there is a risk of some infection and we need to take some extra precaution in these patients who are on
Actually, maintenance of proper hygiene is very much important. and that is in our part of country, the genital infection and the UTI are much less common with the SGLT2 inhibitor than the Western population because of our different type of hygiene maintenance. So special extra education with this hygiene maintenance can help the patients with IUDs also.
Right. I think, Mayank, have you received the slide of Dr. Manika?
Still waiting for the slides.
Okay.
It's the slide deck is too big, so I'm trying to put it in mail. This thing, give me just a second. I'm so sorry about this. I can start my talk while he's processing. It's not getting good because the deck is small. So it says send in some other form, so that I'm doing that immediately. Okay. Let's try. I'm sending it now, Maya. Just fingers crossed, hopefully. So it says it's coming in mail drop. I can't send in the normal email because I have a lot of graphics there.
Okay. Meg, why sir is not able to share the screen? I think you have allowed everyone to share the screen.
We have allowed everyone to share the screen. I think sir is using Mac, so there is a problem with the
settings. So I will request Dr. Manika, you can proceed with the presentation, and meanwhile the Meg gets the slide.
I'll tell you, we have to get used to resource poor settings, all that. I can join with my phone and show the screen and talk. I mean, I don't want to waste the time. Shall we try that? I have done that once before.
Sir, you can do that. But if you have already sent, then the Mayank will put once the Mayank gets it.
Did he receive?
Is it showing sent, sir?
So it says...
Allow me 10 seconds. I have received. I'm just putting the slides.
Okay. He has received the slide. So you can start with setting the context.
Yes. First of all, my apologies. Although we get ready with subject matter, our technological, if something goes wrong, we really get panicky and this new technology, but it's okay. So let's proceed. So I will get the slides from him, right? Can you all see me?
Mayank, start sharing the slide if you have received. Yes. Mayank is sharing, sir.
Okay, thank you, sir. Thank you so much. So this is from the day-to-day very important topics that we discussed. This is a new topic which created a lot of interest at the recent IDF meeting. There was a whole symposium on it. I must say there is no strong evidence, RCT evidence at the moment, but as you see, as you go on, we could see that there is a lot of things that we should think about this diabetes and dementia. Next slide, please. As you know, now the world has crossed the 500 million mark, and Asia is going to be the next slide, hot bed of diabetes in the future, with nearly 152 million diabetics, and India and China will be on top. And we see an aging population in our countries as well. So when you look at diabetes and dementia, it's going to be a huge problem for the healthcare systems of our region. Next one. So dementia also, there are millions of people in the world, more than 55 million as of date, but they say nearly 10 million new cases are added every year. So, and it's a 7th leading cause of death, and it's expected to double in the next couple of decades. So it's going to be a huge problem even in our part of the world, although we may not be recognizing this problem in our patients. Next slide, please. As you can see, the pyramid the shape is changing, and there is a aging population in the world, and the same thing is happening in our region as well. Next, please. Okay, next. So it might change in another 20 years, the pyramid might be upside down. So and the diabetes is also increasing. So there'll be meeting of two pandemics where sort of dementia and diabetes might become a huge problem in the future. So it's better to be, cognizant about that and be ready. Next. So there is diabetes itself is an extra burden for the healthcare system and for the patient and the family. And dementia would be a double hit, I would say, which needs lots of medical care and really a stress on a burden on the part of the caregivers or the family, especially in our part of the world. Next. So this link has been studied even when we were, medical students or registrars. We have seen this, although not much significance was given in our meetings. So as far as 1997, there were these studies which showed some connection between type 2 diabetes and cognitive decline. Next. So this study showed that this was a very important study which showed that with diabetes and dementia, vascular dementia was more in diabetes. It was the hazard ratio was 2.2 as seen in the right-hand corner, and Alzheimer's disease was about 1.6, and overall dementia risk of about hazard ratio about 1.7. So you could see that there's a roughly 1.5 to 2 times increased risk of dementia in diabetic patients according to this analysis. Next. So this study showed that it's mostly the postprandial. Interestingly, postprandial sugars showed a higher correlation with the development of dementia, a higher hazard ratio compared to the fasting blood sugars. We need to study this phenomenon more to see why. Next. So brief outline of what I'm going to do in the interest of time and because it's delay. Next slide, please. We'll go to the topics straight away. From a neurological perspective, I'm going to go through this quickly. Next slide, please. You know, there are staging like the drop in EGFR. There is a preclinical stage, then impairment in the cognitive function, and the proper dementia, what we call is cognitive impairment, which is severe enough to interfere with everyday abilities or activities of daily living, which has several grades, and the decline is faster in diabetes. Like we say for the drop in EGFR, similar pattern is shown with the cognitive decline and diabetes over the years. Next slide, please. General types of dementia, Alzheimer's is the majority that we see, vascular dementia next. But in diabetics, you saw the vascular dementia would be understandably more than Alzheimer's, but those two can, overlap. Plus, majority of the diabetics will have these two types of dementia, vascular being more. Next slide. So I'm not going to go through the pathophysiology, which is, hypothesis, many cholinergic hypotheses, oxidative stress hypotheses, then tau protein hyperphosphorylation, and, different hypotheses. But basically what happens is there is collection of amyloid extracellularly, which causes plaques, and beta amyloid mainly, and this theory about hyperphosphorylation of tau protein and breakdown of that and causing neurofibrillary tangles intracellular, which causes all the changes, cognitive decline, and the pathophysiology so far understood in a very, very simple terms for Alzheimer's disease. Next slide, please. And if you go through, I'm not going to go through, this is straight from up to date. And you could see there are many markers with the CSF. Then the PET scanning with amyloid trace uptake could be diagnosis. Then structural MRI, which shows medial temporal lobe atrophy, which is, can be taken as a marker of biomarkers or other structural markers for diagnosis of Alzheimer's disease. Next. So this is what I said before. Next one, please. So these are some images to show how different stages in the brain, which shows cerebral atrophy developing over time. Next one, please. This graph shows the circled area. The medial temporal lobe atrophy is a characteristic feature associated with Alzheimer's disease. So if you happen to do a scan in your patients, you could look out for these changes happening in your diabetic patients. Maybe they did the scan for a different reason. Next slide, please. As you know, there is a genetic association in Alzheimer's, but it's only about 5%, the ApoE4 gene association. And in diabetes, the effect of gene is augmented. That's what the literature says. And then, as shown before, in those people, the risk of dementia and the progression can be faster. Next slide, please. I'm not going to go through again all these things, but all of you know the increased vascular risk. Our diabetic patients are vasculopaths, so they'll have cerebral microinfarcts, infarcts, neuronal synapse loss, cerebral atrophy. All these things could happen due to atherosclerosis, microvascular disease, reduced cerebral blood flow, and so many factors as given in this, which could lead to increased cognitive impairment and dementia. Next slide, please. And the changes in the diabetic brain, you all know, there can be cerebral brain atrophy, small vessel disease, which was explained before. I have shown in a pictorial manner the changes that can be seen on MRI scans of our patients, may be done for other reasons. Next slide, please. So this is an interesting connection. 3 Ds, diabetes, depression, and dementia. Next slide, please. So there is a bidirectional relationship between depression and diabetes. 60% of people with depression have a very high risk of developing diabetes, 60% higher risk due to many reasons. And people with diabetes also have a 25% higher risk of developing depression. Diabetes distress, you could call it. I think we have discussed in many fora this topic as well. And there is in patients having depression and diabetes, 2-fold higher risk of dementia developing compared to a diabetic without depression. So the studies are showing a clear connection so far, observational studies. Okay, next slide, please. Diabetes, dementia, and hypoglycemia. As you know, recurrent hypoglycemia, we know that can cause problems in the brain, like infarcts and cerebral atrophy. And whether there is a connection between dementia, we'll see in the next slide. Next, please. It's controversial. Let's go to the data. Next slide, please. So these 2 studies, next one, actually showed that there is a connection. Even earlier studies, a large 27-year-old follow-up study also showed that there is a slightly increased risk of dementia associated with long-standing diabetes. But more recent studies, next one, like the Accord Mind study, and the next one, please, and the DCCT EDIC study in type 1 diabetics, followed up over a period of 18 years, did not show any evidence that there is increased dementia associated with recurrent hypoglycemia. So it's controversial. We need more evidence, but we have to keep that in our mind. Next slide, please. So assessment of cognitive decline. So this is not a neurology lecture, but I'm going to go through that just to refresh your mind, brush up your knowledge. Next slide, please. Could be the ADA has recommended these mini-mental state examination is what we are used to. I think it's used in India as well, but there are other methods to measure, which is sort of approved by the American Diabetes Association. Next slide, please. But as clinicians, we should take a good history to make sure that patient is not depressed or not on any other medication which causes a similar picture, or full neurological examination to rule out other obvious neurological diseases. A TSH. Sometimes we might miss, hypothyroid patients might have a cognitive decline with poorly controlled diabetes. Then neuroimaging, as mentioned before, and the specialized investigation, the CSF studies and imaging can be done to diagnose dementia or Alzheimer's disease, which is beyond the scope of this talk, but just to allude, brush up your knowledge. Next slide, please. So now let's look at some of the evidence to say the link between diabetes and dementia, how strong it is. I have given the pathophysiological background and the associations, and the trend towards, or the link is being showed, but let's look at some meta-analysis people have done. Next slide, please. Before that, the changes attributed to type 2 diabetes, again the pathophysiology, there could be metabolic changes in impaired insulin signaling or decreased insulin action, basically, which impairs the beta amyloid clearance from the cells and impaired tau phosphorylation, which we discussed before. As you know, diabetes is a pro-inflammatory stage. There is reactive oxygen species, oxidative stress, and many other changes happening. And the morphological changes of the, next slide, please. Yes, go on. And the morphological changes of the brain in elderly subjects with diabetes mellitus. Next slide, please. You have shown that with increasing duration of diabetes and poor control, there is hippocampal atrophy. So these things could contribute to the pathophysiological changes in dementia and Alzheimer's as well. Next slide, please. Then there is increased neuritic plaques with rising fasting blood sugars. So these are very interesting things. Earlier it showed that the hazard ratio was more with postprandial for Alzheimer's, but in dementia, this particular study shows that it's associated with neuritic plaques, increased plaques with higher fasting plasma insulin levels and the 2-hour postprandial. So there is something, a good relation, but we don't know exactly what's happening. Next slide. Next one. So, ladies and gentlemen, there is crosstalk between Alzheimer's disease and type 2 diabetes. There is some shared pathophysiology, but it's not exactly matching in all areas. The things postulated contributing to the dementia could be the increasing insulin resistance and the hyperinsulinemia, hyperglycemia, what you call glucotoxicity, the inflammatory state, so many factors given in the next few slides, which you can see, but I'm not going to explain all these factors one by one in the interest of time. And there's synaptic dysfunction, and there is malfunction of what they call as autophagy malfunction and neurodegeneration due to many factors in diabetes, which could contribute to the Alzheimer's plus other types of dementia. Next slide, please. It's a complex slide, but it's very simple. Insulin acts as a key which facilitates the entry of glucose simply from the plasma to the fatty tissue, liver, and also to the brain. So when there is impaired insulin action, whatever the reason, increased insulin resistance, the glucose is not entering the brain cells properly, and there is accumulation of beta amyloid and neurodegeneration due to the resultant lack of glucose for the functioning of the neuronal cells. So this is the theory behind insulin resistance and increasing the risk of dementia and the pathophysiology, augmenting the pathophysiology of Alzheimer's disease. Next slide, please. Then it's a complex area. I confess that I would not know all these factors in detail, but it's very interesting. Look at this IDE, insulin degrading enzyme. This is, which is the gene, related to that enzyme is associated with Alzheimer's disease. It's found, which I show in the next slide. But there is, due to this lack of insulin action, there is, collection of amyloid and tau aggregates in the cells, as seen in this diagram, through the MAPK pathway and dysfunction of many post-receptor mechanisms happening in the cells. Next slide, please. So this malfunction of autophagy, they say that insulin resistance and Alzheimer's have a similar action through the presenilin 1 and presenilin 2 receptors or the genes, and then this secreted amyloid and tau aggregates are stays inside the cells, which causes all the problems associated with Alzheimer's disease. Next slide, please. Similar thing, it's the same thing that they are showing, the tau proteins, how they accumulate, and hyperphosphorylation, which causes this neurofibrillary tangles inside the neuronal cells. Next slide, please. So, ladies and gentlemen, these genetic factors is well recognized ApoE4 allele, and this HHEX, this is something new which I saw when I was reading for this topic, and which codes for the insulin degrading enzyme. And there is association, and that clearly we showed where it really acts in the pathophysiological pathway as well. So there's something happening. There is a link which we don't know properly. We haven't got the details yet, but we can look out for these new papers coming out on these genes associated with type 2 diabetes. Next, please. So is it type 3 diabetes? So if there is that gene defect, HHA, insulin degrading enzyme gene defect associated with diabetes and dementia, can we call this type 3 diabetes? Is for the future to decide with more robust evidence. Next slide, please. But at the moment, there is contrast, conflicting evidence. Still, we need more studies to confidently say that there is a clear association, and it's a strong association. Next one, please. Then comes the anti-diabetic therapies and Alzheimer's disease. So there are studies going on studying intranasal insulin therapy, GLP-1 receptor liraglutide, metformin, and pioglitazone being tried in patients with Alzheimer's disease. Next slide, please. So again, the pathophysiology they are postulating. I will skip this slide. We have discussed this many times. Next slide, please. So many GLP receptor agonists, once weekly preparations, complex pathways. But what they say is there is multiple mechanisms reducing basically inflammation, diminishing the tau protein phosphorylation, improving the synaptic function, and influence on insulin resistance is the postulated theory that how GLP-1 receptor agonists would help in dementia, especially Alzheimer's disease. There are only smaller studies. I'll show you the number of patients in those studies. Next slide, please. So these are all 38, 26, maximum 240 patients for intranasal insulin. So it's too early. I wouldn't jump into a conclusion, but there is showing some significant, in these studies, shorter duration, 26 weeks, and less than a year, even that you could see by different methods that there is a trend towards improving the memory or the decline in memory in these elderly diabetic patients. Please look out for newer studies with larger patient pools coming, being published. Next slide, please. Okay, next one. So this study also published in the Lancet, 2-3 years back, showed that with dulaglutide, long-term treatment might reduce the cognitive impairment of people with type 2 diabetes. These are all, still too early to be taken as hard evidence. Next, please. Just to allude you to the evidence. So metformin and pioglitazone has a, slightly more data, and they show, trend towards improving the cognition and even reducing the dementia risk. The studies are going on, especially for metformin. Next slide, please. Next one. So the as you know, metformin acts through the activation of the AMPK pathway, and you saw that in the pathophysiological slide that I showed, that AMPK pathway plays a major role in the propagation of dementia. In the interest of time, please, because I have been slowed down, please go through the next slide. So this is also similar evidence for pioglitazone, DPP-4, and sulfonylureas. There is not much evidence. Next slide, please. I'm going to quickly go through. So the ARBs and statins and aspirin, it is shown mainly reduces the, as you know, vascular dementia. Aspirin, please note the dose, 40 milligrams. Above 40, there is no risk reduction. Actually, it increases the risk due to many reasons. Next slide, please. So they reduce mainly the vascular dementia. And what is it important to us? We should think about good glycemic control, avoiding hypoglycemia, and then modification of the risk factors as shown before, which we have to think about dementia in our diabetes patients, especially the elderly patients, and screen for diabetes in suspected, screen for dementia using whatever the score, using the methods, mini-mental score or other methods shown, would be a good practice in future to recognize these people and take remedial measures. Next slide, please. I'm going to conclude. So I think this, our guideline gives a good idea where to choose elderly people, not to have very low sugars, and choose your correct HbA1c and the values for your patients. Next slide, please. So in summary, ladies and gentlemen, I think this is a new area with lack of RCT evidence, but I just wanted to open your eyes to the connection between these two and little evidence that is there, which might direct us in future to open our eyes and keep our eyes open to look out for dementia in our diabetic patients. Thank you very much. I do apologize for the delay and the the disconnected slides, but thank you very much.
I really appreciate Dr. Manika. Despite all the technical glitches, you were not only able to sail us through in time, but also your presentation was very insightful and had shown us a lot of data. And we can quickly have one question with you as we will be handing over the session to the next set of speakers and chairperson. So Dr. Manika, as you pointed out, that the link between diabetes and dementia is not that very clear. So for a general clinician, so what is the take-home message or the 2-3 crisp points which you would like to convey to the general practitioner who would be interested in knowing that?
Yeah, first of all, I would say that meta-analysis which I showed earlier showed clearly that there's a hazard ratio of 2.2% of vascular dementia in type 2 diabetes. And the Alzheimer's disease, it was 1.6. The hazard ratio. So we know clearly that your patients are at increased risk. What we don't know is the correct pathophysiology and the connection, which factor is causing. And we know with that genetic association in Alzheimer's, that insulin degrading enzyme. So lack of insulin action is a key cause for this. So people with increased insulin resistance, look out. It's being what the mind doesn't know, the eyes don't see. Or, if you don't test, you won't find. So it would be a good practice in future for our elderly diabetic patients to get your colleague or a clinic person to do at least a mini-mental score, because these things are unrecognized. So think dementia and take remedial measures. So hopefully in future we'll get methods, medicine, of course, optimizing the control and reducing the vascular risk factors would also reduce the dementia risk. So I would say just keep an eye open and test for dementia with the mini-mental score or whatever the method you are doing in high-risk people.
Thank you, Dr. Manika. We already had the opportunity to ask a few questions to Dr. Faria. I would have loved to ask questions to Dr. Usha Shriram, but I think she is not there. I would like to thank both the speakers, Dr. Usha Shriram, Dr. Manika, Dr. Faria, for your valuable contribution to the IDF Southeast Asia regional meeting and bringing the best of the IDF Lisbon. Again, refreshing our memories. I had the opportunity to be there in person and meeting all of you there. And again, it was really a privilege to listen to you again. So I can see Dr. Dulani there. If Dr. Dulani is there, then I would like to hand over the session to Dr. Dulani and Dr. Vishal. Dr. Vishal, are you there? Yes.
Yes, sir, I'm here.
Yes. So, Vishal, we have concluded this session, and now you can take over and introduce Dr. Dulani, and Dr. Dulani can further proceed with the session. Thank you, everyone. Stay tuned for the next session.
Thank you.
Thank you.
Unmute, Vishal. Yes, you proceed, Vishal.
So the next session would be by Dr. Dulani Otachi. She is from consultant endocrinologist and senior lecturer. And so the next session, this would be by Dr. Dulani ma'am or Aishat ma'am?
Yeah, Dr. Dulani and Dr. Aishat, they are chairing this session. Okay. And we have the next speaker already with us, and we have the recorded talk of Dr. Siddharthan. Dr. Siddharthan is available with us for any question and answer, so we can take the question and answers. Right. So, Dr. Dulani, you can introduce our next speaker, please.
Welcome, everyone. I would like to next invite Dr. Siddharthan Soigondo. He's talking to us from Indonesia. He's a director, Indonesian Diabetes Institute, Diabetes Care Jakarta, and he's a chairman of the Diabetes Connection and Care, Ika Hospital in Indonesia. Over to you, Dr. Siddharth. I think it's a recorded lecture, so we listen to it and then take questions afterwards.
Mayank, play the video lecture, please.
First of all, I would like to thank the organizers, especially Professor Asad Khan and Dr. Bansi Sabu, for inviting me to be part of this very important meeting. My topic today will be about managing diabetes with dyslipidemia in the Southeast Asia region after the IDF Lisbon meeting 2022. During and after the IDF meeting in Lisbon, I tried to look for the topic which I think is important and interesting to follow: diabetes and dyslipidemia. Why? Because diabetic dyslipidemia and its management was not talked specifically about during the IDF Lisbon meeting. Indirectly, it was mentioned during the Diabetes Therapeutic Global View while talking about the ADA-ESD algorithm, adapting it to the world. Presently, lipid treatment goals are changing rapidly because of many new findings in lipid metabolism, atherosclerosis, and new drugs or medications are invented and already in the market. Why is it important? Because the risk profile of Asian diabetic patients, type 2 diabetes develops at lower BMI in Asians compared with Caucasians. At any given BMI, Asians have greater amount of body fat and tendency to visceral adiposity, the metabolically obese phenotype, that contributes to increased fatty acid influx to the liver, altered adipokine production, fatty liver, and hepatic insulin resistance. A possible reason underlying the inter-ethnic difference in BMI and risk of diabetes. Higher insulin resistance, greater contribution of insulin resistance to diabetes pathogenesis compared to Western population, like associated with a tendency toward greater abdominal obesity, less muscle mass, and increased visceral adiposity in Asians. Reduced insulin secretion versus Europeans. This appears to be a predisposition to impaired insulin secretion among Asians. Type 2 diabetes develops at younger age in Asia. Early beta cell dysfunction due to the increasing prevalence of obesity, genetic and or epigenetic factors, in combination with socioeconomic factors. Higher rate of diabetes complications, for instance, kidney dysfunction, end-stage renal disease, and retinopathy, likely related to increasingly young age of diabetes onset in Asians, longer disease duration, and greater tendency to beta cell failure. Genetic susceptibility, several type 2 diabetes risks occur in higher frequency in Asians. Taken together in some Asian population, inadequate beta cell response to increasing insulin resistance results in loss of glycemic control and increased risk of diabetes, even with a relatively little weight gain. If you see here, the comparison of cardiovascular risk factors which are more prevalent in diabetics than in non-diabetics. You see here, for type 2 diabetes, more hypertriglyceridemia, lower HDL, small LDL, increased ApoB, hypertension, hyperinsulinemia and insulin resistance, hyperinsulinism and insulin resistance, central obesity, family history of atherosclerosis, and tobacco use. According to the IDF Diabetes Atlas, the 9th edition, 2019, the Association of Diabetes and Cardiovascular Disease, you see here the prevalence of cardiovascular diseases, coronary heart disease, ischemic heart disease, hemorrhagic stroke, and cardiovascular disease death, and years of life lost. You see here the percentage are all increased. Yeah, and if we see this, what's the STANO-2 study, which is a multifactorial therapy in type 2 diabetes to achieve blood pressure less than 120/80, A1C less than 6.5%, and total cholesterol less than 175 milligram per deciliter. Most of the CV benefits in diabetes was attributable to the use of lipid-lowering therapy. Lipid-lowering therapy accounted for more than 70% of CV risk reduction in diabetes. In the 2018 ACC/HA guideline on the management of blood cholesterol executive summary, 3 major risk categories are patients with severe hypercholesterolemia, LDL cholesterol levels more than 180 milligram per deciliter, adults with diabetes, and adults 40 to 70 years of age. Patients with severe hypercholesterolemia and adults 40 to 75 years of age with diabetes are candidates for immediate statin therapy without further risk assessment. Adults with diabetes should start with a moderately intensity statin. And as they accrue multiple risk factors, a high intensity statin may be indicated. In other adults 40 to 75 years of age, 10 years ACVD risk should guide therapeutic consideration. The higher the estimated ACVD risk, the more likely the patient is to benefit from evidence-based statin therapy. The risk discussion should also consider several risk enhancers that can be used to favor initiation or intensification of statin therapy. In the 2019 ESG-EAS guidelines for the management of dyslipidemia, lipid modification to reduce cardiovascular risk, the treatment goals for LDL cholesterol across categories of total cardiovascular disease risk. The risk stratification for diabetes patients are moderate risk, high risk, and very high risk, where moderate risk is for type 2 diabetes less than 40 years, type 1 diabetes less than 35 years, no risk factors, and the target LDL is 100 milligram per deciliter. What about the high risk? With diabetes without target organ damage, diabetes more than 10 years, or other risk factors, and the target is LDL cholesterol 70 milligram per deciliter. While very high risk is with diabetes with target organ damage, more than 3 risk factors, and the target of LDL cholesterol will be 55 milligram per deciliter. Based on this ASG 2019 cardiovascular risk categories and recommendations for management of dyslipidemia, you see here very high risk patients with diabetes and established cardiovascular disease or other target organ damage such as proteinuria, renal impairment, EGFR more than 30, 3 or more major risk factors, age, hypertension, dyslipidemia, and smoking or obesity, or early onset of type 1 diabetes of long duration more than 20 years. The high risk diabetes duration more than 10 years without target organ damage, plus any other additional risk factors. While the moderate risk is for young patients with type 1 diabetes less than 35 years, type 2 diabetes less than 50 years, with a duration of diabetes less than 10 years without other risk factors. The 2019 ACC guideline on the primary prevention of cardiovascular disease, the primary prevention group assess ACVD risk in each age group, emphasize adherence to healthy lifestyle. See here? Yeah, diabetes mellitus at the age of 40 to 75 years use moderate intensity therapy, while diabetes mellitus and age 40 to 70 years risk assessment should be done to consider high intensity statin while observing the ASCVD risk enhancers. For instance, if you see on this slide, if there is a primary the patient with diabetes mellitus age 40 to 75 years use moderate intensity therapy, but with the one who 40 to 75 year risk assessment to consider high intensity statin. The high intensity statin will be used when you see here with a long duration of diabetes more than 10 years for type 2 diabetes or 20 years for type 1 diabetes, albuminuria, EGFR less than 30, retinopathy, neuropathy, and anti-brachial index less than 0.9. What about the ACC-HA 2019, especially about diabetes mellitus? The recommendation for patients with type 2 diabetes in adults 40 to 75 years of age with diabetes, regardless of estimated year ACVD risk, moderately intensity therapy, statin therapy is indicated. In adults 40 to 75 years with diabetes and an LDL cholesterol level of 70 to 189, it is reasonable to assess the 10-year risk of first ACVD event by using the race and sex-specific cohort to help certify the ACVD risk. In adults with diabetes who have multiple risk factors, ACD risk factors, it is reasonable to prescribe high-intensity statin therapy with the aim to reduce levels by 50% or more. And adults older than 75 years of age with diabetes who are already on statin therapy, it's reasonable to continue statin therapy. And adults with diabetes and 10 years ACVD risk of 10% or higher, it may be reasonable to add ezetimibe to maximally tolerated statin therapy to reduce LDL levels by 50% or more. This slide shows the American College of Endocrinology algorithm, where ICVD risk categories and treatment goals 2020. They have a different classification, risk category. They start with extreme risk, very high risk, moderate risk, and low risk. And the extreme risk, if you see here, for diabetes, established clinical cardiovascular disease in individuals with diabetes, then the target will be LDL cholesterol less than 55, non-HDL less than 80, ApoB less than 70, then TG and TG less than 150. And for the very high risk, diabetes with one or more risk factors, LDL cholesterol less than 70, and for the high risk is if you have two risk factors and 10 years risk of 10% or 20%, or diabetes or CKD stage more than 3 with no other risk factors, then target will be less than 100. This is American College of Endocrinology guidelines. And if you define the latest modification for high-intensity therapy, statin therapy, moderate-intensity therapy, ezetimibe, PCSK9 inhibitor, cholecycline, and bempedoic acid, these are the latest medication. And here you see the high intensity is only atorvastatin and rosuvastatin. The Endocrine Society, American Association of Clinical Endocrinology Clinical Practice Guideline, developed a Diabetes Mellitus Comprehensive Care Plan 2022. Antihyperglycemic therapy for persons with type 2 diabetes and atherosclerotic cardiovascular disease, a very high risk for ICVD, heart failure, cerebral vascular disease, and chronic disease. You see all persons with type 2 diabetes control the cardiovascular risk factors. And of course, the treatment, you can use their SGLT1 receptor agonist, SGLT2 inhibitors, and so on. But there is a separate guideline or algorithm, a decision tree for hypercholesterolemia with very high risk, 10 years risk of 10 to 20%, includes type 2 diabetes with more than 2 additional risk factors, or extreme high risk, 10 years risk of more than 20%, includes established ACVD or target organ damage, begin with high intensity statin. There's very high risk and extreme high risk, you start with high intensity statin, as mentioned before. High risk is 10 years risk, less than 10%, includes type 2 diabetes with less than 2 additional risk factors, and no target organ damage, begin with moderate intensity therapy. The latest ASG guidelines on cardiovascular disease prevention in clinical practice 2024 use the same group factors, the green soup categories, 4 groups approach as the ACC. Apparently healthy persons, patients with established ICVD, patients with type 2 diabetes, and patients with specific risk factors such as CKD and family hypercholesterolemia. The 2021 guidelines, patients with type 2 diabetes with and without established ICVD or severe target organ damage. Step 1, LDL cholesterol is more than 50% reduction or target less than 70 mg per deciliter. But the step 2 is LDL cholesterol less than 55 mg per deciliter. This is a stepwise approach, and they use the categories following the 4 groups. Now, the definition of very high-risk patients, if you see here, the ASG type 2 diabetes according to the ESG, type 2 diabetes mellitus with target organ damage, there's microalbuminuria, retinopathy, or neuropathy, or at least 3 major risk factors, or early onset of type 1 diabetes of long duration, more than 20 years, while the ACC, HHA, major ACVD plus high risk condition, that is diabetes. Yeah? And Canadian guidelines, recent ACS, clinically evident ACVD, and any of the following, where diabetes mellitus or metabolic syndrome, if criteria almost the same approach as the American guidelines. The latest guidelines for the American Diabetes Association, the cardiovascular disease risk management, or the standard of care of diabetes 2023, there are 4 pillars: glycemic management, blood pressure management, lipid management, and agents with cardiovascular and kidney benefit, with lifestyle modification and diabetes education as the base of treatment of our patient with diabetes and cardiovascular disease. The lipid management for primary prevention, according to the ADA standard of care, you see here that for people with diabetes age 40 to 75 years without ACVD, use moderately intensity therapy in addition to lifestyle therapy. There's every diabetes patient with age 40 to 75 without atherosclerotic disease statin is already given at moderate intensity. For people with diabetes age 20 to 39 with additional ACVD risk factors, it may be reasonable to initiate statin therapy in addition to lifestyle therapy. But for people with diabetes 40 to 75 years at higher cardiovascular risk, including those with 1 or more ACVD risk factors, it is recommended to use high-intensity statin therapy to reduce LDL cholesterol by more than 50% of baseline and to target an LDL cholesterol goal of less than 70. While for people with diabetes 40 to 70 years at higher cardiovascular risk, especially those with multiple ACVD risk factors and an LDL cholesterol more than 70, it may be reasonable to add ezetimibe or a PCSK9 inhibitor to maximum tolerated statin therapy. In adults with diabetes age more than 70 years already on statin therapy, it is reasonable to continue statin treatment. For secondary prevention, if you have for people with all ages with diabetes and ACVD, atherosclerotic cardiovascular disease, high-intensity statin therapy should be added to lifestyle therapy. While for people with diabetes and ACVD, treatment with high-intensity statin therapy is recommended to target an LDL cholesterol reduction of more than 50% from baseline and LDL cholesterol of less than 55 mg per deciliter. Addition of ezetimibe or a PCSK9 inhibitor with proven benefit in this population is recommended. If this goal is not achieved on a maximum tolerated statin therapy. For individuals who do not tolerate the intended intensity, the maximum tolerated statin dose should be used. I'll try to an example of our guidelines. Sorry, this is an Indonesian example of Indonesian dyslipidemia guidelines in 2021. We try to choose 2 different pathways for different education for different groups. Yeah, if we try to use the ATP3 algorithm, where a person with diabetes and multiple risk factors of metabolic syndrome is considered as very high and LDL target less than 70 milligram per deciliter. Yeah, and the second type of pathway, the second choice is using the American Heart 2018 algorithm as reference, where a patient without ACVD is considered to use moderate intensity statin, but if there are several ACVD risks, then increase high intensity statin. Yeah, this depends which one we want to use. And actually, the Indonesian guideline is following the 2018 American guidelines. It's almost the same. And if we see for this data, free for Asian, burden of diabetes in South Asia is high. This is worsened by the fact that there are differences in Asian diabetes risk profile compared with Caucasians. International guidelines consider diabetes patients have at least a moderate to high or high to very high risk of cardiovascular disease. This proper therapy with moderate or high intensity statins are needed. In the Southeast Asia region, shared decision-making should be an important part of lipid management for people with diabetes. Different treatment goals. We know that in our area, different strategies of different groups. Some can afford, some cannot afford, and thus we have to choose. Although sometimes let's say for instance Indonesia, very difficult, not very difficult. The people mostly can afford only the lower doses, and yeah, that's what we can. But if you see, we want to achieve the target less than 70 or less than 55, it will be hard. And the new drugs are not yet available, thus we have to fight with what we have. Thank you very much for your attention. Thank you once again. I hope.
Well, that was indeed a very good lecture. And the next session would be by Dr. Shehzada Salim from Bangladesh, and his topic would be chronic complications of diabetes in South Asian countries and ways to mitigate it. Dr. Shehzada Salim is Associate Professor, Department of Endocrinology, General Secretary, Bangladesh Endocrine Society, and Sub-Editor of BSMMUJ, Associate Editor of BJEM. So over to Dr. Shehzada Salim, sir.
Okay, my slides are visible?
Yes, sir, your slides are visible.
Okay, thank you for the kind introduction, and I am grateful to IDF Southeast Asian region for arranging a beautiful program coming back from the Lisbon, and also selecting me as the speaker on chronic complications of diabetes in Southeast Asian countries and ways to mitigate this. And greetings from Bangladesh Endocrine Society to all who are listening to the presentation. I am grateful to my previous speaker as he elaborated many of the parts and made my presentation very easy. And previous speaker, Dr. Manilka from Sri Lanka, he also covered many of the parts. So I like not to duplicate the previous talks part. So I do not have anything to disclose. Everybody, not only the endocrinologists and other physicians as well, including the patients, they are aware of that the prevalence of diabetes is increasing worldwide. But as we are talking about the Southeast Asian region, we can find that next to Africa and Middle East, the increase rate is third in position. From the Southeast Asian region, it is 68% from 2021 to 2045 year. So this estimate says from the IDF Atlas 10th edition. Now, not only that, the number, but we can find that the age at the state comparative diabetes prevalence in Bangladesh is 14.2, Bhutan 10.4, India 9.6, Maldives 9.2, Mauritius 22.6, Nepal they are doing better 8.7, and Sri Lanka 11.3. And the money spent for diabetes management, this is not very good in shape. Bangladesh very lower, $76.5 US, and Maldives is spending highest from this group. It is around 1,900 per patient per year. So what is the burden? We can assume from this part, but a sharp increase in the prevalence of diabetes of this South Asian region has been noticed, and both in urban and rural areas. So previously it was told that the urban area is very much in a very much risk zone of diabetes mellitus, but not only now these days we can very confidently say that rural area as well has the higher increased rate of diabetes mellitus from this region. And not only that, the rapid urbanization, I should say the unhealthy urbanization is going on, encompassing the total geography, and the lifestyle modification, lifestyle transition also contribute to have more patients with diabetes mellitus. This increased prevalence of diabetes in Southeast Asian regions is multifactorial. Not only these factors, but also biological factors are also contributing, including genetic factors. I will highlight few of them. So if we go to the complications according to the other publication, this has been published by Mr. et al. In 2017, they found that in Bangladesh, India, Pakistan, Nepal, the age-adjusted death from CKD and major attributable risk factors in South Asia, we can find that in Bangladesh is the highest in India. Next to India, it is Bangladesh. So Sri Lanka, then Nepal, Sri Lanka, and Bangladesh, not only the death rate, but also systolic hypertension, fasting blood sugar, and body mass index all contributed to have increased mortality in patients with diabetes. The health burden of diabetes and associated mortality is largely due to its macrovascular and macrovascular complication. It is all known, but I will focus in our regional pattern. The Southeast Asian newly diagnosed patient with type 2 diabetes mellitus have a higher prevalence of complications at the time of diagnosis compared to Europeans. The macrovascular disease is 15.7 versus 9.4, and macrovascular 27.32 versus 16.5, including retinopathy and nephropathy. And several studies have demonstrated that compared to other ethnic groups, Southeast Asians with diabetes have a higher mortality rate due to chronic complications of diabetes. Now, what are the factors that cause increased prevalence, that cause increased rate of chronic complications and mortality? The number one is insulin resistance. Several studies, not thousands of studies, indicated that this one. I focus only one or two. The South Asians have a higher degree of insulin resistance compared to other ethnic groups, and which play a vital role in the development of diabetes. In 1980s, Mohan et al. Evaluated differences in the insulin response to an oral glucose load in Asian Indians and compared to Europeans, and it found that this group of patients has higher insulin resistance. The pancreatic beta cell dysfunction, this is also higher. Probably all seniors are very much aware of the term that this population group has underdeveloped pancreas. They have the low capability of producing higher insulin dose. So in requirement, so there will be postprandial hyperglycemia, and that has been proved in several studies. The body composition, this is one important thing, that this group of population having the lower body structure but higher fat composition. This is the term as the sarcopenic obesity in the Indians. So for a given BMI, South Asian populations have a higher amount of total body fat compared to Caucasians and higher amount of abdominal adiposity. This is very much associated with the cardiovascular risk. The increased risk of diabetes in South Asians is partly explained by the body composition, as the term I tell, the sarcopenic obesity among these people. The other biomarkers, I am not only going to in detail, I am only highlighting this point. The adipose tissue secretes adipokines that have metabolic consequences and further increase the risk of diabetes in South Asians. Adiponectin is thought to play a role in modulation of glucose and lipid. So compared to Caucasians, Asian Indians, men have lower levels of adiponectin independent of body fat content and distribution. That will contribute to insulin resistance and insulin dysregulation. Now, very important one, the genetic factors, though large studies are still awaiting, but at least 60 genes are associated to contribute to development of diabetes in this South Asian population, including Bangladesh, India, Sri Lanka, Nepal, Bhutan, Pakistan, all countries. From Bangladesh, one study showed that the 11 genes are strongly associated of developing diabetes among Bangladeshi population. The lifestyle factor, the role of urbanization and migration, it is very much discussed. The rapid urbanization and migration with subsequent lifestyle changes have been implicated in the rising rates of diabetes in South Asians. And the diet. The typical South Asian diet has several dietary imbalances: low intake of monosaturated fatty acids, polyunsaturated fatty acids, and fiber, and high intake of saturated fats, carbohydrate, and trans fatty acids. These dietary imbalances are associated with insulin resistance and dyslipidemia. Urbanization and migration have further exacerbated the effects of this imbalanced diet. In 2 years back, V. Mohan et al. Published one data regarding the carbohydrate consumption pattern from 11 countries of the Southeast Asian region. It showed that the people who are not having diabetes, among them, daily in total 80 to 90% of the total calorie is coming from carbohydrate. So the huge amount. Among the diabetes population, it was about 75 to 80%. Physical inactivity, gradually we are becoming more physically inactive due to urbanization, due to financial improvement, due to lack of facility altogether. Especially the growing people, they are suffering more. So the good number of young people are having diabetes from this area. To my words, this is the appropriate term, the food access. That does not mean that we are consuming huge amount of food every day. This means that we are taking a more amount of food as we spend as the calorie utilization per day. So we are taking more calorie, we are spending less calorie every day. And that is meant by the food access. This is one of the main important factors of causing the increased diabetes rate in our country. Now again, coming back to complications, this has been published in 2018, and this good photograph shows that the increased rate of diabetes complication in South Asian region, the vascular complication, namely the diabetic stroke, ischemic stroke in Pakistan, it is 30.5%. Ischemic stroke in Sri Lanka, it is about 5%. Now the retinopathy from India, about 18%, macroalbuminuria in Asia, 24%, in India, 26.3%, neuropathy, diabetic peripheral neuropathy in Sri Lanka, 24%, and nephropathy, 19.1%. All have been contributed by insulin resistance and poor control of diabetes. Now, the macrovascular complication of diabetes. With the increased prevalence of diabetes in Southeast Asian region, diabetes-related macrovascular diseases is expected to have a large health economic burden among this population. The coronary artery disease, the main culprit of causing mortality in type 2 diabetes mellitus. We can see that there is increased subclinical coronary artery disease and the clinical coronary artery disease. In an 11-year follow-up study of diabetic individuals in UK, South Asians are 3.8 times more likely to report a history of myocardial infarction. This is common for all, but we can see that the middle-aged people with diabetes, they have higher chances of having cardiovascular disease, and most of them are residing in this area. Cerebrovascular diseases, several studies have shown the strong association between diabetes and stroke in South Asians. South Asians suffer most commonly from lacunar strokes, which suggest small vessel disease attributed to greater diabetes prevalence in South Asian population. And it is around threefold more likely to have intracranial atherosclerosis compared to other population. Now, the cardiovascular disease mortality, you can find that up to 27 per 1,000 died due to cardiovascular disease among the young people, and mostly from this area. Now, peripheral arterial disease, this is one of the most important disorder, but commonly ignored by the physician and by the patient as well. So this should be included in our daily practice for screening the peripheral vascular diseases, but because this is one of the macrovascular diseases that can even contribute to diabetic foot and ultimately diabetic foot amputation. The macrovascular complications, many of the part has been discussed, so I am not going to those ones. The patients with type 2 diabetes mellitus from this area have a higher prevalence of macrovascular complications, and at the time of diagnosis, compared to the European 27.3 versus 66.5. So it is critical to understand the natural history of these complications in South Asians. Diabetic retinopathy, again, compared to the European, it is 36 versus 27% among the patients with diabetes. And for the same level of retinopathy compared to South Asians, Caucasians were 12.5 years older, and diabetes for 12.5 years longer suggested that South Asians develop diabetic retinopathy at a younger age. This is again very detrimental because it can cause blindness, permanent blindness. South Asians also had a higher prevalence of visual impairment compared to white Europeans, 6.9 versus 3.3%. Diabetic nephropathy, many studies have shown that the prevalence of nephropathy, both albuminuria and chronic kidney disease, is higher in South Asian population. A cross-sectional study from UK showed that the macroalbuminuria was greater in South Asian compared to Europeans. This is 40 versus 33% in men and 33 versus 19% in women. South Asians had poorer glycemic control and more hypertension, although this did not entirely account for the difference. The prevalence of CKD and in South Asians with diabetes is high. And stage 3 CKD was more prevalent in whites compared to South Asian, but stage 4 to 5 CKD was more common among South Asian population. Several studies from Bangladesh, especially from Bardem, showed that the stage 3, 4, and stage diabetes, diabetic kidney disease were more common among patients who had diabetes in our countries. Diabetic neuropathy, this is interesting. Diabetes neuropathy is prevalent in about 19%, but the diabetic neuropathy is its complication lower in South Asian compared to the Caucasian. This is one important area that can satisfy ourselves. Now, not only the complication, what are the cost of diabetes management? As I showed that the countries from this area are spending less, but the diabetes detected in the early age, the patient should be warranted to have long time of diabetes care. That will cause a huge cost. The rate of complication also higher, so that will also require huge cost for diabetes management, though we are not spending as much as that should be. The cost of care increases substantially when complications occur or when admission to hospital, surgery, or insulin. Studies from developed Western countries and developing countries in Asia have shown similar results with respect to quality of diabetes care and glycemic outcome among the diabetic population. And less than 30% of the patients achieve desired glycemic control from this area. Very recently, from our government channel, we found that only 13% patients from diabetes had good glycemic control. Now, the current response from the states and the challenges. The member states of the WHO from this area were committed to halt the rise in diabetes and obesity by 2025 as a part of the Global Action Plan for the Prevention and Control of Non-Communicable Diseases 2013. And 2020 that has an overall target to reduce premature mortality by non-communicable diseases by 25%. So it is again shown by the Mohan et al. The benefits can occur when lessons and good practice in diabetes prevention learned in one country and are applied to other countries, because we are sharing the clusters of risk factors and the outcomes. Now, so what we can do to mitigate these problems? There is no doubt that appropriate treatment of all people with diabetes reduce the risk of complications and early death. Interventions to improve treatment will be the first to show benefit, but treatment is not simply the regulation of blood glucose levels. It includes control of concomitant risk factors and cardiovascular diseases, education and support for life care, and screening and treatment of microvascular complications. All of these points are lacking from our country, this part of the world. As a lifelong and progressive illness, diabetes requires continued care by multifaceted healthcare team. The postulation and the graph algorithm has been given by American Diabetes Association, the chronic care model that should be applied. The main priority is strengthening capacity in primary care to diagnose and manage diabetes. That should be best option. Although diabetes management guidelines are available in most countries in Southeast Asia, Asian region, essential medicines tests are generally not available in primary care. In Bangladesh, we formulated guideline and very soon it will be published. Furthermore, the availability of tests and therapeutic interventions for chronic complications at the secondary care level is poor in the public health care sector. So, how to way forward? With a focus on prevention, countries of this region are encouraged to employ comprehensive strategies that include awareness raising programs, incentives for producing and buying healthier food, building and organizing cities to encourage physical activity, and fiscal interventions for discouraging the production and use of unhealthy commodities. This is the statement given by WHO. Several interventions. I am going to the community intervention for the physical activity. This is according to the ADA or other intervention. You can see that the nutrition status, nutrition intervention, Mediterranean style diet is best one. Weight management. The overweight or obese patient should reduce the body weight, but we can find few people having underweight, so they should encourage to have appropriate weight. Cigarette smoking should be ceased as soon as possible, and good glycemic control should be targeted because most of the countries from this area could not attain good glycemic control or sustain it. And the blood pressure and other parts has been covered by my previous speaker. So this was one approach to reduce the cardiovascular diseases among patients with diabetes mellitus. So the good food practice, physical activity, monitoring and screening the complications, and the tobacco cessation and blood glucose management, appropriate management of blood sugars as well. This is again for common people for the good health diet practice. I am not going in details, but this is in the website of the International Diabetes Federation that can be translated to in your own language to encourage the people to consume healthy foods daily. At the end, I like to conclude by saying the need to combat the negative impact of diabetes on the economic growth of individuals and nations with sound financing approaches is critical. Member states of South Asia region are at various stages of improving the equity and efficiency of their health system, but this should be in same concert. We need a comprehensive framework to make our societies less diabetogenic, make our screening system more patient-friendly, make our behavior change interventions more powerful and sustainable, and make our healthcare systems more effective to control diabetes and complications. The healthcare and societal burden of diabetes is alarming in many Asia countries, particularly in China, India, and others. In addition to the rising of the population with diabetes and its complications, the younger age at which the disease developed and the escalating occurrence of type 2 diabetes mellitus in children and adolescents of a care of significant concern. This should be very vigorously done. Rapid rates of urbanization, modernization, readily available fast foods, and sedentary habits have altered the lifestyle of the population, more so among the young. The health consequences are devastating in South Asian region as well in other parts, so we should be very much concerned about it. The primary prevention of diabetes is possibly the modifying risk factors such as obesity and insulin resistance. These are very much implicated to our lifestyle habit and the food habit. National programs promoting healthy lifestyle among the population starting from a young age should be given priority in the healthcare agenda for every country. Thank you all for your patient sharing, and probably at the end of the 4 presentations, we will come back with the question and answer session. Thank you again.
Well, Dr. Shehzad Salim, I must say that was an amazing lecture. And the next session. The next session would be by. Is there any disturbance? The next session would be by Dr. Peter Schwartz from Germany.
Yeah, thank you very much to the chairmen of this session. First, I would like to thank a lot for the invitation. And I actually would like to congratulate Bansi Shabu and all the organizers for drafting this meeting together. Yesterday, already at the inauguration, I have said this from the point of view from IDF. This is exactly what IDF should be like, that we are spreading the message about diabetes, spreading the message about prevention of diabetes, but arguing why is it important to treat and to prevent. And I would like to say Dr. Selim, just now, he basically has given the best argument why we should prevent diabetes. If we are looking into the prevalence of microvascular and macrovascular complications in Southeast Asia, I think it needs no more answer or no more argument to say why we should prevent diabetes. And this is what I would like to address in the next 20 minutes. Here my introduction. The main thing where I'm getting engaged into helping people with diabetes, building up programs for prevention of diabetes, but also encouraging people to act to improve care of diabetes in their countries, is in my function as president-elect of the International Diabetes Federation from actually 8 weeks past on. And that's why what I have said, it is so important to have meetings like this. But let's jump into prevention of diabetes, and I will mainly focus on type 2 diabetes. And my task is to give you some ideas and examples, what you can do as a clinician or a healthcare provider or diabetes team to help the people to prevent diabetes from developing. Here you see 540 people on Facebook. All the red ones will develop diabetes. And this is a projection from Caucasian population in Europe. So in Southeast Asia, you would probably see twice as many or even more as many red people on this slide. But why I'm showing this, there are also the green ones. The green ones, they have the same lifestyle. We could say they actually do the same things wrong. They are maybe female, take an anti-contraceptive pill, like to eat tiramisu, and like to have in the evening a glass of white wine. I apologize for saying this. But this is a typical combination of risk factors here in Europe to develop liver fat. So this is the one-way road to accumulate liver fat. And today we know this is one of the main drivers of developing diabetes, but already 15 years before the onset of diabetes. So actually, this could be a very interesting point or interesting determinant to tackle if we really want to prevent diabetes from developing. There's a lot of new information from the last years, and we have discussed this at Lisbon about prevention of diabetes. But the most strongest information is very, very simple. If we would walk 10,000 steps from the age of 22, we basically would prevent any chronic disease from developing, or we would prevent 99.7% of chronic diseases from developing. This shows what is the strength of physical activity, but it's going ahead. If you have diabetes, or if our patients have diabetes, and it doesn't matter how much they are walking per day, if they only increase by 1,000 steps, it would reduce the postprandial glucose by 1.5 millimole. And this is about twice as much as 1,000 milligram metformin are doing. So I must say this is a cool information because it shows us that prevention of diabetes is not in our brain as physicians. It's not in our prescription as diabetologists. It's in the muscle of our patients if we would be able to activate this muscle to walk. Because every muscle cell who is used, every muscle cell who is active is burning glucose and is initiating metabolic processes who basically help to prevent diabetes from developing. But this means we have to understand the pathophysiology if we really want to tackle the diabetes epidemic and prevent the disease. Here you see continuous glucose monitoring of young women with a high normal A1C. And the green arrows mean she's eating something. So it's actually a nurse in our diabetes ward. And if you see her, she's chewing something. She's always eating. But the purple line is a glucose. Normal is between blue and red. And here we see it's a total flat glucose curve. I must say, my first intention, as I have seen this, I thought it's several years ago. I thought the sensor is broken. Today we know that healthy means a total flat glucose curve. Healthy means, in this case, being very insulin sensitive. That means there are many insulin receptors on the fat cells, on the muscle cells, and every glucose which is arriving is immediately incorporated into the cell. But look here, this is her father. He's actually having a better A1C, and in the morning and in the evening, he has also normal values. But in between, we see there's, before he wakes up, there's a fluctuation, breakfast, maybe this was lunch, then it's going down again. What does this mean? Today, we know that this fluctuation are a very early sign of the development of prediabetes, or maybe he has already prediabetes. In this case, not, but it could be like this. And this is actually the right moment to tackle diabetes, or to tackle to address preventive measures of diabetes development. Because in this case, it needs maybe another 2 years to develop prediabetes and another 5 years to develop hyperglycemia with diabetes. If we would be able to act at this point, we would get the people. The difficulty is we don't find them. We cannot give a glucose sensor for screening to everyone. But from the physiological point of view, this would be the right moment. So the ultimate result of this is, if we really want to improve the outcome of people with diabetes, because this is also a kind of preventive measure, and addressing what Dr. Selim just has now said, with macro and microvascular complication, we have to do this. We have to cut the low glucose values and cut the high glucose values. And this will improve morbidity and mortality of the patient. You can imagine if you have two people with the A1C of 7, the one has low fluctuation, the other one has big fluctuation. The one with the big fluctuation will die because of a heart attack and a stroke. The one with the low fluctuation we can accept a higher A1C in this case, probably. So let's bring this together. This is the physiology of diabetes development. And so you see here about 80 years of a patient. The visceral fat is basically what is defining the development of diabetes due to the secretion of free fatty acids out of the visceral fat. And today we know that there are more than 700 peptide hormones released out of the visceral fat compartment. And these hormones make us getting depression, metabolic syndrome, dementia, impotence, but also diabetes and insulin resistance. And there's a new candidate on the game, and this is the hepatic fat. And if you look into the physiology, here is basically this woman I showed you at the beginning. The father is around here, and the accumulation of hepatic fat occurs in a period where there is a mean increase of insulin and insulin resistance, but here the pro-insulin increases. This is a precursor of diabetes or of insulin production. And if there's a sudden release of pro-insulin in the bloodstream, this means there's a fast increasing stress of the beta cell. And this is somehow associated with an increase of liver fat. We don't know, is it only associated with each other, or is there a causal relationship? But we see that liver fat accumulates and then it goes on. Here diabetes starts, and here we diagnose diabetes. So if we are honest as physiologists and scientists, we are coming far too late if we are acting here to prevent complications of diabetes. We have to think about to go into this clinical paradigm to prevent diabetes from developing. And the tissue or the determinant we have to address is the interplay between visceral and hepatic fat. And here you see two examples. This is subcutaneous fat. This is the visceral fat. This is what is making us sick. Here's the insulin signal transduction cascade. Insulin is docking to the receptor on the muscle cell. All these substances were phosphorylated and activated. Then the receptor moves to the membrane. All these red substances come from the visceral fat and block this process. This is what you have to know to understand insulin resistance, because insulin resistance is as simple. More liver fat, more visceral fat means more insulin resistance. But diminishing the liver fat, reducing the visceral fat means improvement of insulin resistance. But the insulin resistance, the common soil for all these diseases, and the liver fat is the devil in our body because it makes you becoming a non-responder to oral diabetes management and a non-responder for physical activity. And I apologize for this German slide I just see. What I would like to point out is this chart here. And here is the insulin resistance shown on this scale. And now we are combining people who have no liver fat. NAFLD in this slide is a synonym for liver fat. And who have liver fat. And you see, if you are obese, but you don't have liver fat, you have a better insulin resistance than a slim person having liver fat. And this, I think, from a clinical point of view, shows the relevance of liver fat as a driver of diabetes development. And it's also not only a driver, it's also our big hope to reach a remission of diabetes. Shown here, if we have high liver fat content, this always goes along also with a high pancreatic fat content. This destroys beta cell function. If we would be able to remove this fat from the organ, we can reach a remission of diabetes, but it means we have to reach low liver fat content or no liver fat, no pancreatic fat. We may be able to restore beta cell function. And my question now to you would be, if I would be in front of you, how can we get the visceral fat away? And the answer would be it's physical activity. Because of the release of these free fatty acids and all the hormones in the bloodstream, if you can say if the blood flows through the muscle is active, it initiates processes to burn free fatty acids, and by this you reduce the amount of visceral fat. If you walk 10,000 steps every day, you can reduce the visceral fat per 2 weeks by 80 grams. So you can count when it's gone. The liver fat or the pancreatic fat, the only way to get it away is fasting. If you fast and you don't eat for 2 weeks, so that means 0 calorie for 2 weeks, you may abolish the liver fat and pancreatic fat completely. In my eyes, this is very effective prevention of diabetes. Lifestyle intervention was tested in several studies. If we change lifestyle, we prevent about 50 to 60% of diabetes. If we give drug, it's about 30% of diabetes. If you look into the real world evidence, these are the 5 core goals for prevention coming from the Finnish diabetes prevention study. If you implement only none of these goals, 8 out of 100 people get diabetes. If you implement all 5, none will get diabetes. So this is very hopeful. So changing lifestyle is very powerful. And if you look into the studies I just have shown, what have they reached? The Finnish study and the American study, reduced visceral fat, reduced insulin resistance. The studies done in Asia had actually a broader scope what they have achieved. So this is actually, I will not say better, but at the end it is better because they address the better clientele of patients. But we also have to understand our patient. Again, if I would be in front of you, I would ask you who likes to drink a Coke. Some may raise a hand. Then I would ask who likes to drink a Diet Coke, and maybe some more will raise a hand. And I would tell them, stop drinking the Diet Coke. And why? Here are 380,000 patient years on this slide. If you drink one soft drink, what it does was diabetes risk. If you drink water, it has no influence on diabetes risk. If you drink orange juice, it increases diabetes risk by about 40% per year, like a normal Coke, but the Diet Coke increases by 60% per year. How can this be that the Diet Coke without sugar is associated with a higher diabetes risk than the normal Coke? And the answer are the artificial sweetener. There are 38 artificial sweetener available worldwide. 36 do what I just want to tell you. They change the microbiome. So if you exceed a certain threshold of artificial sweetener every day, 14 different bacteria invade your gut and they help us to digest. We don't feel it. But the bad thing on this bacteria is they produce fatty acids, and these are heavily saturated fatty acids, and then they are in our gut, and we incorporate them like the fat from the tiramisu And the bad message is that these fatty acids from this bacteria, they are stored in our liver. So they make a liver fat increase, or they at the end make a NASH. And the bad thing is, if you're doing physical exercise, then you consume a high amount of artificial sweetener. It changes your gut microbiome. Then these fatty acids are produced and you become a non-responder for physical activity. So you basically walk 10,000 steps a day, but it works like walking only 2,000 steps a day. So this is a big barrier for prevention, or it's a big catalysator basically for developing diabetes. And if we touch what is our strategy to change for prevention of diabetes, if we talk about people with diabetes and obesity, we as physicians are out of the game as decision maker for the lifestyle of the patient. And the patient is purely following his quality of life if he really want to change something. So if we think about the development of prevention strategies, we have to develop strategies that people like, where the people have the feeling that it's improving their quality of life, then they may adhere. And this is not so difficult because there are standardized behavior change models for diabetes prevention. There are techniques you can use like motivational interviewing, reflective listening, change talk. You can apply to help the people to move from different stages of readiness to change into a stage of maintaining a more healthy lifestyle. And we were able to put this together into standards of diabetes prevention, which are available in many countries in the world. 54 countries have adopted to this diabetes prevention standards we have developed already about 10 years ago. And these are guidelines and toolkits for the prevention of diabetes. At the end, how to develop and implement a program for prevention of diabetes, finally being successful to make a difference for people with diabetes risk, but also focusing on training the workforce who should be able to deliver prevention programs. Because this is a very important point, that if you have a high number of people who have a passion and want to do something, they also need to know what to do and how to do it in a correct way. There's a long list of material available, and also drafted programs how to develop a diabetes prevention program in the occupational setting, in a rural setting, in a community setting, and so on, and available in different languages and different cultural and religious background. I mentioned that abolishing the liver fat is only able with fasting. And I always get the question how this fasting is meant for, or how is it implemented? At the end, it's very simple. You decide to stop eating. You have to clean your gut. You have to drink 5 to 6 liters of water per day, only water or simple tea. The first and the second day of the 2 weeks is good. You feel a little bit hungry, but this is fine. The third and the fourth day is a catastrophe. Here in Germany, I always say it's like you have a heavy hangover after 2 bottles of vodka. But then in the fourth day, it suddenly switches. And what happens on the fourth day? You run into a ketosis. So the body stops burning glucose, because the stores of glucose are empty. We store about 1,800 grams of glucose in our body. But after 2 days, or after, let's say, 3.5 days, this is gone, what is easy accessible. And then the body starts burning ketones. And if we have our hand and we have a handful of glucose and a handful of ketones contain more energy than glucose. So ketones are like, it's like a superpower for our brain. It's like superpower for our heart. And if we have to burn ketones, we have to get them from somewhere, and they come from the fat. And the body accesses the fat, which is easily accessible, and this is in the liver and visceral fat. So the fasting is a very, very good way, and the only way to remove the hepatic fat and to reduce the visceral fat. But you have to be physically active if you are fasting. You have to walk 10,000 steps a day. If you fast and lay in bed, then the body breaks down muscles. And the fasting is only as successful as you break the fast And fasting break means first day 600 kilocalories, then 800, 1000, 1200. Then you can go on with the normal life. At these days, you have to drink still a lot and celebrate what you have achieved. And I would like to show you an AGP example of a diabetes patient. And it's like, remember the father I have showed you initially with the fluctuation of glucose. And this is an AGP of someone after he has fasted. So you get a flat curve for someone with diabetes. So for the fasting, you can reach this, that you have a sudden impact on liver fat, improving all the other parameters as well. And in many cases, this may mean remission of diabetes. But we have to address needs of our patient. I would like to go fast through this, combining it with all the digital information which is available today, and assessing what really the patient wants. We can develop toolkits at the end, assessing the risk and then deciding if there are 100 different interventions qualities for prevention of diabetes, that assessing the need of the patient will tell us what will be successful for this patient. So smart health, I think, will be disruptive. Here we have analyzed how oral agents lower A1C, how lifestyle lowers A1C, how digital interventions lower A1C. And you see young digital interventions have a strong impact on A1C because we are in the pocket of our patient and we have never been so close to our patient. So using smartphone-based apps is a bright future for prevention of diabetes. Is this enough? Of course not. Don't forget the 10,000 steps a day to be walked to prevent diabetes from developing. This is evidence-based. It keeps you healthy. And it makes you healthy also in South Asian population. Using a pedometer, here you find the old pedometer will help. Today, every smartphone has a pedometer pre-installed. And if you 3 times a day look on the step count, you walk 3,000 steps at the end of the month more than the beginning of the month. But don't trust your physician. Here are 31 diabetologists from Germany on the slide. Only one is on the stair. All the others go to the escalator. Airport in Doha, airport in Munich, airport in Dammam in Saudi Arabia. So these are we as physicians. So maybe we should think to be a good example to our patient, to be physical active ourselves. 10,000 steps is the goal, and let's work together to use our ethnic, our cultural, our religious knowledge, our intuition, our scientific knowledge, and work together to use all this aspect to finally walk away from diabetes. Thank you very much. Shukriya.
Well, Professor Schwarz, I must say that was an excellent talk, especially the presentation on Diet Coke and the stairs and the escalator thing. Once again, I thank all the 3 speakers, Dr. Siddharthan, Dr. Shahzada Salim, and Dr. Peter Schwarz. Any questions from anyone to be answered? So we would take quick few questions. Fine. I once again thank all the speakers and my co-chair, Dr. Dulani and Dr. Aishat ma'am. And over to the next session. We have a wonderful next session with the chairpersons, Dr. Vijay Patni and Dr. Subhajyoti Ghosh. Over to you, sir. Do we have the next
Thank
chair?
you, everyone. Am I audible? Okay.
Yes, sir.
So to continue with the session, so our next speaker will be Dr. Dinas Sestra from Nepal, and she is a President South Asia, the Federation of Endocrine Society, consultant endocrinologist. She completed her MBBS from Tianjin, China, and is an MD in internal medicine and endocrinologist too. So basically, she will be speaking on treating obesity in women and diabetes. Over to you, ma'am.
Good morning, everybody. I want to thank on the outset Dr. Banshi Sabu for making me part of this great academic feast. So the topic given to me is very interesting and I think important for this era, treating obesity in women with diabetes. So in my overview, there's just a short introduction, obesity and risk of diabetes, and then we'll talk about how treating obesity in women with diabetes is important. So the introduction is quite simple. We all know what obesity is. WHO defines it as a serious chronic disease characterized by abnormal or excessive accumulation of fat that may impair health. This sounds a bit old, but that's what it is as definition. And this is like a subjective thing, So to make it more objective, we can actually calculate obesity, or we can say this person is overweight, normal range, or nowadays we call it pre-obesity by actually calculating the BMI. So BMI is calculated by weight in kgs divided by height in meters square. So then the numbers are like, if you're under 18.5, you're underweight. It doesn't matter where you are internationally, right? But normal range is from 18.5 to 25 internationally. But for Asians, it's different. So we know that for Asians, the BMI will be slightly lower. It's going to be 18 and 23. And pre-obesity, or what we used to say overweight, is like over 25 and under 30. And for Asians, it's more than 23 and less than 25. Obesity per se is defined in international classification as over 30, and for Asians, over 25. The international classification of obesity further goes on to go like class 1, class 2, class 3, because that is associated with more morbidity and more risk of mortality and more comorbid conditions. But for the Asians, we just stick to obesity being more than 25. We also know that BMI has its own caveats, and that is why we can also sometimes use the waist-hip ratio, which can be more reliable for the visceral fat and obesity, which we know is one of the driving causes for diabetes and obesity. So we're not surprised. The global prevalence of obesity is on the rise. Among adults, 650 million people are living with obesity now, which is a big number. And the sad part is that not only it's the adults, but now even the children and adolescents are actually, there's a rise. So it doesn't matter whether you're in Central Asia, whether you're in Latin America, or whether you're in Europe, boys, girls, both alike, there's a rise in the number of children and adolescents with obesity. So why we are talking about it is like, it's not, how it is about now fatty liver not being as benign as it was, and we know that it's got its complications. Same thing, we would say you're overweight, or, there's a bit of obesity, you have a bit of a belly fat. But now there is enough data to tell us that the life expectancy actually decreases as the BMI increases. So it's something serious that we have to think about. And that is why there's been a worldwide noise, awareness. Everybody's just like trying to bring it out that actually, it is not it's not so silent, it's not so benign as we used to think a few years ago. And even in Asia, like we know that, or Africa, developing countries, that we always thought that being overweight or being a bit healthy, we would call it. But actually, no, obesity, when there's extra fat, is actually going to have a lot of health repercussions for us. So with that introduction, we can talk about obesity and the risk of diabetes, how that is coming, right? So we know now that the obesity is driving the type 2 diabetes pandemic. We know diabetes is on the rise and obesity is literally pushing it. There is a greater risk of developing type 2 diabetes. So higher the BMI, whether it's men or women, women particularly are, as you can see, have a higher risk with a higher BMI, but so do men, but if not as much. And 90% of people with type 2 diabetes are overweight or have obesity. So diabesity is the dual epidemic. So the terminology diabesity is used to describe the combined detrimental health effects of obesity and diabetes. And as we said in the previous slides, like 85 to 90% of type 2 diabetes are overweight or obese. And the numbers are getting worse. It is estimated that by 2025, which is not very far, right? More than 300 million of people will have type 2 diabetes associated with obesity. So the power is in the numbers. And how it relates to women is, so we can see that, for example, a baby is born large. This child becomes overweight, a girl child, and then an adolescent has obesity, becomes obese or has PCOS. And then she becomes pregnant, and then during her pregnancy, she develops GTM or hypoglycemia during pregnancy. And then again, she is going to give birth to a large baby, or with the fetal programming of her making prone to obesity and type 2 diabetes. So it's a vicious circle that is going on. So that is why women's health has to be prioritized. So there are, this is just a very blank way of saying there are stages of life in the women, the puberty, the young women, perimenopausal and menopausal. And we know that each of these stages are governed by different kind of hormones, right? So what happens is that with this also, another thing what we can think is that the effects of this environment on this body weight is like settling. So, when you're young, the normal weight might be a certain BMI, but as she grows older, she has one pregnancy, then there's postpartum weight, and then she gets menopausal. And then each time there's actually a new normal weight for her. And these women just think that, I'm a mother of 2, or, now I'm menopausal, and that is why this is normal for me. But actually that might not be good for her. So the health goals for people with type 2 diabetes and obesity is, of course, we want to improve the blood glucose. We want weight loss. We know that 5 to 10% has a significant impact on diabetes and its comorbidities. Improve the quality of life, limit side effects of type 2 diabetes, and optimize the use of glycemic medication. And of course, the goal in all is to improve the comorbidities and the CV risk. I see this and I think, remember how life was so easy when we thought, intake versus expenditure, hunger, satiety, nutritional absorption, and you expend it, physical activity, resting metabolic state, and, you've got, just lose weight, go on. But no, now we know obesity is not that simple. It's a complex and multifactorial. The energy intake, the energy expenditure depends on a lot of things, the hedonic input, the experience, the adipose tissue, how they act, the pancreas, what is the fetal programming, how the gut, the microbiome, the genetics, the epigenetics, the medication she's on, the other conditions that women are prone to also, like, hypothyroidism, osteoarthritis, other autoimmune disease, and then the environment, the socioeconomic. So the etiology of obesity is complex, right? So we can see that the obesogenic environment can be financial stress, any kind of stress, where she's not sleeping well, sleep deprivation, emotional stress, sedentary job and commuting, eating disorders. And there are now, we know about the endocrine disruptors. And then the genetic susceptibility, her epigenetics, the medication she's on, whether she's menopausal, premenopausal, whether it's post-pregnancy, weight reduction, fluid retention, and gut, like I said, the gut microbiota and hypoglycemia. These are the driving forces. So really for the management, as now we have realized that nothing is really straight. For everything, we do need a team. And the team of diabetes management is also bariatric surgeons, physical educators, dietitians, physicians. Everybody has to work together. The treatment options still now remain, number one would be lifestyle intervention. You have to eat healthy, physical activity has to be there, and there has to be behavioral therapy. We have to pay more importance and equal emphasis on behavioral therapy. Pharmacotherapy is there, and we are lucky that, in this last few years, we are at least getting better drugs which are more friendly towards these weight, right? And then, of course, there has been enough data that bariatric devices and surgeries are helpful. So for the dietary management of diabetes or obesity guidelines in women, it's not too bad. It's almost the same. Don't eat too much fat, 30%. It should be less than 30%. The saturated fat, try to keep it less than 10%. The carbs, make sure they are complex carbs, and then 50 to 55%. Sucrose should be less than 10%. The protein, the good ones, 15 to 20%. And of course, reduce your salt, and then increase your dietary fiber. So as I was saying, at least the drugs that are there, we can choose. We have some help with that. There was an era of just sulfonylureas and insulin, but now we know that if there is a matter of hand about, about weight. So the least favorable would be sulfonylureas, insulin, and TZDs. But we know that even sulfonylureas, some are better than worse. Insulin's also the same. Then the weight neutral, not so good, like not so bad, not so good, are the AGIs and DP4 inhibitors. And the most favorable now are the GLP-1 agonists, the SGLT2 inhibitors, and metformin are good old drug. So weight loss, of course, does reduce the risk of type 2 diabetes. And we've seen that over 10 years, whether if you take the placebo versus lifestyle changes, and metformin, lifestyle is always trumping it. And if you lose weight, definitely you have a better, you have the reduced risk of type 2 diabetes. And you can see that it is not only in diabetes, it is in preventing diabetes, in managing diabetes, and in the remission of diabetes that we're talking about these days. So weight loss improves obesity in these women, reduction in the risk of diabetes, heart disease, of course, cholesterol, blood pressure, and OSC, which is now we know is more and more. And of course, the one thing might be missing is liver, in fatty liver, and the quality of life. So what are the drugs that are available really for the anti-obesity, and what are the effects on the HbA1c? Orlistat has been there. We have been using it. It does work. Liraglutide is there. Sema is there now. And the good old topiramate and propionine are there. And they all have their modest, moderate weight loss effects on these women. So these are one of my last few slides, is like the latest ADA-ASC consensus reports of 2022 also highlight the importance of prominent focus on weight management. So it's not only about glycemic, cardiorenal risk, but also about the weight management. So for that, in these women, of course, behavioral and lifestyle modification has to be there. I mean, no amount of medications can compensate for if the woman is just sitting depressed, saying, I can't move, I can't eat, I can't sleep. You have to sort that out. And then the OADs, there's metformin you can start, and the kind of the mild ones, the alpha glucosidase inhibitors, and the GLP-1 analogs, the SGLT2 is there. And if nothing works, then of course bariatric surgery is there. So to summarize my talk today, obesity is defined as an abnormal or excessive fat accumulation. The global spread of obesity has been pandemic, and it has pushed diabetes to its limit. We have the dual epidemic that we are fighting now. Studies have proven that the effects of weight loss on diabetes prevention and management are there. And so it is very important to manage obesity in diabetes women. Thank you so much. And I would like to take this opportunity to invite everybody for the SAFI's International Endocrine Congress we are doing here in Kathmandu. It's being held on 17th and 18th of March. It's a weekend. Hope to see you there. Thank you so much.
Thank you. Indeed, it was a wonderful presentation. So now I would like to introduce our chairperson, my co-chairperson, Dr. Vijay Patnani sir, and to introduce our next speaker.
Thank you. And can I have a question for Dr. Shrestha? Or we can go ahead with the next speaker. Okay,
so
fine,
we can go ahead. We can have the question session at the end.
Thank you. Thank you. Thank you. Yeah, can I have the introductory slide, please? We have Dr. Matthew, who is from slides are not visible. Can you see the slides?
Yeah, so on that ground, sir, can I continue with the
Yeah, you please go ahead. Yeah, I can't see the slide. Oh, she's from the Belgium.
So,
thank you.
To continue with this learning from IDF.
Yeah.
So may I introduce Dr. Chantal Mathieu. So, ma'am is MD and PhD from Belgium. He's a professor of medicine. He's a chair of endocrinology at the University Hospital Gestumberg. Then he received her medical degree and PhD at the University of Leuven. Then her clinical area of interest is organization of diabetes care, and she is involved in several clinical trials in type 1 and type 2. She also received prestigious InWev Valiant Latour Prize for Clinical Research, and also the Vice President of EASD and Chair of Postgraduate Education at the EASD. With this introduction, may I welcome ma'am, and the session is all yours now. Over to you, ma'am.
Hello, everybody, and excuse me for my voice, but I have encountered the European virus, And in the meantime, I am president of the ESD. So it's, as always, a pleasure to be with my Indian friends. And I will indeed go back to you to the work we did in the last years on coming together with international experts on both sides of the Atlantic from ADA and the ESD to make the joint ADA-ESD consensus on the management of hyperglycemia in people living with type 2 diabetes. And I've given it a twist, namely how to adapt this to the world. Of course, I need to be open, and I share with you my conflicts of interest. I do advise most companies that make tools or drugs that help us treat people living with diabetes. All the income of this work goes to the institution. So here you can see the people, the experts who came together this time. Every 3 to 5 years, approximately, this effort is happening. And so translating ADA, ESD consensus guidance to the world is actually quite easy. I started with this critical question in mind and looked at and re-looked at the whole text, re-looked at all of our slides. And as you will see, it is adaptable to everywhere in the world where you are, whether you're in Asia, in Latin America, or in Europe or North America or Africa. It's all the same. Because first of all, this figure, for instance, saying that the person living with type 2 diabetes should be at the center of care, be an integral part of the medical team, and that also the goals of our therapy should really be to prevent complications of diabetes, acute and chronic, and optimize quality of life. That is true whether you live in New York or Brussels or Mumbai. And so everything starts with looking at the characteristics of the person sitting in front of you. Some key characteristics like, does this person have a myocardial infarction? What is the renal function, etc.? Because now we do have evidence that these key characteristics will drive the choice of pharmaceutical products in the treatment of these people. Then, of course, you have to consider specific factors that will impact the choice of treatment, like side effects of agents, tolerability, renal function, for instance. Come to a shared decision plan, discuss with the person with type 2 diabetes, and then agree on this plan, implement the plan. But then, as importantly, is to reconsider, to reevaluate the plan at different times as the life of the person goes on, because the conditions may have changed. He or she may have started to become a bus driver. And so you may have to adapt the therapy depending on the specific circumstances. Now, we always present this big table on how to choose pharmaceutical glucose-lowering medications in the management of hyperglycemia. But again, this year, we put on the top of this table, we put the importance of healthy lifestyle behaviors. I think Peter Schwartz, in his talk a couple of minutes ago, really showed how nicely lifestyle behaviors impact on obesity, impact on diabetes. And so this is not to be neglected. And part of that also is education, information of the person sitting in front of you on why it is important. And again, it is a therapy that is demanding. And on the other hand, people do not have pain, people don't feel anything. And so to really explain to them what this disease is all about is so important. And then the third little statement in this line is really also very important. And our American friends really put a lot of emphasis on that, because in their system, where a lot of treatments come out of pocket, in contrast to Europe, the social determinants of health, namely taking into account, is this a single mother? Is she raising on her own 3 children? Is she limited in monetary circumstances, etc.? All of these things matter. And also, in my country, although we have reimbursement, social determinants of health are crucial in really determining how we will approach the people living with type 2 diabetes. And then, of course, this little bullet on the top of the right is still there and remained very important. We had it in 2018, put it back in 19, and put it back now again, namely revisit every 3 to 6 months, because the situation of the person may have changed, and we need to be proactive. The word is now in the consensus. We need to avoid clinical inertia. But I want to come back to these healthy lifestyle behaviors, because here we introduce now the novel concept, a novel figure, where we brought together interesting points where now evidence is growing. And this evidence is growing, for instance, on how intense should physical activity be? And what type of physical activity should we advise to people living with type 2 diabetes? Should we tell them to walk and run? Or should we rather, and there's some interesting evidence coming out, tell them and give them tips on how to strengthen their muscles? We all live lives that include a lot of sitting. Also, the people living with type 2 diabetes have a lot of sitting in their daily lives. And so giving tips based on evidence on how to incorporate physical activity in your daily life that we know includes a lot of sitting like I'm doing now is important. And also giving them a very specific advice on what they should accumulate. Again, Peter already alluded to the 10,000 steps. And then finally, a lot of evidence now emerging on the importance of sleep. Not too much, not too little, but also, unfortunately, a lot of evidence is coming out now on the impact of disruptive behaviors in work, where night shift workers, for instance, have a higher risk of insulin resistance. Also, people flying across time zones, for instance, a higher risk of insulin resistance. And so I really invite you to go to the websites of ESD, ADA, and download not only the papers, but also the full presentation, where you will find a lot of these figures for you to use with a lot of practical tips. And here, for instance, the fact that if you are sitting down the whole day, for instance, if you work in a phone answering company, just standing up every 30 minutes, walking around, a bout of exercise, breaking the sitting will be important to improve insulin sensitivity. And again, what type of exercise? It needs to be an exercise that induces sweating. Not just a little walk, going to the shops, but really physical exercise. And again, it can be very practical, like doing your house hold, cleaning windows, etc. But having exercise that is moderate to intense needs to be incorporated. And again, a lot of attention, dear friends, on the avoidance of sarcopenia. It was, again, already alluded to by Peter Schwartz that if you lose weight while lying in bed, you will lose also a lot of muscle. And so when we are using medications or interventions that make people lose weight, we have to realize we lose fat and muscle. And so in order to limit the loss of muscle, we need to preserve the muscle and do exercise that preserve the muscle. And also we need to pay attention to sarcopenia being present in many people with type 2 diabetes who have a history of dieting and who have really shifted from a balance between muscle and fat to a preponderance of fat. And to fight this is very important. And as said, also the step counter is quite interesting. Building muscle, I already alluded to. And then this intriguing evidence emerging on the importance of quality, not too much, not too little, but also quality of sleep. And then again, the chronotypes, the early birds being more protected than the night owls. And then comes what kind of medications you should choose to help lower glucose in people with type 2 diabetes. And there again comes the new evidence that was accrued in last years on how to treat people with a cardiovascular and a renal risk in those who are at high risk. And on the other hand, we now put a lot of emphasis that we need to put forward when we talk about treatment of hyperglycemia, goals for glycemia, but also goals for weight in people with type 2 diabetes. And you see there's no lines, no arrows here. So they are equal. You need to do the goals for achievement of, the goals for hyperglycemia and weight, and the goals for treating cardiovascular risk. But let me first very quickly go through the right-hand side of the figure where we say put glycemic targets for the person, be aggressive, be proactive from the beginning. In many people, you will use combination therapies from the beginning. The good old metformin is there, but particularly in individuals with cardiorenal risk, specific classes of agents like the SGLT2 inhibitors and GLP-1 receptor agonists will have to be there from the beginning, as I will show, independent of hemoglobin A1C. And also in others, we promote the use of combination therapies from the beginning to avoid clinical inertia. And then we just ranked the available glucose-lowering agents depending on their potency, going from very high to intermediate. And in the very high category, you have the typical high doses of dulaglutide, the semaglutide, and the tirzepatide that unfortunately at the moment is not yet available in my area, and I guess also not in your area. So really ranking just on the basis of glucose lowering potency. Insulin is there. As you know, insulin is one of our most potent glucose lowering agents, but is limited, of course, in its potency by the fact that you are hindered in titration by the effect on hypoglycemia and weight. And then, as said, also important, have weight targets for the people with type 2 diabetes. Weight has an immediate effect on glucose. We saw by the previous speaker, weight is at the basis of hyperglycemia, but also helps us control hyperglycemia if we can control the weight. We open the discussion to introduce bariatric surgery in those where it is appropriate. And then we say, when you choose your glucose lowering agents, take into account their effect on weight. And so here again, we rank now the glucose lowering agents depending on their effect on weight. And again, do reiterate all of these cycles, and importantly, reintroduce education at every step where you feel you're not on target. And then where most of the information, of course, has come from in the last years is how to treat those with a high risk of cardiovascular disease or of renal disease. And so here we bring together everything. We say that those with pre-existing atherosclerotic cardiovascular disease or with those with a high risk of cardiovascular disease, in these, you need to use a GLP-1 receptor agonist with proven cardiovascular benefit or an SGLT2 inhibitor with proven cardiovascular benefit. And if need be, combine, eventually introduce also the TZDs. In those with heart failure, there it's obvious it is the SGLT2 inhibitor class that needs to be on board. And in those with pre-existing chronic kidney disease, and here we fully aligned with the KDIGO guidelines, namely being an EGFR below 60 or albuminuria that is present already from the microalbuminuria level in these individuals. So a limited EGFR below 60 or albuminuria present there we prefer the SGLT2 inhibitors because these agents have shown direct protection of the kidney, especially canagliflozin, empagliflozin, and dapagliflozin. However, you have to realize that below 60, these agents will have little effect on glucose control, but we propose them for their direct kidney protection. And also because in these individuals, they protect against hospitalization for heart failure, and several studies also show protection against mortality. If these are contraindicated or not tolerated for side effects, for instance, like genital infections, then we propose to use a GLP-1 receptor agonist that has shown cardiovascular protection in individuals with chronic kidney disease. And again, combination of therapies. If glucose control is not controlled with the classes we propose here, you of course need to take the right-hand side of the table into account, as demonstrated here with the different agents for you to control glucose. But let me go back to the cardiovascular and renal, so you know that a lot of evidence has accumulated in recent years with the outcome trials. Again, go to the papers. They are free to be downloaded for you, also from the websites of Diabetes Care and Diabetologia. Going back to the details, so those with pre-existing atherosclerotic cardiovascular disease or the high risk category, a lot of evidence now really putting forward GLP-1 receptor agonists on the forefront in this category, and the SGLT2 inhibitors in this category, here mainly for the reduction of the hospitalization for heart failure. And so here in individuals with pre-existing cardiovascular disease, we are very firm. We say that there should be a GLP-1 receptor agonist with proven benefit or an SGLT2 inhibitor with proven benefit on board. There should be to protect for the GLP-1 against MACE, for the SGLT2 inhibitors against MACE, hospitalization for heart failure, and also directly protect the kidney. Again, when we go back to those who have already a cardiovascular incident, or those who are at high risk, you will see that the language in the consensus is a little bit weaker when it comes to those at high risk. Why? Well, because the amount of evidence is just a little less. It is obvious that when you take all of the studies, you put them together for GLP-1 receptor agonist and SGLT2 inhibitors, and you put them together for those with established cardiovascular disease or not, it's just the numbers that are less. And so the whiskers of the confidence intervals overlap with the one. But overall, the protection will happen with the GLP-1 receptor agonist or the SGLT2 inhibitors in those with pre-existing disease or those with the high risk. But it's just that the evidence is a little less overwhelming. And so here our wording, and I can tell you we discussed hours and hours on this wording, here we say could be used in those with the high risk, but solely on the basis of the amount of evidence being present. We do not doubt it. And then, interesting, the discussion whether metformin plays a role, whether hemoglobin A1C plays a role. And here it is obvious that here on the left-hand side, and pardon the size of the font, but whether you have metformin on board or no metformin on board, whether you have a low hemoglobin A1C or a high hemoglobin A1C, every statement on heart protection, on heart failure protection and kidney protection is there, independent of metformin, independent of hemoglobin A1C. And so these bold statements are also there in our consensus. So introducing SGLT2 inhibitors or GLP-1 receptor agonist should be there to directly protect the organs independent of metformin and hemoglobin A1C. What about heart failure? There, it's very easy. There, it's really the SGLT2 inhibitors that are the most powerful agents. And here you all know now also, we also have Deliver in the meantime, but that was not published at the time of the consensus. We know now that not only in people with type 2 diabetes, but also in other people with pre-existing heart failure, hospitalization for heart failure, other important outcomes are reduced. And as you know, also in individuals with type 2 diabetes who do not yet have heart failure, this class of agents protects against hospitalization for heart failure. What about chronic kidney disease? I already introduced the criteria. Here are the 3 big studies, credence in people with type 2, but then now we have overwhelming evidence. And again, EMPA-Kidney was not published at the time of the consensus, but we have overwhelming evidence now of direct renal protection by SGLT2 inhibitors, specifically dapagliflozin, empagliflozin. And here for DAPA-CKD and EMPA-CKD, we also now have evidence that it is independent of the type of renal disease that protection happens. It is actually also independent of type 2 diabetes being present. So also independent of metformin, independent of hemoglobin A1C. And so very, very bold statements that these should, SGLT2 inhibitors should be present in people with CKD. Here we put the limit of 20 mils per minute. So you need to be above 20 mils, again, because of the evidence. But when you look now at EMPA-CKD, you see that the protection happens even in EGFRs below the 20 mils per minute. And so here is the whole overview. It's not or, it is really and. It is direct organ protection, and it is glucose and weight goals, and that is all that is important when choosing glucose lowering agents. And so we brought it all together in one big figure because we wanted to emphasize again the person with type 2 diabetes at the center, the importance of glucose goals and weight goals and the choice of agents for that. We wanted to emphasize that specific cardiorenal protection happens with specific classes and agents within these classes. But we also wanted to emphasize that all of that needs to be embedded in a whole holistic cardiovascular risk factor management in people living with type 2 diabetes. These are the components of the care. And there are principles of care that you should take into account, like try to avoid hypoglycemia, avoid clinical inertia, take care of the importance of language. Don't talk about a diabetic, talk about the person living with type 2 diabetes. And again, here we put everything together with the highlights. And again, I just want to emphasize the importance that all of this needs to be embedded in a holistic approach of people living with type 2 diabetes with blood pressure control, statins, etc., etc. And then this slide. This slide I snuck in when we presented our consensus at ESD last year because of some frustration that we have evidence. This evidence is translated in guidelines. This guidelines, this evidence is translated in a consensus between experts who work now for 1 year in reviewing this evidence. But we are still inert. We lack translation into the real world. And again, we use many excuses, monetary excuses, etc., or the fact that specific groups like young people or old people are not present in the evidence, etc. But we shouldn't use excuses. We should translate the evidence in our clinical work and really make it work. And my final slide is really a publicity slide for the ESD e-learning website, esd-elearning.org, where you are free to go, free to register. It is accredited now by the Royal College of Physicians. So you will, if you participate in modules on the website, you will get accreditation, not only a certificate of participation, but also accreditation by the Royal College of Physicians and also the Royal College of General Practitioners. So I want to end here with really a warm call. Go to the websites, download the papers, download the slides for you to use, and use our e-learning website for further education. Thank you very much for your attention.
Thank you, ma'am. It was an excellent insight into the ADA-ESD algorithm. And I think you have been able to justify the talk very well. And we'll take the question at last. I think we can go to the next speaker. Can we have the slide of the next speaker, please? So we have Dr. Rakesh speaking on pre-diabetes, and he is known to everyone. He is a professor and head of the Department of Osmania Medical College and Hospital. He's a consultant endocrinologist at Saha Endocrine and Diabetes Center, President Endocrine Society of India, Vice President South Asian Federation of Endocrine Societies. He is the section editor of the Topical Endocrinology Endotext, online textbook of endocrinology, editorial board member of IJF, anything and everything as far as award goes, and publication, more than 150 publications. I invite Dr. Rakesh Saha for his deliberation.
A very good afternoon to all those who have joined today's program. I would like to, at the outset, thank the chair and the chair-elect of the IDF Southeast Asia region to give me this, to invite me to speak on this prestigious platform. I would be speaking about pre-diabetes. So let me share my screen. Yeah. So as we know, pre-diabetes is the harbinger of diabetes, is the forerunner for diabetes, and we know that while we are going through this epidemic of diabetes, we have an even bigger epidemic of pre-diabetes, and that is what needs to be addressed if we need to win against diabetes. So I would quickly go through this the following heads to discuss about this topic. And to start off the discussion, I would like to say that pre-diabetes is a term used to describe individuals who have an abnormal carbohydrate metabolism, yet their glucose levels are not high enough to meet the criteria for diagnosis of diabetes. So we are seeing that there is an increasing prevalence of pre-diabetes globally, and it's becoming a public health challenge. It's important that we consider several aspects as to how we could stop this progression from pre-diabetes to diabetes. Could we identify those individuals who are at a greater risk for conversion from pre-diabetes to diabetes, and how we could look at the various comorbidities that accompany, or the complications that accompany along with pre-diabetes. So we have a significant, in the sense that there is a confusion in terms of the fasting glucose level to be used for diagnosis of pre-diabetes, while the ADA uses the range of 100 to 125 to define pre-diabetes. The WHO and would use the range between 110 to 125 to define pre-diabetes. And again, there are differences in terms of the numbers of the HbA1c, with ADA recommending 5.7 to 6.4 being the range for the definition for the diagnosis of pre-diabetes, while the International Expert Committee looking at a range of 6 to 6.4. In view of this, there are differences in terms of the prevalence rates identified by different studies which have used different criteria. Now, if you look at the IDF Atlas and look at the prevalence of pre-diabetes as per the recent IDF Atlas, we know that there are the prevalence of IGT is 10.6% or 541 million, whereas the prevalence of IFG is in the range of 6.2%, and that works out to a figure of 319 million people with IFG. We know that these two do not add up together, because there could be a lot of overlap between those individuals who have both IFG and IGT. In the ICMR INDIAB study, which looked at 15 states across India, the prevalence of prediabetes was reported to be 10.3% using the WHO criteria. It would be higher if we were to use the ADA criteria. According to the National Urban Diabetes Survey, which was carried out a little earlier, the prevalence of prediabetes in the urban areas at least was in the range of 14%. Another study which was looking at adolescent girls and boys in India showed a prevalence of 8.4% of prediabetes amongst adolescent girls and 12.3% amongst the boys. So showing that this is something which is starting off early with the changes in lifestyle, and we need to address it earlier, and if we need to prevent diabetes. So if you look at the important factor here is that while we speak about diabetes being about half of the people with diabetes not being aware about their condition, we could say that when you look at prediabetes, which is even more of an asymptomatic condition or more of a biochemical abnormality, we see that even in a country like US, where who spends a lot of money on their healthcare system, they find that 90% of their prediabetics are not aware of that they have prediabetes. So that is the need, showing us the need for greater awareness, greater education of the population, and also looking at screening for prediabetes so as to identify prediabetes early and take corrective action. Now, if you look at the pathophysiology of prediabetes, the pathophysiological defects are almost similar to what happens with what causes diabetes, but just a little about how the insulin resistance and insulin deficiency, which we conventionally say that the insulin resistance comes first, and then when insulin deficiency sets in, then diabetes comes in. But what has been seen in longitudinal observational studies was that beta cell failure and insulin resistance do not develop one after another, but they are concurrently present in the same individual. And all the pathophysiological abnormalities that we know of, which are contributing to diabetes, are seen in people with prediabetes, and all of them are shown to contribute to the development of prediabetes. One interesting observation which I would like to highlight here is the data from Professor Monier et al., who have shown that if you were to identify prediabetes earlier, and if you would like to look at identifying people who are going to progress, then looking at the 1 hour value on the 75 gram OGTT is going to be more helpful, because if you look at this, if you look at the figure on the left and look at the two middle lines, the dotted lines, you see that is the range of prediabetes, and if you look at the doing the fasting value and the 2 hour value, even in the one on the higher the higher line, you find that even those individuals would have missed out from the diagnosis of prediabetes if we were using the 0 hour and the 2 hours. But if you look at the 1 hour value, this individual crosses the cutoff that we're looking at 153 or 155, which is a good indicator to predict the development of prediabetes. And if you look at all the longitudinal studies which have clearly shown that this cutoff value of 155, above 155 at the 1 hour time point on the OGTT, gives us a better predictor of the development of prediabetes and progression to diabetes also. Now, if you look at the pathophysiological, if we try to differentiate between IFG and IGT, then certain things which come out is that if you look at IFG is more of a, if you look at the insulin resistance in IFG, it is mainly hepatic insulin resistance, and while if you look at IGT, these individuals are the ones who have more of muscle insulin resistance. And the timing of the abnormal insulin secretion is also different between IFG and IGT. IGT, in individuals with IFG, tend to have a early phase insulin secretory defect in the first 30 minutes, while in response to the OGTT, while those with IGT have both early and late phase insulin secretory defects. And hence they have differences in terms of their manifestations, their presentations. We could say that IFG is more common in men as compared to women. Younger individuals tend to have more of IFG, and older individuals tend to have more of IGT. High plasma triglycerides, presence of fatty liver is more of a common finding seen in those with IFG. Now, if you look at there have been several studies which have looked at the genotype associations, and they have shown several SNPs to be associated with the 2-hour post glucose load value, and also those which are associated with HbA1c and those which have been associated with BMI. If we look at the risk factors, we are all aware of the risk factors of which contribute to the development of prediabetes, whether it be the presence of the age, advancing age, presence of obesity, which is an important driver of this epidemic, then hypertension, dyslipidemia, female gender, presence of various factors which contribute to insulin resistance, and various inflammatory states are all contributing to the development of prediabetes. And we look at and accordingly the various screening criteria are defined for screening for prediabetes. And the interesting point is that here that we are seeing a higher prevalence of prediabetes even amongst adolescents and children, and therefore there is need to screen those with a strong family history of diabetes, those adolescents with a maternal history of GDM during the child's gestation, and those who present with signs of insulin resistance or conditions associated with insulin resistance, like hypertension, or those who develop hypertension, dyslipidemia, the adolescent girls who have polycystic ovarian syndrome, and those who are born small for gestational birth weight. And we have the ADA risk scoring system, and we have the risk scoring proposed by Professor Mohan et al., which is the Indian diabetes risk score, which has been validated across different parts of the country in different studies. And this is a very simple scoring system, and those who have based on 4 criteria, that is the age of the individual, the abdominal obesity, physical activity, and the family history of diabetes. And a score of more than 60 indicates a high chance of developing diabetes, 30 to 60 indicates a moderate risk, and less than 30 indicates a low risk. Now, if you look at the clinical profile of these individuals of prediabetes, they are at higher risk of cardiovascular disease, which is very well known to all of us. And the important point that I would like to highlight is that even microvascular disease tends to be seen in these individuals, although at a lower rates. The important reason for this is the clustering of the other risk factors, namely dyslipidemia, hypertension, obesity, all these contributing towards the increasing the risk for cardiovascular disease in individuals with prediabetes. And several meta-analyses have shown that approximately 20% increased risk of cardiovascular disease is seen in individuals with prediabetes. We have Indian data from the CURE study, which has clearly shown that the carotid intima media thickness correlates with the progression from normal glucose tolerance to IGT to the development of diabetes. And similarly, we see a rising rate of prevalence of CAD amongst the Indian population. Even the Nurses' Health study gave us similar data about almost a twofold increase, more than twofold increase in the risk of cardiovascular disease amongst those who had pre-diabetes. And after the diagnosis of diabetes, it goes up to about 3.7-fold increase. Prevalence of cardiac autonomic neuropathy is also seen to the extent of about 4 in individuals with pre-diabetes, although at a lower level than what would be seen in individuals with diabetes. So the contributor to this is probably the plasma lipid abnormalities, a high triglyceride, low HDL, and ApoE has been shown to be another good marker for predicting the progression from pre-diabetes to diabetes. And the linking factor between pre-diabetes and the development of the vascular events is probably the increase in free fatty acids, the increased visceral adipose tissue, increased RAS activity, and which are all leading to endothelial dysfunction and activation of the coagulation pathways, and leading to increased vascular events, and also a decrease in insulin sensitivity at the level of the muscle of the vascular endothelium also has been identified, and that contributes towards the development of cardiovascular disease in people with pre-diabetes. Retinopathy is seen to the extent of 8 to 12% amongst individuals with pre-diabetes, even in the DPP study, those individuals who did not progress to diabetes also had 10% prevalence of diabetic retinopathy, indicating the fact that that even at these levels of glucose level that was seen in pre-diabetes, there is an increased risk of retinopathy. Similarly, increased risk of neuropathy is also seen, and nephropathy also seen, although it did not go up to the level seen in patients with diabetes. So we know that if we look at the natural history of prediabetes, there is progression. There could be reversion of those individuals who become normoglycemic, and then there are those who continue to be pre-diabetic and they have cardiovascular disease and mortality from the cardiovascular disease. So if you look at the progression rates, they are different in different ethnicities. We see that Burma Indians have the highest rates of progression of 87.3 per 1,000 patient years of follow-up. Amongst the Indian population, Asian Indian population, we have seen that the prevalence rate was next to that of seen in Burma Indians, but higher than all the other populations. And this progression rate has been shown in different studies to be much higher than what is seen in other populations. And this correlates with the insulin disposition index, which becomes a good marker for showing for calculating the progression of pre-diabetes to diabetes. Are all pre-diabetics the same? Probably there we could classify these pre-diabetics into different phenotypes based on not only the clinical parameters, that is, we have simple parameters like identifying those with IFG, those who are diagnosed with IGT, and those who have a higher HbA1c. They could have different risks in terms of progression to diabetes, in terms of their cardiovascular risk for cardiovascular disease, in terms of the risk for chronic kidney disease, or in terms of the all-cause mortality. And different factors could be added on to decide, to put them into a low risk phenotype. This is one which restores back to normoglycemia with lifestyle intervention, while the high risk phenotypes are the ones which do not restore back to normoglycemia but progress to develop, or either persist as pre-diabetes or progress to develop diabetes. So these are the ones who need to be focused on, and therapeutic interventions need to be directed to these individuals. And that is the reason why this sort of stratification or phenotyping of pre-diabetes may be helpful. One interesting observation is that brain insulin sensitivity is also another factor which contributes to the visceral fat deposition. A lower insulin sensitivity, brain insulin sensitivity, contributes to higher visceral fat deposition. And these clusters, there have been 6 different clusters identified based on these parameters, based on all these parameters, and these clusters have different risks for progression to diabetes, as I've just mentioned. And this is graphically shown in this cartoon. So, could we use any biomarker to identify this? Several biomarkers are being studied: adiponectin, IL-6, PETUNA, FAB4. All these could be potential biomarkers, but we need more data on this to identify a simple biomarker which can predict the progression of prediabetes to diabetes. Now, coming to the therapeutic interventions quickly in the next 3-4 minutes that I have, I'll highlight about the therapeutic interventions and what needs to be done. How do we need to choose individuals who would need pharmacotherapy? Although we know that we have a lot of robust data on the lifestyle interventions in terms of preventing the progression from pre-diabetes to diabetes. We have the different studies, the DPP study, the Indian DPP study, the Chinese studies, the Finnish study. All of them have shown close to 50% reduction. In the Indian DPP study, however, we saw close to about 28% reduction in the progression with lifestyle interventions. And as you can see here, this cartoon illustrates the extent of the reduction in the progression which was seen with various lifestyle intervention studies. There is a very recent study also looking at stratifying those with high risk and providing them more aggressive lifestyle intervention as compared to the lower risk individuals, and this study has also shown the PLI study, which has also again shown that there is a good evidence for lifestyle intervention, helping even the high-risk individuals, particularly when they are directed towards with a more aggressive lifestyle intervention. And restoration to normal glycemia has been shown to reduce the prevalence of microvascular disease and the CV risk factors, despite less use of medications to lower lipids and blood pressure. So there is benefit of restoration to intervening early and trying to restore them to normal glycemia. We have data on different pharmacological agents. You can see the entire list here, and the rates, the reduction in progression of to diabetes was variable with different agents. As you can see, the greatest results we've seen with glitazones and also with anti-obesity medications, which have shown, and also medications like liraglutide has shown a very good reduction in the progression to diabetes. Tirzepatide is another drug which is on the anvil and which has also shown a good benefit in terms of reducing the progression. And early intervention is therefore helpful in preventing the development of complications. Who requires pharmacotherapy? Drug therapy can be instituted in people in persons with pre-diabetes if there's a high risk of developing diabetes or its complications. That is, if you are able to identify the multiple risk factors or phenotype them into the high risk category. Those who are unwilling to modify their lifestyle, those who have presence of symptoms of hyperglycemia in the form of either weight loss, asthenia, and those who have the comorbid conditions which can be resolved with hypoglycemia, like development of foot ulcer, or so in all these situations, pharmacotherapy may be needed. And today we have the approved pharmacotherapy in prediabetes, at least, is with metformin. And metformin in the DPP study has been shown to be particularly helpful in those pre-diabetics with a BMI more than 35 kg per meter square, those who are younger individuals less than 60 years of age, women with prior gestational diabetes. And here in all these, metformin may reduce the risk of progression from pre-diabetes to diabetes. And it has been used where lifestyle has been ineffective in reducing body weight and improving glucose tolerance. So in addition to all these measures that we take at the patient level, at the provider level, we need to educate the providers across the region to improve their awareness about prediabetes and screening for prediabetes, so that they can screen their patients and they can educate them about this. But there is also need for carrying out advocacy at the level of the government and various other agencies, so as to bring about a change in the lifestyle of individuals, which is very difficult to bring about, and we need to work at different levels. We have been doing that. We have initiated. We have for the first time identified August 14th as the World Pre-Diabetes Day, and you can see we had a interaction with our past chair, Dr. Shashank Joshi, was in conversation with the IDF president, then IDF president, on the International Pre-Diabetes Day last year. And so I think I would like to summarize and conclude by saying that pre-diabetes is rising at alarming levels across the globe, and also in our region, Southeast Asian region. The conversion rates from pre-diabetes to type 2 diabetes is very high amongst our population. Individuals with clinical risk factors for pre-diabetes can be screened using simple scoring systems like the IDRS screening tool. The risk for microvascular disease starts at the stage of pre-diabetes, as it increases the risk of CVD events, myocardial infarction, stroke, and death. Pre-diabetes has also been linked to retinopathy, neuropathy, and nephropathy. Management of pre-diabetes is multidimensional, with not only lifestyle interventions but pharmacotherapy, but also psychological support to the individual and education. Future efforts in the direction of identifying a easily measured biomarker that can predict the risk of progression is going to be something which we are all looking forward to. With that, I would like to conclude by saying that pre-diabetes is indeed a window of opportunity. While it is associated with the host of metabolic abnormalities, but it gives us a window of opportunity to prevent diabetes, and this is where we need to act and take and work towards preventing diabetes. Once again, I would thank the chairs, the past chair, the present chair, and the chair-elect for inviting me to this important event. Thank you all.
Thank you, sir. It was an excellent presentation. And I think everything was covered in pre-diabetes. And we will be looking forward to a few questions. Yes, do you have any question in the chat box or should we go ahead? Dr. Ghosh? Yeah. Do you have any questions?
Since there's no question in the chat box.
Okay. So are the speakers there or? Can we ask few questions? Do we have the time?
Yeah, I think we still have another 10 minutes if we need to have some discussion.
So, my question to Dr. Shah is, I know there are not much of guidance as far as the molecular therapies for pre-diabetes is concerned, excepting metformin. Where would you place imeglimin, if at all, as a molecule for pre-diabetes?
So we had a recorded talk of Dr. Sai. So Dr. Sai is not available. Only ma'am is present over here, so you can ask the question.
Okay. So Dr. Shrestha is there? No.
No. Her talk
we only
also
have Dr. Matthew from.
Dr. Matthew is there, right?
Yeah.
I have a query for excellent talk, ma'am. I'd just like to know whether oral semaglutide, does it has any role at present in established atherosclerotic CVD?
Yeah, that's a very good question. So oral semaglutide is the same molecule as the injectable semaglutide, of course. But at the moment, there's no evidence to say that one is better than the other, but the evidence is stronger for the subcutaneous Ozempic product. So whereas the oral semaglutide is a very elegant way to administer semaglutide, it does come also, at least in my country, with a big price. But so considering the fact that it is the same molecule, we brought together all the evidence for the molecule semaglutide when making our decision. And so we chose to delete injectable or oral and just have the molecule.
Absolutely. So basically, suppose we have option of injectable and oral both together at our place, and we have a known atherosclerotic CVD patient. So in that case, should we go for a straightforward advocacy for injectable one rather than the oral?
I think you need to talk with your patient, and it sounds a little bit soft, but it is what it is. If a person says, go away with your needle, I will never inject, then it's not worthwhile. Or if a person says, these pills, I already take so many pills and I will not wait half an hour after I take my pill in the morning before eating, etc., then the oral form is not a choice. So it is really depending on the person sitting in front of you. I have patients preferring an injectable once a week done. And then I have people who say, I'm afraid of needles. And there the oral semaglutide works very nicely. But you need to take care of really taking into account all of the requirements of this oral drug. You have to take it with a limited amount of water. You cannot eat half an hour or take other pills half an hour after taking the pill. So that's a bit more hassle. But in people who do not want to inject dulaglutide or semaglutide, I think it's a very good alternative.
Thank you, ma'am. Do you have any preferences as far as SGLT inhibitors are concerned if a patient comes with preserved ejection fraction?
Yeah. Again, for heart failure, there it's clear, and protection for hospitalization for heart failure, there it is clear they behave like a class. And even ertugliflozin is also showing benefits for hospitalization for heart failure in people with type 2 diabetes. This being said, the evidence of ertugliflozin is a bit confusing with the VERTIS study, where it was not so convincing as was the EMPA-REG data or the DECLARE data or the CANVAS data. So ertugliflozin is a little bit more on the side, because also now for the real heart failure studies have been done with dapagliflozin and empagliflozin. The real renal protection studies have been done with canagliflozin and now with empagliflozin and dapagliflozin in people without type 2 diabetes. So I think it's a class effect, especially on heart failure. But of course, when you have the choice of agents, I would propose you choose those where you have the evidence.
Right. Any other questions, Dr. Ghosh?
No, it's fine. Like the sessions are very interactive. And only thing I just want to know about the ESD, their opinion, and ESD, their opinion on hydroxychloroquine. Because whenever we say about diabetes, we talk about insulin resistance. There are some data saying about the role of hydroxychloroquine in reducing insulin resistance. So can you give your opinion regarding that, ma'am?
Yeah, I cannot give ESD's opinion because we don't have any statement on that. I can give you my own opinion. I think the evidence base is small and have, again, I always tell my Indian colleagues, you have so many people you can study. You can set up very rapidly a robust study that would give you the data to convince everybody. So ESD for sure doesn't have an official statement. I personally think there is some evidence, but please do the study. You can do this. You have the number of people to give the answer.
Great, ma'am.
Thank you.
Thank you.
I think we can close it.
Yeah, we can follow the session for the next.
Thank you, ma'am, once again.
Bye-bye.
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 So to carry on the next session, we are handing over the session to Dr. L. Krishnamurthy from Bengaluru and Dr. Bhumi from...
So we have Dr. Vishal Vaidya over here. The next chairperson is not available. So Dr. Vishal will carry forward the next session.
Okay, yeah. So the session is all over to Dr. Vishal Vaidya. Thank you.
So the next session would be chaired by Dr. Perry. We have a recorded by Dr. from Luxembourg. Dr. Karim, she is MD, PhD in Rotterdam, Netherlands. She participated in the creation of multidisciplinary team DECCP for the care of children and adults with diabetes in Luxembourg, a dynamic and international team. She received several research grants from EU, European Union, interregional and international funding structures. Research topics of the team include epidemiology, technology in diabetes care, and pathogenesis of type 1 diabetes. She published more than 160 publications in peer-reviewed journals and several chapters in the books. Between 2012 to 2016, she was Secretary General, and currently she is the President of the prestigious International Society for Pediatric, Adolescent and Young Adult Diabetes. This is only global scientific society with a focus on all forms of diabetes in these age groups. Through ISPAT, she has been able to meet with and been motivated by many colleagues and persons with diabetes around the globe. One of the focus areas in her presidency is education and development tools to facilitate and improve education in diabetes. So over to Dr. Karin. I think we will be having a recorded lecture. Dr. Karin's recorded lecture.
Dear colleagues, dear friends, it's a great pleasure for me to join, even if it's in a pre-recorded version, this meeting and to share the presentation I have given at the IDF meeting. Transition from pediatric to adult diabetes care is something occurring everywhere, and I think the slope is still pretty slippery, and we should make it more smooth. I'm Corinne de Beaufort. I am past president of ISPAT, and will try to share my slides, which apparently does not work. So now it seems to work, but there is a slight delay. So just a short word on ISPAT, the International Society for Pediatric, Adolescent and Young Adults with Diabetes. As we want to create a better world for children, adolescents and young adults, this transition period becomes extremely important. And here, regretfully, there is a change in the position of the circles or the ovals. And maybe that shows already that there needs to be improvement in how we address this and how we shape the future of diabetes in young persons by improving the transition from pediatric to adult care. For this, we need the three groups: pediatric teams, persons with diabetes and their caregivers, and of course, the adult teams taking care of young people with diabetes. So the learning objective of my talk includes that the change from childhood to emerging adulthood involves major changes, physical, sexual, psychological, but as well social development-wise. And we need to organize a structured transition because that should and might minimize and prevent loss to follow-up, something really important in this phase of life. Finally, if you have a look at the data, I think we need to have more long-term outcome data in order to be able to support best practice in this field. So the changes, physical, sexual, psychological, and social, are very important to consider. It's not only the physical ones, which are initiated by changes in the hormonal axis, at two levels, of course, androgen-wise and gonadotrophin-wise. And this is listed on this slide, in which I will not go into detail, but which is important to be aware of with respect to the consequences abnormalities in either axis might have on the development of pubertal changes. But let's certainly not forget the major changes adolescents go through at the level of their brain development. Neurotransmitter changes, emotions, which are the limbic regions, maturing earlier than the frontal regions, the frontal lobes, leading to some changes or disbalance between emotions and planning and self-control in decision-making. And of course, it varies in one or another person, as we all know. There is this change in the affect regulation, integration of cognitive goals and emotions. the increased activation of the amygdals, sensation-seeking, affective imbalance, hyper-responsive, and a higher risk, of course, of addiction. There is an increase of emotional disorders in adolescents. This disbalance, affective disbalance, is important to consider. These data are based on and modified a little bit on the presentation of Karen Lange, psychologist from the Hannover team in Germany. So I think we all know the fantastic clarity around the emotions of adolescent sentiments. Even if some of the words are in French, I'm sure you can identify despair, love, revolt, happiness, and enthusiastic emotions expressed by the young adolescent. They focus on their body changes and function, the development they have to go through to identify themselves, their identity, their gender role, the love relations. And it's not the other parents anymore, which are going to be the most important, but it's the peer group. And they want to become from dependent, independent, and sometimes are not always as ready as they think that they are. So who am I? And am I normal when in this phase I am faced as well with a chronic condition? Working with adolescents with or without chronic conditions absolutely necessitates to take into consideration these topics listed on this slide. These are key issues for them, not only their chronic condition or their diabetes, their peer relationships. Are they perceived differently with their diabetes? Sexuality issues, eating patterns, substance use and abuse. We need to make it something which we can discuss with them. Injury and accident prevention, the mental health issues, and also their view of the future. How is their work going to be influenced with their studies based on the fact they are faced as well with diabetes? Helping them to access support groups is something very important, and that has been demonstrated by different support groups, to mention one, DDoC. Now, this is the very beautiful drawing, and one of our persons with diabetes, made for our drawing competition in Luxembourg. And you can see the many different issues that are working when you're diagnosed with this condition. Why? Why should I have it? I don't want this. I didn't do anything wrong. I want my own old me back. I don't want to live with this shit insulin, and so on and so forth. And then adolescents. In the past, very often there was this transfer from care, pediatric care to adult care, age 12, 15, 18, fixed age. And this was in the middle, or is, where it's still organized this way, in the middle of this massive change of emotions, in this chaotic period. Is that wise? Because let's be honest, non-adherence in a chronic disease, and certainly in diabetes, may lead to treatment failure, decreased quality of life, increased risk for chronic complications, and as such, an increased healthcare utilization. For all age groups, from the young age to the very old, good metabolic control remains our target. As much time in range, maybe we need to discuss in future. The normal physical, as normal as possible, and psychosocial development, and optimal quality of life, despite the challenges diabetes is bringing with it, and prevention of acute and late complications. And we know that a good metabolic control is needed from diagnosis onwards. There is a difference, even 25 to 30 years after the difference in the DCCT treatment groups. I think we're all aware of intensive treatment, conventional treatment, even if you have to say that the intensive treatment at that period of time was still definitely not as intensive as we consider now intensive treatment. So differences between pediatric teams, family-focused, friendly, we think we are, well known to the families for years, and we know the families for years. we might have a little bit of maternalistic or paternalistic approach. And then we've got the adult teams. And by nature, they've got different pathologies, different approach. They consider that the patient should have autonomy, independence. They are less personal, which is, considering their patient population, totally appropriate. And if patients are not adherent, it's not always their problem. Whereas as a pediatric team, we might consider it partially our problem. So now if we discuss transition of care from adolescence to adulthood, we should be able to guarantee continuity of medical care and provide ongoing good quality of life for young people with chronic conditions. And with young people, I do indicate youth where brain maturation and physical maturation are evolving, haven't finished when you start transiting at 15 or at 12, or with respect to brain development, even before 25. We need to ensure that these young people cannot opt out of both systems, only to reappear in an adult system in crisis with complications, be it acute or chronic ones. Now, in an integrative review, they discuss different points: the timing of transition, the way transition is perceived, be it by pediatricians or pediatric teams, excuse me, it's not the doctor only, it's the team, adult teams, or by the young people and its caregivers or parents. Just as important, it's the group of 3 units who all need to be ready. And we have to prepare. You don't throw them out at a certain age. You need to prepare them and see whether the maturation is sufficient. We need to evaluate and follow up what happens after transition, and not, if the first contact wasn't optimal, let them go. We need to identify the barriers at all 3 levels and facilitate factors to make sure we prepare it all as good as possible. Now, on transitions, there are different papers, systematic reviews, Cochrane analysis. And to be honest, I think there are still not a lot of papers showing us the long-term outcome, which makes it difficult to impose a certain recommendation and approach. So there is still scope to evaluate the models of transitional care. Very interesting was one of the reports from the Dutch group on the Loes van Staan 2011, where they really said key to success is take into account the adolescent's attitude, what they want to. Of course, we can't keep them until 40 years, as might have been done in the past, because as pediatricians, we're not competent anymore for that age group. But we need to ensure that they've got a level of self-efficacy in managing their condition. An interesting paper appeared in 2022 and showed that the longer gap between the pediatric and the adult visit led to more emergency department visits. Older age at transition showed and was associated with less emergency department visits and diabetes-related hospitalization. Very important point. Risk for a prolonged gap in care was absence of a mental health care provider in the pediatric team. Other very interesting observation was absence of hyperlipidemia. So was this consideration that they knew more about their condition? Interesting about this observational study is that it included the longer period of time and therefore might hint at where we have to focus on. So who should be involved around this table? Adolescents, primary care physicians, because sometimes they might take over care. Pediatric subspecialists, adult subspecialists, team members of multidisciplinary teams, family members, sometimes service commissioners, and all together we should try to make a systematic and formal transition process. Start early with preparation, 12, 14 years. Include transition coordinators, someone who is following whether the maturation of the young person, the readiness of the young person and its family is sufficient to go for a change of care team, there needs to be a good communication between and collaboration between healthcare professionals, adult and pediatric. We need to know where we stand, what we propose, and harmonize our approaches, even if we are not identical, which is normal. It should be an individualized transition plan, and definitely we need to enhance self-management. And do not forget to have an active follow-up after transition. So when, at what age, and when should one start to prepare, and how? I think we really need to include those points in order to identify best practice in transitional care. And it will not be the same in different regions around the world. And in an old paper, 2010, we published at that time approaches in care. And you can see some had no transition, other had a market meeting with all the adult doctors and the young people could choose. In others, that was just with shared consultations, which was really good, perceived. Web-based preparation with special programs. I think it's important to evaluate what the effect is and what the impact is and how we can prevent dropouts. The National Alliance to Advance Adolescent Health Care Transition states that you really have to get a structured program or transition or care policy. You need to track, comes back every time and again. You need to track what happens and monitor whether they are still being followed in the other unit. We need to evaluate transition readiness and orientation to adult practice. And the same goes for that planning. It really needs to be something structured. And then after transition and or the initial visit at the adult team, we need to identify whether the care is really taken over and whether he or she is well integrated in the adult unit in order to let go and say, okay, this is going to be last visit in the pediatric and an ongoing follow-up in the adult care. And let's not forget that diabetes is a chronic condition with a lifelong, with consequences if we have not ensured a proper transition. So let's communicate to coordinate and minimize care and minimize gaps. Let's try to evaluate and assess as good as possible knowledge and skill to take care of themselves, because then that will help the adult provider to see where further interventions might be needed and what the strengths are of one or another young person. And we need to focus on relationships, not on HbA1c. That's only one part. As I mentioned several times, we need to have a strategy and a structure to identify and address the psychosocial needs, very important point in this age group. And a team-based approach can help young adults to stay aligned and collaborating within the team approach of the adults. So my take-home message is there is no rigid age, there is no perfect method yet. It needs to be made to measure for the individual, and continuity in care is vital. Harmonious approaches between pediatric and adult teams, written summary for teams and persons with diabetes, and a long-term follow-up in order to make sure that it's not only one visit, but a good transition into the next care system. Teamwork, key point. And here I would like once again to state seamless, coordinated, developmentally appropriate, psychologically sound. And then we are successful in what we can offer to the young people. Thank you very much.
Thank you very much. And that was Dr. Karen. I think Dr. Biswajit is there. So that was Dr. Karen who's spoke about the transition in diabetes care, whether it's smooth or slippery. I'm sure all of you have understood that it's one of the difficult and organized manner, and the teamwork is a must to have this transition. And next we have Dr. Thomas Dane from Germany, who's going to talk about from research to care in pediatric diabetes. And Dr. Thomas is a professor of pediatrics, diabetes and endocrinology, and he's the chairman of the SWEET project and is a past president of the International Society of Pediatric and Adolescent Diabetes, that is ISPAD, and of course German Diabetes Association and the German Diabetes Aid. He's a former research fellow of the Joslin Diabetes Center of Harvard Medical School in Boston, and he's a recipient of the Lifetime Achievement Award of the IDF. Over to Dr. Thomas, please.
Hello, my name is Thomas Dane from the Children's Hospital auf der Burg in Hanover, Germany. And it's a pleasure for me to talk to you today about from research to care in pediatric diabetes. It is about novel tactics for precision medicine in diabetes. These are my disclosures, and I want to take this opportunity to invite you to the ISPAD 2023 meeting in Rotterdam and the 2024 meeting in Lisbon, Portugal. Now, we have encountered a paradigm change in pediatric diabetes because we understand that although the disease became treatable in the year 1922, when on January 11th, Leonard Thompson received the first successful insulin injection, we know now that type 1 diabetes is really not one disease entity, but really it's like apples and oranges. There are different ways how you are developing type 1 diabetes. There's an autoimmune disease long with several stages before the onset of symptoms, and these different stages might be different in different people, and obviously we need precision medicine to treat this appropriately. And it is important really to look into type 1 diabetes. You can see that really in all age groups, this is from the SWEET registry, and I want to thank many of my Indian friends who actually supported the SWEET registry with lots of data, that we can see that also during the COVID years, we have a big increase in the numbers of children with type 1 diabetes in all age groups. So it is really rising in over time. And we understand through research that type 1 diabetes is an autoimmune disease where there is a damaging event that initiates the release of antigens from beta cells, creating a pro-inflammatory environment that exacerbates the beta cell damage through antigens that are activating autoreactive T cells. And if this whole process is happening, the damaged beta cell will end up to decrease their insulin production, and in the end of the day, it might even then completely stop producing it and be a dead beta cell. So is there any way that we can actually look at this process? So there is in the beginning an autoimmune trigger, and antibodies appear in the blood that we can kind of predict who is developing type 1 diabetes. And already at stage 1, where there are no signs and symptoms of type 1 diabetes, we know that somebody who has multiple antibodies, 2 or more antibodies, will eventually develop type 1 diabetes. So we can diagnose type 1 diabetes much earlier than we were previously able. And then we're developing stage 2 diabetes, where there is not only the antibodies in the blood, but already the process of the disease has proceeded so far that there is dysglycemia. And I will show you in a minute that we have now new treatment options in this time of this stage of diabetes. And what we have known for quite a long while is, of course, stage 3 type 1 diabetes, where there's hypoglycemia, hyperglycemia, where the symptoms of diabetes are present, and where we need to start exogenous insulin. But clearly, this understanding of research that type 1 diabetes starts much earlier than the typical symptoms gives us new opportunities for care for children with diabetes. And the first drug that has been approved by the American Food and Drug Administration is teplizumab. And this has been approved from age 8 in people with type 1 diabetes in stage 2, meaning they have multiple antibodies, they have dysglycemia, but they do not have the clinical symptoms and hyperglycemia of stage 3 diabetes. And this is on the basis of this study, which has been published in the New England Journal of Medicine in 2019, and more recently, the update has been published in Science Translational Medicine in 2021. And you can see that in those 44 people who have been administered with teplizumab over a 14-day period, so only an infusion of 14 days was tested here, and then people were actually followed up, and it was looked when diabetes was occurring, the clinical diabetes diagnosed according to the guidelines, and this was compared with placebo. And basically what the teplizumab is actually doing, it is changing by really working with the autoimmune process to preserve the beta cell function and stabilize the insulin production by really changing the balance of the immune system again, and thereby preserve the insulin production. And what this ends up to is that in the extended follow-up of the patients, we can see that up to 3 years, 2.7 years on average, but some people even had a 10-year delay of their diabetes when they got teplizumab. So there's an average 2.7-year delay in the onset of clinical type 1 diabetes. So it did not move from dysglycemia, which does not need insulin, to the stage which is needing insulin. And this data has then been checked by the Food and Drug Administration in the US and said, yes, this is the first immune modulatory disease-modifying therapy. So we are moving away from research to care by actually not only treating diabetes by substituting something in form of a metabolic disease, but actually, as this is not a metabolic disease, but rather an autoimmune disease, we are now treating this disease by interfering with the autoimmunity first. So this is really a big paradigm change in the treatment of type 1 diabetes. Now, obviously, we have the problem. How do we identify those people before they have the signs and symptoms? As up to 85% of the individuals with type 1 diabetes do not have a family history of the disease. And so we need to start to work in having a population level screening. And we understand that these antibodies are actually appearing very early in life. Already 80% of the children develop insulin antibodies before age 5. And the development of 2 or more antibodies confers the risk of 50% of type 1 diabetes before age 5 and 80% before age 15. So we have to start early to do this population screening. And so the concept now for the personalized medicine means we need to have early detection. We offer then immune modulation. If this doesn't work, the best way to date to treat type 1 diabetes, and I'll show you in a minute, is automated insulin delivery using artificial intelligence actually to treat type 1 diabetes. Here you now see the screening that we are doing in Germany. There are 3 federal states of Germany where this can be done. It started in Bavaria and Lower Saxony and also Saxonia now. And by taking blood samples of children, and we have tested close to 200,000 now, we can able to identify children with multiple islet antibodies. And as soon as teplizumab would also be approved in Europe, this would be then a treatment option that we can give them. But before this improvement is in place, we are now giving them also the opportunity to participate in other research trials, because as you will see in a minute, it's probably not that teplizumab will work in everybody. We will have to find other drugs and drug combinations. So we now have the first possibility of immune modulation, which will help us to delay stage 3 diabetes. But if we are preserving the beta cell function, it might also help us with the other treatments of type 1 diabetes, which come later on. For example, automated insulin delivery, but also injection therapy. When you have more C-peptide, the treatment will be much easier. And C-peptide is now the new marker to see how good a certain immune modulatory therapy is working. If you have more than 1,000 picomoles, then you are insulin independent. If you have more than 200, is still able to improve the glucose control. Even a little amount, like 5 picomoles, are associated with a reduced number of hypoglycemic events. So it makes a lot of sense to preserve C-peptide through immune modulation. And there are now a large number of potential treatments that are there, those which have a higher relative risk, obviously also have a higher likelihood of benefit. But in the very young children, you might consider to use intervention that is less riskful. And so there are many, many different trials which are now developed to make a difference. And thereby we have to understand that we have to characterize the patients much better, because the better we understand which patient, which genetic basis is there, and which genetic basis will help to work with an individual therapy. Like in cancer therapy, we will have combination therapies that are targeted to the individual child with diabetes in order to preserve the beta cell function. And we have a big platform in Europe, and we're trying also to collaborate outside of Europe called Enodia, where we are using a master protocol so that we can compare one trial with another. We are using the C-peptide and using the grouping of the C-peptide to see how things work. And then we have different data in labs from, for example, lipidomics, transcriptomics, and proteomics data to analyze really the difference between the patients and understand the latent factors and the other things who might modify the disease activity and respond to certain types of therapy. So we are now in this complex model of immunology, testing 4 different approaches, 4 different medicines, which are really targeting different places in this immune system, in this autoimmune process, and hope to find the best individual treatment, the best combinations in the long run. Now, if we look at this whole picture, we have the GPAD initiative, which is a global initiative trying to identify direct at birth. We have Enodia, who is using the antibody treatments to have treatment in stage 1, 2, and 3 diabetes with immune modulation. But we are also making big improvements in the automated insulin delivery. And if we see here that the first, this is the first trial where automated insulin delivery was studied outside of the hospital. It was a multi-center trial in Israel, in Slovenia, and Germany. And you see how different children are. It is important to have these studies in multi-center trials to see that. And with the help of artificial intelligence, with the artificial pancreas, we were able in these camps, and you're also doing a lot of camps in India, you know how much the risk of hypoglycemia is higher in those children that are running around in the camps. But with artificial pancreas, we're able to reduce nocturnal hypoglycemia after such a busy day. This was the first step, but it took actually quite a long time to convince people that really every day, every night has a different insulin need. And so it makes, of course, a lot of sense to use these automated insulin delivery devices, because we cannot tailor it so perfectly with an injection therapy as with automated insulin delivery. But this system that we actually published in 2013, it took until 2021, when a system with automated correction boluses and with changing the basal rate depending on the insulin and the glucose levels was actually commercially available. And you can see that every new iteration of such an algorithm change always leads to an improvement in time and range. So again, we can expect also in the future more and more improvements in this area. So does that also only work in adults or in adolescents? No, you can see here another study that both in preschoolers as well as in school children, we are able to have these improvements with technology. So also very young children are able to improve their glycemic control with the help of such a device. And there is really no age limit for these technologies. And if we take a look how this is for the long term, this is data from the French study, where they presented at the ISPERT meeting in Abu Dhabi the results, the long-term results. And you see that very early in the trial with automated insulin delivery, they had to stop due to COVID and things with the algorithm for a certain period of time. So we have an improvement. They had to stop the automated insulin delivery immediately. The improvement goes away again. They could restart the trial. And then over a long period of time, really the results remained very, very stable. They had a sustained effect after 2 years with a time and range very close to the target of 70%, no severe hypoglycemia. So we can really see from these French results that there is reason to believe that this is a sustainable improvement. Now, what is also quite interesting is that to look at the differences between countries, because previously we see on the left side that A1C analysis show big differences between countries. Always the people in Sweden can report very, very good average A1Cs, although they also have, like everybody else, the higher average A1Cs during adolescence. And in England, usually the A1Cs tend to be a bit higher on average with the same curve, basically. But on the right side, you can see the first data on the comparison of automated insulin delivery in different countries. And you see there is no longer a big difference. So really, technology is able to kind of make the differences between countries much, much smaller. So parents and patients from different countries are able, with the help of technology, to have very, very similar results. And we also see that we know that there is a social gap. So people with more difficult social circumstances used to have worse control compared to those who come from more affluent surroundings. But also, again, with technology, those differences are going to be smaller. So this is really another sign how the research is really influencing care. So a summary was done from one of the editorials saying, with these new ways of treating type 1 diabetes, we're not only reducing caretaker burden, but we're also protecting the young brains, because we understand now that hyperglycemia is so important for the brain development, much more than hypoglycemia. And this is also a paradigm change in our thinking of pediatric diabetes. So shall we do it from the very onset of a disease? This is a study using automated insulin delivery from the very beginning. And you can see that there is more than 10% difference in the time in the target range. The curves tend to separate more and more over time. So we can actually say that if this would be possible, why not start automated insulin delivery from the very beginning? Now you can say, well, what does it cost? What shall we do? And clearly, I think if we, for example, see how the cell phones become more and more available around the world, this is also technology just like the closed loop insulin pumps. I hope very much it will be possible to give more and more people such a technology, because it's likely to improve outcomes quite a lot. So if we look at the current principles of therapy for care, if we have a resourceful environment and we can choose for different therapies, if a patient is not reaching the treatment targets and they want to change their insulin therapy, and it is possible to give them something like an automated insulin delivery device, then I think we should do this. And if we look at the current research, again, if there is a patient who has dysglycemia, who has multiple antibodies, I think also they should be informed about the possible new approaches for the treatment of type 1 diabetes, if this is available in a resourceful environment. And if the family wishes to participate in immune modulatory trials, they should make aware of that and be pointed in this direction. So if we look back over those first 100 years of treatment, we see on the left side Theodore Ryder, one of the first patients. You can see him, how he would be very close to dying in the very left. Then he was a chubby child getting insulin, and he was without major complications for a very, very long period before he passed away in 1993. And I think if we look at the children now, here we see the first pump patients that we had in 1999. Then we started the closed loop in 2011. And now in 2020, we are offering to all our patients the possibility of participating in immune modulatory trials. I'm pretty sure that the future is close to have appropriate diabetes management with precision medicine and artificial intelligence. And this is the future, as we really have to find a good daily profile that you can change to every child, adolescent, and family, and express their appreciation. And if possible, with the resources to use the modern ways to achieve very, very good results. Greetings from our team in Hanover, and hope to see you soon in person. Have a very good day and a good conference. Thank you very much for your attention.
Thank you, sir. Thank you. And that's very promising to see that the bench to bedside, what we see, how the research is transforming the type 1 diabetics. Dr. Bishwajit is around, sir?
Yes, Murthy, I'm here, but
yes,
keep
sir.
Going. Yeah.
Sir, you can introduce Dr. Philip, sir, for the next talk.
I think you can going, because I'm lucky, as because I got opportunity to work with Professor Philip Home.
Okay.
I had been in the Newcastle in 2003 to 4.
Please introduce. You are the better person, sir. Then you know him.
So everybody knows Professor Philip Home. He is the past president of IDF Europe and past president of the IDF and also the IDF Europe. And he is the president in the Diabetic Federation, emeritus professor. So he also, I think he doesn't need any introductions. I think I'm requesting Professor Philip Holmes to start his deliberation.
Thank you, sir. Please.
Thank you. So I need to share my screen. So, and I hope everyone can now see and hear me adequately. It's good to be with you in the subcontinent again, even virtually. This short talk invited by IDF is biosimilar and biobetters in diabetes, the evolving landscape. I do have dualities of interest, and I show them here. They include virtually all the manufacturers of insulins of these kinds. If we think about what a biosimilar is, then there is a standard definition as an improved biological medicine intended to be the same chemical formula or structure as a reference already marketed medicine and demonstrated to have similar properties by direct comparison, particularly in PK/PD studies, but also in limited preclinical and clinical studies. And of course, the intended advantage here was in cost saving. That saving comes from two areas, really. A carryover of safety assessments and dose finding from the original reference biological. And that means a huge saving in terms of the costs of development of a new insulin for a biosimilar compared to a original. And secondly, of course, it breaks the monopoly and therefore allows competitive pricing. Now, in diabetes, we use a lot of different medicines of biologicals. I've listed some here. And today I'm going to concentrate, of course, on insulins, but GLP-1RAs, anti-VEGF, and erythropoietin are other examples. Biobetters, by contrast, don't have a standard definition. They're not a pharmaceutical category which is recognized by regulators. And this definition is minor modifications of existing biological medicines with the intention of improving disposition, safety, efficacy, or even just manufacturing attributes. And of course, the intention of the biobetter then is improved efficacy, safety, or tolerability. In fact, it's not as simple as that either. If we actually look at the different categories of insulin available to us, they're more than just biobetters and biosimilars. In many countries, we have copies available. These are often less regulated, new manufacturers coming to market with an insulin, but without the PK/PD studies, etc., for a biosimilar. Recently, we've seen duplicate branding where the same company, for example, Novo Nordisk in the US, manufactures the same insulin and sells it under two different brand names. We have the biosimilars, and of course, insulin glargine, insulin aspart, insulin lispro in particular, many of those under development. And then we have biobetters by formulation, such as insulin glargine U300, faster aspart and faster lispro, and we'll see there are other developments underway. Also under biobetters, however, we have new entities. And of course, you can go back to the original MPH. That was a biobetter when it was first marketed in 1948. But the first insulin glargine, detamir, degludec, aspro, lispro, etc., are all new entities, but biobetters compared to the human insulin from which they're derived. And we have new ones in development. And then we have a group of insulins which are called hybrid, of which particularly I think oral insulins we would note. So biobetters is a modification of existing biological medicines with the intention of improving those things. But you can ask what modification defines a biobetter. Is it structure or formulation? How does it work? And I put those history up here to show that. Clearly, you're moving from recrystallization of insulin in the 20s to single component insulin from 1970 onwards. That's a purification step. It's not a new entity. It is, in a sense, a manufacturing step or formulation step. But the move to human insulin was to a new structure of insulin and a new manufacturing process. And clearly that requires a lot more in the formal development process and regulation. And that's true also of going from human insulin to mealtime insulin analogs. And that was shown by insulin X10, an analog which proved to be carcinogenic in rats. But the move from mealtime insulin analogs to fasting-acting analogs is only, in inverted commas, formulation. And the move from faster-acting analogs to even faster-acting analogs, which I'll discuss shortly, is again a formulation change. And clearly the amount of regulation that's required in moving, whether you've got a new drug entity, structural change, is different from formulation change. Manufacturing change will require targeted safety assessment as well. Formulation change, however, using non-novel excipients allows a development process similar to that of biosimilars. So again, the term biobetters breaks down with time. If we look at examples again of basal insulins, then new entities were insulins, detamir, glargine, and MPH. Insulins, degludec and isodec are new novel acetylated entities. And again, it's not predictable what that might mean. And that's true too of Lilly's insulin FC. But insulin glargine U300 was really just a formulation change. And a lot of the safety data from the original Lantus could be carried over. So let's look at some things related here to biobetters. We see here the improvement you get postprandially with the faster Lispro compared to ordinary Lispro. And you can show similar data for insulin aspart. Note also, though this is very much better, not best, the excursion here is still of the order of 4 millimoles per litre after meals. That's still grossly excessive compared to normal physiological glucose excursions after meals. So far, so good, but if we actually look at what's happened in practice, it isn't so good in terms of the major regulatory outcome, which is, of course, HbA1c. In this right-hand column, you can see the gains here compared to the original Lispro and aspart are quite small. In the pump study, there was no gain at all. In fact, it was slightly worse. And that was true in both type 1, but more noticeably in type 2 diabetes. So a small gain in a biobetter formulation, but really not coming through in HbA1c. And the same was true with hypoglycemia. But perhaps we can expect more in the future. This is insulin aspart in grey compared to the new Aricor 278. And notice this is U500 data. U500 is normally a more slowly absorbed insulin, but this one's quite remarkable in the insulin is getting into the circulation really in the first 30 minutes. And this is the first physiological early insulin response we've seen from any mealtime insulin. And you can see it gives better pharmacodynamics, better glucose action also in that first hour, and will be expected when the phase 2, phase 3 studies come along to demonstrate that. It's not all perfect. Physiologically, we come back to baseline at 4 hours. This insulin is still well above a baseline at 4 hours. So we're not quite there yet in terms of risks from late postprandial hypoglycemia. Then as another example, we have the weekly insulins. I show data here from Novo Nordisk, who've in press releases, and I dare say they're somewhere in the submission press process, have released data on 6 phase 3 studies, thus emphasizing that this is a new chemical entity with new pharmacological properties. It needs a full development process. But you can see here why, if you look at the hypoglycemia line, the hypoglycemia is increased in headline terms in each of these 6 studies. And of course, if you toss a coin 6 times, that's statistically significant. And you'll see it's quite a big increase in relative terms in the key pivotal studies in type 2 diabetes. These first 3, it's either a doubling or even more than 2.5 times the comparator glargine or degludec insulins. And of course, we need to know what time of the week this is occurring, how significant it is, how frequent it is in that small proportion of people who will be suffering the events. And we can look forward, I hope, to the phase 3 papers on that score. But these are all things the regulators will need to look at with the new insulin. And Lilly's basal insulin FC as yet has only entered phase 3. We don't have further data, although its phase 2 paper, you will note, was just published this last week in Lancet Diabetes and Endocrinology. So even if it were the same chemical entity and millia formulation change, the hypoglycemia data emphasize the need for a full safety assessment where you have a large pharmacokinetic, pharmacodynamic change. So the regulatory and clinical assessment must be tailored to each new biological medicine and not determined by classifications and definitions. So that's biobetters in quick summary. Let's have a quick further look at biosimilars. And here I want to emphasize that the regulatory process, I think, is still rather flawed. The regulators like to see area under the curve. This is for basal insulin for 24 hours and Cmax. But actually, those aren't the things which are important in clinical practice. What's important in clinical practice is the profile, as we can see on the right. What's important in clinical practice is, of course, the concentration levels at 24 hours, whether this insulin works for the full 24 hours. And because of hypoglycemia, the peak-trough ratio shown here for insulin glargine U100, the Lilly compared to the original Sanofi. And I think you'll agree with me that what you really get confidence from here is that the profiles are identical, not the AUC Cmax data. Interestingly, actually, these are significantly different. The Lilly insulin is different on these. You can see confidence intervals, upper limit do not exceed 1. You also see the confidence intervals are quite wide, and the regulators accept confidence intervals of 80 to 125%. But would you accept a change of insulin dose of 25% in clinical practice? You wouldn't. You would ask for 5 to 10% change. So really the regulators at the moment are asking for the wrong parameters and rather weak parameters coming from glucose clamps, rather looking at glucose profiles, which is they ought to be doing. Next question, are we really getting that cost advantage? And here the answer is kind of yes and kind of no. If we look at insulin glargine U100, and we look at a regulated country like the UK, where prices are fixed at national level, then the Lilly biosimilar actually doesn't show advantage, or didn't a year ago, over the Sanofi insulin. Their saving was 0. The Biocon was a little better, but to the order of 15%. Things are a bit better for the Sanofi Lispro and the Sanofi Aspart, improvements of 25 to 30% as cost savings. But this is nothing like, of course, the slump in costs one sees with generic medicines. Say a drug like atorvastatin, whose costs became 10% of what it was originally. And similar things are true of all the sulfonylureas and other glucose-lowering drugs which have come off patent. So this emphasizes, I think, that biosimilars are still expensive to develop, requiring those phase 2 clamp studies and phase 3 studies. Then there's the question of interchangeability and substitution. Just for definition, substitution is switching by a healthcare professional on user agreement, usually with enhanced monitoring, cautions, and supervision. So this is intended change, carefully managed, whereas interchangeability is where a pharmacist merely says, this is a prescription for Lantus, but that's just insulin glargine. I'll actually give them the Biocon or the Lilly preparation, something that's very different and occurs all the time with genetic tablets and pills. But as Diabetes Canada has put it rather nicely, it's not that easy with insulin. People have a love-hate relationship with their insulin, and they say a biosimilar should not be considered as interchangeable with its reference agent without regard for the individual or clinical concept, and further that it should only be done with explicit knowledge and consent from both the patient and their healthcare providers. Indeed, in some cases, where there is psychological dependence on a preparation, it shouldn't occur at all. Indeed, in Europe, in the UK and in Canada, interchangeability is not a matter for the regulators at all. It's determined at healthcare funder and healthcare delivery level. And advice in the UK is that all insulin products should be prescribed by proprietary name, and there should be no interchangeability or substitution by pharmacists. However, originator products may have their funding discontinued by funders, and that may force swift changes, in which case this kind of supervision is important. In the USA, things are different. 2 insulins have been approved as being interchangeable as a result of the uninformed laws over there passed by Congress. I've tried to look for the data which supports that interchangeability, and I cannot find it as yet in the literature. I doubt it's satisfactory. So to conclude, ladies and gentlemen, it's not just biosimilars and biobetters, but there are a whole group of different classifications of novel insulins available to us, from copies through to new structural entities. Different variety. Sorry, somebody's coming in and interrupting me. Could I ask you to mute, please? A variety of different types of insulin-based medicines are available globally. Formulation advantages and structural changes given us useful new products, and with the weekly insulins will continue to do so. Biosimilar regulation has ensured quality, but of limited cost. And patient psychological dependence on their familiar insulin does not support interchangeability, but does support substitution. Thank you for your attention.
Thank you, sir. Thank you very much and joining us live. We are indeed privileged to have you, sir. I think we are on time. We have about 2 minutes. Sir, are you comfortable with the interchangeability in your practice? As you said, in UK, you are supposed to be prescribing in the proprietary name, but given a choice, will you choose biosimilar?
The answer to that is twofold. One, of course, is when you're starting somebody who is naive to insulin, then it doesn't matter because they don't have the experience of the previous insulin. So there, I'm very happy to choose the cheapest preparation amongst those that have been approved. And yes, we will use the biosimilars. Changing in practice, it is a bit of a burden. You do have to see people more frequently. You do have to increase monitoring. So I wouldn't say I was happy with it because, frankly, it's more work for everybody. But where the price saving is such that in our stress times in healthcare, and I notice that's true everywhere at the moment, including recently articles on Canada, the UK, France, then there may be a need for cost savings. And in those circumstances, we will look at it in our practice. But we prefer to do it in a planned way and certainly with patient consent.
Thank you, sir. Thank you. Dr. Bishwajit, sir, do you have any?
No, I have the same questions because we are facing the same thing, the issue when we prescribing our patients. So,
in a sense, using a biosimilar is not all that different. Transferring somebody to a biosimilar to, say, transferring them from human insulin to insulin aspart or insulin aspart to faster insulin aspart. You are putting in place a new entity with different properties. Psychologically, as far as the patient's concerned, this is different, and you need to protect them from that.
Will you be very confident to use in type 1 and in pregnancy where immunogenicity comes into picture, sir?
Yes, I think the same is true in type 1 diabetes. It doesn't quite so much apply as we do like to use the up-to-date long-acting insulins and degludec, of course, and U100 glargine don't have equivalents amongst biosimilars. Where we do see biosimilars being available is for faster aspart and faster lispro, and then the Sanofi versions do give us those options. And as I said, we'd be comfortable with them, particularly for the first time of starting a faster acting mealtime insulin.
Thank you, sir. Thank you.
Is there any questions? So how many times do we have?
Okay, thank you very much. Good to be with you.
Yeah.
Thank you, sir. Thank you.
Yes.
Thanks a lot.
Thank you.
Bye now.
Bye, sir. Bye, sir. Bye. So I think we are done with the session and over to the organizers. I can see.
But before leaving, we also give our sincere thanks to the organizers for giving us the opportunity to chairing these sessions, and also thanks to Bansi for organizing, and Professor Azad Khan, the chair and the chair select. Yeah. So thank you.
Thank you, sir. It was always a pleasure to catch up, and Bansi sir is doing a good job in the
the tremendous work.
I'm sure he will take it to much heights under chair elect,
and that is
from
incidentally for bye.
Sure, sir.
Yeah.
Good.
Bye.
Go to organizers, please.
Thank you, LSM sir. Thank you, Vishwajit sir. Of course, it was a wonderful session. Can I request the RX team to make sure that we have the next chairpersons for the next session, please? Dr. Sharma sir and Dr. Thivaya Fernandopoulos sir from Sri Lanka.
Yes, I have updated. Dr. Sharma has joined.
All right, awesome. So, Dr. J.K. Sharma, sir, is a very senior physician from the city of New Delhi. And sir is an academician, a researcher, as well as a clinician, and has led all of us when we talk about leading us into the Royal College of Physicians and, mentoring us. So, can I have his one slide CV, please, Mayank, to introduce him? So J.K. Sharma sir has a lot of laurels and a lot of degrees in his name, and he is the consultant diabetologist from the Center Delhi Diabetes Center from New Delhi, and Dr. Satya Silan, if I'm correct. She is an MD Family Medicine with interest in obesity medicine, nutrition, and metabolic disorders. So if we have J.K. Sharma sir, can I request him to introduce our first speaker?
No, actually, the first speaker is not available at the moment as we are running ahead of the time. So I think we can wait for 5 minutes or more.
Mm-hmm. Okay, sure. Let's do that. Let's wait for 5 minutes.
Can you see it? All right. So Dr. Sharma, you are introducing me, or shall I get going?
I think everybody knows you well, and you are a well-known figure. So with this, you can start your presentation and make us wise in this field.
Thank you very much, Dr. Sharma. So good morning, everybody. Good morning in the UK, which is where I am. And I guess it's afternoon for all of you. Thank you very much for asking me to speak here. Special thanks to Dr. Banshi Sabu and Dr. Shashank Joshi for inviting me. I'm Dr. Neeti Paul. I'm the immediate past president of IDF Europe. I'm a diabetes advocate. My interest in diabetes is not just professional, it's very personal. My son has type 1 diabetes and has had it for over 30 years. So it's been a long journey for us as parents. I am a practicing doctor in the UK, but I wear a number of other hats. And my topic today is insulin access. And I named it Keeping the 100-Year Promise, Making Insulin Access Universal. And some of the slides that you'll see and some of the work that you'll see is work that we've done across IDF Europe. This is the International Diabetes Federation of the European region. And some of you might know, we've just managed to get a resolution passed in Parliament, and we'll talk about that in a minute. So what are the worldwide challenges to insulin access? And you might think, why is the ex-president of IDF Europe talking about it? We're a wealthier region. We have more access and more wealth than a lot of the other regions. But our region is very diverse, and across our region we have many disparities in how insulin is actually funded. It's the same, I guess, in the US, where you are seeing people actually storing their insulin, not rationing their insulin. So it's not just the poorer countries, but the wealthier countries as well. Insulin access still remains an issue. For me, the biggest thing on why insulin access doesn't happen or doesn't happen properly is access to insulin requires sustainable, high-quality diabetes services. And if that's not present in the form of health system capacity, infrastructure, lack of services, and integration at a primary care level, which I know in India remains an issue. I've been there, I've got the T-shirt. Inadequate capacity for providing diabetes and infrastructure for information management as well. So nobody knows what the data really looks like and where people are getting insulin, where they're not. Industry effort to support challenges for access to insulin are limited. They're doing what they can, but it's sometimes seen as not their job. And advocates are not holding governments responsible for challenges faced both by industry and patients. So in many countries, advocates, especially in Southeast Asia, don't have the same status as, I guess, a professional would have. So it's really important that in your countries, especially in India, you recognize advocacy efforts and really get patient advocates on your side. Otherwise, some of this will never happen. In IDF Europe, we have very large type 1 platform with over 400 type 1 advocates across the region who support all our advocacy efforts, as well as now building out a type 2 advocacy platform. The other thing is, you might find that odd is, and you might know it, 3 multinational companies control more than 90% of the insulin production. So it leaves very little space for smaller companies to compete for insulin sales, and biosimilar insulin manufacture is in flux as current manufacturing continues to be dominated by these 3 MNCs. You in India have a better space, I guess, where you've got generic manufacturers who are starting to manufacture biosimilars. So you're a little bit better off than a lot of other countries. The research to control and minimize wastage of insulin to expiry in maximum 28 days after usage is not being carried out. So people don't actually say, you could use your insulin, it's still active, but the research hasn't been done. So obviously the manufacturers won't recommend it. Post-COVID and during COVID, we saw huge issues, which is the manufacturer supply chain and regulatory issues, and the global market shift from human insulin, which can be produced at a relatively low cost. And these are some of the stuff that I picked up from the WHO Compact on Diabetes and what they published around insulin access. So it's a relatively low-cost human insulin to pricier analogs is imposing an untenable financial burden on low-income countries. And in general, human insulin is as effective but analogs are 1.5 times more expensive. So I guess the scientists on this call and doctors on this call might not like what I'm saying, but it's an absolute fact in low-income countries. Suboptimal regulation and policies, including suboptimal pharmaceutical pricing approaches, weak procurement and supply chain management, and insufficient financing to cover demand and weak governance are affecting access to insulin and related devices. So it's not just about the insulin, but how do you actually, when you're on insulin, in some countries, test strips are rationed. And across Europe, there are many countries that we come across that test strips are rationed. And delivery devices are definitely rationed. So it is something that one should be talking about. This is not insulin, when Banting and Best discovered it, they sold the patent for $1. They intended it to be for use of human good. So really it needs a little bit more thought. Supply chain management, local production of insulin are widespread challenges in lower income countries. I guess in India, a little less, but you also have the supply chain issues of cold chain, etc. And the research has always been geared towards wealthier markets and neglecting the public health needs of low and middle income countries, which account for about 80% of diabetes burden. What's the need? I'm not going to talk about type 1 here, but 1 out of every 2 people needing insulin for type 2 diabetes doesn't get it, which is a big issue. Diabetes on the rise in low and middle income countries, and yet that consumption of insulin is not kept up with the growing disease burden. So we know that there must be some people who need insulin, they're not getting it. And the WHO report that I referred to highlights that while 3 in 4 people affected by type 2 live in countries outside of North America and Europe, they account for less than 40% of the revenue for insulin sales. And you can immediately see why there's a difficulty in insulin access. So what are the solutions? And I didn't want to be, all doom and gloom early in the morning here. It's 9 o'clock in the UK. But I also wanted to look for some solutions. And we've been looking for some solutions at IDF Europe as well. And I'll tell you how we came to some of these conclusions. It's streamlining the biosimilar approval process, increasing pricing transparency throughout the insulin supply chain, improving affordability by regulating prices and markups using pooled procurement and improving transparency in the way prices are set, lowering or removing patient cost sharing for insulin. By this, I mean out-of-pocket spend. And I do know in India, a lot of people will be buying their insulin. It's not funded. Ayushman Bharat does fund it. Often people don't have access to it, and maybe it's not fully funded. Increasing access to health coverage for all people with diabetes. That doesn't exist in India. Using health resources wisely by selecting human insulin where possible and allocating adequate funding to provide a full package of care. So this is not just about insulin, it's about providing packages of care. We should be boosting human insulin production and supply and diversing the manufacturing base for biosimilar analog insulins to create competition and reduce prices. And it will happen over a period of time, but we need to do it pretty quickly. We need to promote local manufacturing capacity in underserved region and promote R&D centered on the needs of low and middle income countries. And I guess you guys are doing that, but there's a bigger push needed for this. And strengthening the health system's care and delivery, which is the biggest challenge I guess India will face, is the health system's care and delivery systems. And this is not about the wealthier cities. It's not about tier 1, tier 2 cities. It's about the rest of India too. This requires political will, healthcare infrastructure, diabetes expertise from patients. Don't forget them. They're the ones who are going to make some of this possible for you. Education, access to blood glucose monitoring as part of this, and psychological and social support. I do know that myself and my cousin in India, we support a very small family foundation, and we we can only afford to fund about 10 kids. We do know that girl children with diabetes, type 1 diabetes, are less likely to get insulin in poorer families than boys are. So there's a whole social system that we need to be talking about out here as well. Establishing a diabetes kind of system requires you to have collaborations. And for us, I'm just talking about Europe now and IDF in general. It's some member associations, including some of you people on the call, who are part of these collaborations. For us, anything we test, anything that we look at, we ask our member associations. The WHO, UNICEF, ISPAD, some of you know about. EASD for us in Europe is very important because it's our platform for getting the researchers and academics involved. Life for a Child, and I'm going to talk about that in a minute. You guys know a little bit about it. My dear friend Shashank knows a little bit about it. International Insulin Foundation, which is based out of the UK. And I'm going to talk to you a little bit about direct relief, which IDF directly supports and funds. There's a Ukraine case study that I was going to present, but I guess today's greater need is the big earthquake in Turkey and Syria, and where we're going to be funding some insulin supplies through our member associations, but via direct relief. And pharmaceutical companies, your life sciences companies, equally important as part of this story. I'm terribly sorry. I've got a little frog in my throat and my screen is not moving for some strange reason. May I ask? 1 second. I'm just going to have to start sharing again. Something's happened to my screen. Not doing it. IT. Okay, I can't screen share. It's not moving. My slides are not moving.
Ma'am, just click on the slide and then try to right and left arrow.
Okay, got it. Okay, got it. Done. Life for a Child is an organization that provides essential supplies, including insulin syringes and blood glucose monitoring equipment. Really important organization across the world. It produces accessible education material for children, families, undertakes research, helps advocate for positive change, and supports 34,000 children in 44 countries. So it's an organization that we very much support in IDF Europe, but across IDF, the IDF family as well. The International Insulin Foundation, some of you guys might have heard of it. And what does it do? It's what is needed to manage insulin requiring diabetes in resource poor settings, barriers to care, how can these be identified? They developed a rapid assessment protocol for insulin access called RAPIA. And if you haven't seen it, please do. It's quite an interesting tool to see, whether insulin access can happen or not. We have resources for advocacy worldwide developed with collaborations. All of you would know about the IDF World Atlas of Diabetes. I've got the link there if people want to click on it. And then, of course, what I found extremely useful in the last kind of 6 months, it was launched at Lisbon, IDF World Congress in Lisbon, was the JDRF Type 1 Index. You can get it on your phone. I would click on that link and get into it. And you can put in country by country. I guess you could also put in state if in India wanted to develop it further, and you can get an index of type 1 and what care is like for type 1 patients. And I think it's a really good index as to be used as an advocacy tool with governments and with payers. This is what the IDF World Atlas on Diabetes shows. And it's no surprises to you, I guess, in India. Greater than 20 million people with diabetes, right? Big problem in your neck of the woods, but other places too, as you can see across that world map. Again, this is taken from the IDF World Atlas on what type 1 per IDF region. You can see your region here. So I guess the problem is getting bigger and bigger for people who need insulin. And this was, for me, one of the starkest slides that really tells you what the life expectancy of a 10-year-old child diagnosed with type 1 diabetes in 2022 looks like. This is not looking great, right? So in India, the life expectancy of a 10-year-old child diagnosed with type 1 in 2022 is between 25 and 39 years old. It's not great. So I think it's really it's problematic and related to all the issues I talked about, not just insulin. So I'm just going to focus on Europe now, and we presented this in Lisbon, and these are lessons from Lisbon. Just on a priorities for action on diabetes, the focus on Europe, what we did was, in my triennium, is to look at 3 things: improving access to care and quality of life, increasing the voice of the person with diabetes. And we did a lot of work on this. And I firmly believe this is where everybody should be focusing their efforts, and getting people with diabetes as part of your your diabetes team, but also advocating with government and reducing the incidence and diabetes-related complications. Those were our three themes in Europe. These are the three pillars by which we did what we needed to do. One is mobilizing a strong diabetes ecosystem, and that's leveraging and supporting our member associations, which we do, building external alliances, strengthening network of people living with diabetes, and pillar two on the political agenda is positioning our advocacy effort and developing the evidence to position the effort and enhancing our visibility and advocacy reach. And that led to what I'll show you is a resolution many years after St. Vincent's, published in the European Parliament in the summer this year and tabled by the President of the EU, Roberta Metsola. So ensuring the organization's sustainability, so whatever you do for people like us, we are NGOs, we need to make sure that we are sustainable. So I spent quite a lot of time fundraising as well and making sure that the governance and financial accountability was in place. In this, we have twinning programs with a lot of people across Europe, really happy to also look at countries outside of Europe. And I'm sure there will be those things coming along from the IDF family as well. We do a lot of work around a network of people with type 2 and a youth platform. Like I said, we had online during COVID and an in-person youth lab, and this has continued. This is yearly, continues throughout our efforts, and we've got all our previous youth leaders engaged in this. We also have parliamentarians, MEPs mobilizing for diabetes secretariat. We host the secretariat, and we have regular meetings with the parliamentarians as well as the parliament. Now, I guess for us, it's really important to get diabetes on the agenda to make sure that any grants or anything comes out and national plans are being written, diabetes is firmly on the agenda. And we answer a lot of the EU consultations as well as pan-European consultations. And within the broader European region, we focus with the WHO Europe, WHO Global Diabetes Compact. We helped write some of that, the Council of Europe and other NGOs, and we wrote the Europe-wide IDF Europe Diabetes Roadmap to 2030. It's available on our website. Please have a look at it. And the reason I say all this is also part of insulin access, because if you don't have all of this, your advocacy efforts are in thin air. And this is our motion for a new diabetes resolution. So this is about health system design, and this is about reducing co-payments, a burden on people, and making sure that every country in the EU has a national diabetes plan. And this is, we had a campaign for the centenary of insulin. We did lots of webinars and seminars, just like you did, but led to a lot of the stuff that we talked about. So we do monthly country profiles in our region on video testimonials and on our website about what country profiles look like, what is the funding levels, what is their advocacy efforts, where they've got to with national diabetes plans. I think all really important as an NGO. So I'm speaking from a point of view as an NGO. We've published a lot of papers, again, on our website. There's a position paper on, we do thought leadership, short position papers when they're needed, like for, vaccination of people living with diabetes. At the time, we wrote that very quickly with our researchers and academics. And then papers on value through innovation, and a lot of it around gaps in care. So we've got a lot of publications that our member associations definitely use for their advocacy efforts. We've got evidence in many of these countries. You can see them marked here. And then just finally, what's that worth? I'm just giving you a little case study. As the war in Ukraine happened, we created a solidarity website on our website, co-hosted it on our website. A lot of the refugees that were coming across the borders from Ukraine were ending up in neighboring countries, or as far as, Nordic countries, just making sure they knew how to access their insulin, how to access their medicines, how to access the healthcare system. And we connected them to the local NGOs and local member associations that were able to do this. And like I said, we also put in money through direct relief, and a lot of donors put that money in, including a lot of our corporate partners. And similarly, we're doing the same for Turkey and Syria. I'd like to stop here, and thank you very much for asking me to speak around this very important webinar that you've organized. Happy to take any questions from the floor. There's no questions I can see. Sanjay, are you moderating or are you coming next?
I'm coming next. Hi, Niti.
Hi,
I was
how are
listening
you?
to your lecture. Very nice. Loved listening to it.
Thank you. If I don't know who's moderating the session, I think he may have vanished. I don't see any. I don't see any questions, so I'm going to put myself on mute and put my camera off and hand it over to you, Sanjay.
Thank you. I don't know if there's any moderator, but okay, I'll just straight away start my lecture. I'll introduce.
Yes, sir. You can share your slides and you can start your sessions.
All right, I'll do that. Okay, I don't know if you can see my slides. Can you see my slides, please?
Yes, sir.
All right, thank you. I'm Dr. Sanjay Agarwal, and I'm the Secretary General of the National Body of India, the RSSDI. And what I've been told to speak in the next 15 minutes is implementing type 2 diabetes prevention program. Now, we all know that primarily India has the second highest population with diabetes, and Asia as such has a high prevalence of diabetes. And obviously, we need to do something so that we can bring the burden of disease down. Why is it so? Because we do have certain characteristics. We have diabetes occurring at low BMI. We have a high prevalence of metabolic syndrome. We have insulin insufficiency and resistance, and we have a younger onset of the disease with a longer disease duration. Now, what this translates into is the fact that, we get very early complications of diabetes and probably end up with a high prevalence of morbidity and mortality. Couple this with the fact that we have bad lifestyle, poor education, awareness about the disease process, and over and above that, poor resources in terms of support, finances, and how to go about getting their own supplies for medications and things like that. Now, here are probably not only problems that are related to India specific, but Southeast Asia as a complete region. And as I said that, while we have genetic and acquired risk factors, the environmental and the societal factors are more important from our perspective. And these are the points where we need to do intervention and see that as a community, can we do something for our patients with diabetes, which will reduce not only the glycemic goals, bring them to more better glycemic goals, but reduce the burden of diabetes, pre-diabetes, diabetes, and cardiovascular risk as such. The question that arises is why prevent diabetes? And we know that, the longer that you can keep the patient away from overt diabetes, you're going to reduce the risk of macrovascular complications. And we need to optimize our resources to see that who are the people we need to screen and identify with pre-diabetes, and can we treat them to prevent them from progression to diabetes. So the question is, how do we identify those with pre-diabetes? And, we've had various risk scores. Something that really works well for us is the IDRS score, which was developed by Dr. Mohan and his group, and they have a 10-year follow-up in the CURE study. What they looked at was they had the score settings, and if you had the scores, they sort of give you almost 5 risk factors could explain almost about 80% of all incident diabetes, and that was obesity, physical inactivity, poor diet, high triglycerides, and low HDL values. So clearly, these are your first goals that you need to really address if you have to reduce, the burden of pre-diabetes and diabetes. And your intervention should start here in terms of public awareness and, goal settings, not only from the public point of view, but also from the physician's point of view, because you see a lot of inertia on part of physicians to go aggressive in terms of goal setting. Now, this was the IDRS score that was proposed by Dr. Mohan, and you can see that they looked at age, waist circumference, physical inactivity, and family history of diabetes and the score value given to them. Now, this works very well in the clinical setting for identifying patients who need a more sort of, aggressive approach so that we can optimize the resources and not waste them enough. So if you have a score a very high risk of having, if you have a score of more than or equal to 60, then you have a very high risk, in which case you need to investigate further. If you have anything between 30 to 50, there's a moderate risk of diabetes, and you need to follow up on these patients. And if the score is less than 30, then the patient has a low risk of diabetes. This paper again, by Dr. Mishra and associates, which Bansui and Shashank also part of, does mention that we should not wait to screen our population beyond let's say third or fourth decade. We need to screen earlier. And last year we had a Defeat Diabetes program where we initiated that, let's have people test their blood glucose, because the awareness of testing the blood glucose levels only once has also not been there. So we sort of made it a campaign, and we sort of had awareness of about 128 million in 100 days. And in a single day, we did 1 million tests. Now, when we analyzed the data, we did find that almost 16 to 18% of our population around the age of 18 to 20 years tend to develop onset of diabetes, which they have not really been aware about it. So, I mean, there have been a lot of intervention trials, and I'm not going to get into the specific, but that's not the scope of my talk. But they have clearly shown that intensive control does reduce the risk. And we've had the US DPP program, the Indian Diabetes Prevention Program, and all these prevention programs have given the benefits of lifestyle as well as metformin. And now, of course, we've got newer agents which target obesity, which helps to sort of not only target the glucose values, but also the weight issue, which may be the mother of all evils as such. So I'm not going to get into the specifics, but we know that lifestyle intervention works, metformin works. The combination probably doesn't give an added benefit. And again, when they looked at the Indian Diabetes Prevention Program, they did say that progression of IG to diabetes is high in native Asian Indians, and both lifestyle modification and metformin significantly reduce the incidence of diabetes, but there's no benefit of combining lifestyle and metformin as such. This was, of course, the figures that they put out, and then they came up with the Indian Diabetes Prevention Program 2, and where they tested pioglitazone. And what they did conclude was that pioglitazone does not enhance the effectiveness of lifestyle modification to prevent conversion of IGT to diabetes in Asian Indians. All right, I'm not going to get straight into the talk that I really wanted to give, is that we need to have training diabetes care models which are going to work well for us in terms of prevention. So these could be training healthcare providers, peer for progress model, that was star shifting, and multifactorial intervention, which is an integrated care model that we need to do. And this excellent paper from the DRCP said that we need to identify who's at risk, readiness, accessibility, and acceptability. Then what should be the population target, the social needs supports, group alignments, personalized and empowerment. And where should it be done? It should be in person, online, distance-based, or community-based. And when? So it can be at all times. So every opportunity that you get should be an opportunity that you should take to counsel. So brief counseling, nutrition therapy, lifestyle change program, and medications. Now, this was something that was very interesting, that they took the applications to diabetes prevention and management to a multi-level and multi-sectoral interventions. And then you've got, the peer support, the community organizations, health in all policies, and multi-sector, multi-level engagements. And these have already been sort of started in certain states in India. So perhaps the time has come when it should become habitual to think of people being embedded in a socio-cultural and economic context. And you need to sort of, educate our patients better, look at what the ground realities are in terms of understanding of patients, what are available, and then obviously sort of, talk about it in that language. So these were some of the innovative and low-cost approaches to prevention management that was put out in Asia program. And this was a paper by Dr. Anup Mishra. So when I just talked about task shifting, so you need to involve the pharmacists, nurses. You need to have school-based programs for education regarding nutrition and physical activity. You can have health promotion today through smartphone and digital platforms, because every person practically has a phone, and you can utilize that to see how you can sort of bring in the phone as a tool for health promotion. Then you can have, of course, customized mobile vans where you can take the care to doorsteps, because there are sections in India or parts of India which does not have adequate resources of even diagnosis or provision of health care. So these mobile vans serve to bring the healthcare to the doorstep. Then you can have bidirectional screening, nutrition in perinatal period, which has been integrated as part of the NCD program. And then you need to ethnically tune lifestyle intervention. So it may be in the workplace, community, and you probably need to tax the unhealthy oils in foods that will become a deterrent for people to use it. So this was another project, the project Diabetes with Dignity. And here, this was the clinical effects of a trial of empowerment of community health workers for improving diabetes care in a rural Indian setting. So what they're trying to do in this program is to see how can they take people from within the community, train them, and send them back to the community. And can they impact the local population out there to make the difference in understanding of healthy practices, which may then obviously bring the incidence of non-communicable diseases down. So some of the things that they identified is, first of all, they defined what a healthy village should be. It should tobacco-free society, free diabetes health camps and education, inclusion of nutritional needs, and they created a whole bandwidth of people called as Arogya Sati, which I'm going to talk to you about, as skilled health educators. And then, of course, they implemented the adult vaccination program. We've got the Anganwadi workers, and these are sort of locally skilled people from the community, and they were trained as diabetes educators. So they go into the community, go door to door, and talk to people and sort of educate them, diagnose them. They do basic screening tools, basic examinations like a blood pressure examination. Some of them are empowered to also look at the blood sugar values. And this helps the people to understand what their health is, as well as identifies the health needs of the population. Now, this was a rural project that was initiated by the government of India, and these were the different arms of it. The vision was to create health awareness and prevent communicable and non-communicable diseases in the community. The mission was to initiate and assign Arogya Sati health friend concept, where in one health friend, it attends 250 families every month to maximize out the reach. So they've had state-of-art diagnostic centers with primary level assessments, chronic care, acute care, and imaging facilities in terms of X-ray and sonography. Then they've sort of initiated as part of the rural project as Arogya Sati, which I just said, they created a whole bandwidth of people who were termed as Arogya Satis, and they put out the healthy village concept that I just talked to you about. So who is an eligible Arogya Sati? It's preferably a female who can read and write and has basic 10th grade qualification, knows the native language, motivated enough, compassionate and caregiver, has good interpersonal skills, and is a quick learner. And they are trained and made capable of identifying a wide range of diseases and non-communicable diseases based on signs and symptoms. They help and guide patients to which specialty department is the best for his or her treatment. They check blood pressures and suggest dietary and lifestyle changes that are needed to control it. They check blood sugars and suggest dietary and lifestyle changes that are again needed to control it. They do basic sort of care in terms of dressing of wounds, physiotherapy, hygiene and sanitation, and infections, women health, and child care. And they are sort of assigned to 250 families to visit families twice a month. They do regular health assessments and they collect data. And with all the trainings and knowledge that are provided by the officials, members, and various medical experts, Arogya Sati has become capable to serve the communities and earn a decent livelihood with the respect and dignity as people with such skills are usually lacking in the villages. So they work on an incentive basis, so they do make some earning out of this. But what it really translates is they get a job, but at the same time, they make a difference in the community. As I just said, the mobile has become a good tool for sort of, empowering people to learn all about the disease process. And this is, again, an excellent sort of article that was put out that India just crossed 1 billion mobile subscribers milestone, and the excitement was beginning. But what it has shown is that there's almost 80% that overall, that 50% in the rural areas, the reach has been. And they looked at the effectiveness of mobile phone messaging in prevention of type 2 diabetes by lifestyle modification in men in India. And this was a prospective parallel group randomized controlled trial. And they've shown that it has been a highly effective tool for education purposes. So let me end up by saying that what can we do? We should provide adequate facilities for recreational physical activity, encourage walking, cycling rather than mechanized transports, discourage consumption of junk food through taxations, ensure availability of healthy foods, where there's fresh fruit and vegetables at affordable prices, encourage healthy eating practices in schools, and use of mobile phones to deliver lifestyle advice. I just want to end up with some of my own thoughts that Asia accounts for the largest number of patients. We need to develop region-specific guidelines because we have a lot of guidelines that come from the Western globe, and we need to see that how can we develop our own, ethnic-specific guidelines which may be suited for our purposes. We need to have a strong advocacy with governments from Asian countries to adopt diabetes as an important public health problem and make countrywide programs to reduce the burden of diabetes and complications. Remember that there is a wide disparity in household income and expense, and we need to develop low-cost models of care to allow better compliance to treatment, and we need to encourage insurance companies to cover the cost of care for patients with diabetes. It's just beginning in India, but we still need to do a lot for these people. We need to develop better education tools and invest more in prevention programs. This is, of course, the WHO resolution for non-communicable diseases, and it clearly mentions that we need to do more in terms of prevention and control of diabetes at the community level. We all need to work together, and IDF as a body should sort of take the lead in seeing that how in the underprivileged or low middle income or low income regions, we need to bolster up our efforts to see that, we can bring better care to the people with diabetes. I'll stop here. Thank you very much for your patient listening. If there are any questions, I'll be happy to take them.
Excellent talk, Sanjay. I just wanted to congratulate you on a great talk. And these community health workers you've talked about, are they funded by government or are they funded by you guys?
They're funded by the state government. So, we have been trying to see, so there are a number of these initiatives. They have something called as an ASHA worker. That's one.
I know them. I know ASHA workers and I know the Anganwadi workers, but I didn't know about these, what do you call them?
Arogya Sathis. So these are sort of foot soldiers that they're developing in the peripheral areas because that's where the care is least in the country. And they're trying to see that can they involve people from the community itself, train them and put them back in the community for better care and, advice as such.
Do you have any written material on that? If you could share it, I would love to see that. It's a very good idea.
I'll send it across to you. And we have been trying to engage from the body, going to the government to see that how can RSSDI partner with them and see whether we can sort of help in educating these people, as well as give them resources, to see that they can do the basic requirements of testing that may do. So, for example, we did the Save the Feet campaign last year. And we provided the tools for just monofilament testing to see which are the feet at risk. And take basic questionnaire-based, history to tell us that, okay, which are the people which need care. People who had, wounds which are non-healing or typical diabetic feet, they were told that how they can sort of be guided to better care facilities, salvaging feet. So Vijay Vishwanathan led this initiative he's a D-Foot International president, and he was part of that whole program from the RSSDI. And as I said, the Defeat Diabetes was a big success for us for creating awareness for testing the blood glucose. And that gives us some great results. And the next one that we're doing now is Know Your BMI. so that, we can make awareness about obesity across the country.
I'd love to see that too. Just a quick question from me again on this. You made huge progress. Does India have a national diabetes plan, or does any state have one?
No, sadly, no. We don't have one. We have been trying to sort of push the government of India as well as state governments, because we've sort of put together a program at our end from the RSSDI, but we're trying to see how we can involve the government of India to do that. But involving the government anywhere is a slow process, and I'm sure we'll have to push it hard and see how we can convince them to partner and make this effective.
So whatever way IDF Europe can help you in terms of getting a resolution across the line was quite a difficult task, and the EU obviously is a disparate bunch of people across many countries. So it's almost like you're kind of trying to do this at a national government level. So I think we can help with your advocacy efforts and what you need to do.
Thank you so much. I really appreciate that. I mean, we are making progress. We're talking to people, but it's a slow progress.
Thank you for your talk. It's really great. Thank you, Sanjay.
Thank you, Niti. Love talking to you, and as well as listening to your lecture. It was really, really very informative. I think there was a third lecture too.
So yes, good afternoon, Sanjay sir. We have our next speaker.
I think
Dr. Tim Street is there. So I would request RX team to load his presentation and start his talk.
Hello, everybody, and thank you very much for inviting me to speak at this IDF Southeast Asia covering what happened in Lisbon. I'm today going to speak about DIY in the diabetes world and why this is important and why it relates to IDF and outside of Asia and EMEA. So the starting point is, what is DIY? Well, DIY is an approach to delivering technology in the diabetes world that has been built by users of the technology for users of the technology, taking advantage of the features that that are available already in those tools, and then being able to expand them and use them mainly at a cost that is a lot lower than the commercial offerings out there, and enabling them to do more with the tools that are available. So the first place I'm going to start with that is in automated insulin delivery, because that's been the buzzword now in the diabetes world at all of the major conferences for the last probably 4 years. And whilst it's a great buzzword, it comes at a cost. So for those people who don't know what automated insulin delivery is, let's just start with this pretty simple schematic, which has been doing the rounds now for around about 10 years. Now, people who use these systems call them loops or looping, which is using an automated insulin delivery system to maintain optimal glucose level. It's usually made up of a CGM sensor, some sort of CGM receiver, CGM being continuous glucose monitor, a control algorithm, maybe an integrated device with an insulin pump, or maybe separate from an insulin pump. Traditionally, that has been the pump receiving the data from the continuous monitor and then doing the work. But more recently, we've seen that this also means things that are running on phones and similar devices. Now, I'm going to quickly run through a few of the commercial options that we have here, because it's worth having a look at those. And the commercial options are available now. Omnipod 5 is available now in some areas, coming soon. Medtronic 780G, Tandem with Control IQ, Diaboloop, and CAM-APS-FX are available in different regions. but they all come at quite a significant cost. And why this matters is because for many people, it's unaffordable. I mean, even in the US, where most of these are available in some form or another, they're quite expensive. And that means that without insurance in the US, you can't get them. In Europe, they are available. Excuse me about the noise in the background. That would be our young puppy getting a bit enthusiastic with his brothers. We have multiple of these systems available, but they're quite expensive. And with national health services, that means that they're not available to everybody, because there has to be an assessment made about the price and the benefits to do that. So in the UK, for example, Wellpath has done a fantastic job of pushing the closed loop pilot through NICE and getting uptake of it and recommendations for use. The limitations that NICE are looking to put in place would restrict access to them to around about a quarter to maybe 20% of those people with type 1 diabetes. So if you take a step back, open source options have been available for a while, but they require some level of technical know-how. And the question that arises with open source options is, could they be an alternative where the cost of delivering commercial options is too high? Now, this gets interesting because right now the open source DIY options are built and installed by the end user of the system. They rely on the user setup of the system to be reasonable to get good results. And that means you need regular review, and you also need healthcare professionals who understand how they work to help users use them if the users aren't able to do so already. But they do allow extensive customization and automation, which perhaps are less available in some of the commercial options because of the other piece that relates to the DIY stuff, which is it is not under regulatory approval. Those of you who follow the news in the diabetes world will have seen that earlier this year, Tidepool got a version of one of the DIY options approved by the FDA as using the US model of CGMs that are enabled for use in closed loops, pumps that are enabled for use in closed loops, and controllers that are enabled for use with multiple pumps and CGMs. The Tidepool loop is the controller in that section. If we go back up to this image here, it's this component, the control algorithm device, that has been approved for use as Tidepool loop based on a DIY option. So what is available in the DIY world? Well, there are 3 systems really, plus some peripheral stuff. There's Android APS, which is probably used most widely outside of the US. It allows interoperability with multiple different CGM systems with multiple pumps. It runs on multiple Android phones. It allows multiple different pieces of software to be used to talk between the CGM systems and the control algorithm device. It can talk to, as I say, many, many different systems and many, many different CGMs. But perhaps more importantly, it allows the use of things like Freestyle Libre, which is much more widely available than many of the other systems and is also relatively cheap. It also allows use of some of the cheaper CGM systems that we're starting to see in the marketplace. I think it's worth, at that point, taking a step back and saying, if you do choose to use cheaper CGM systems with this, there are questions over the reliability and accuracy of them and whether you would actually want to use them with any kind of automated insulin delivery system. My own work investigating on an N=1 basis the performance of some of the systems suggests that they are not reliably accurate and often miss lows and also miss highs. So it's not necessarily the right thing to do that. But if you were looking to try something, if you could do it in a controlled way, it may be something you could look at. The other major option out there is Loop. And Loop is a iOS-based system that does allow some access to non-Dexcom CGM devices through a system called Spike, although Spike hasn't been kept up to date for quite a long time now. It uses that actually slide is slightly out of date. It now allows access with the Omnipod Dash, so there's no longer a need to have a third-party device that sits between your Omnipod and your Riley Link. And most users of Loop now do use Omnipods rather than MiniMed pumps. So where the majority of people are using systems other than Omnipod, or where there are access to some of the other systems, the reality is that Android APS gives you a broader set of options than the iOS Loop does. I personally am a user of, I don't know if you can see that in the image there of me, I'm personally a user of Android APS shown in this setup. I use it with a AccuCheck pump, the Insight pump, which I've always found to work very well for me with it. The key piece here is that these are not regulated devices. In the UK, we've discussed this with the regulator. In the US, a long time ago, Dana Lewis, when she came up with the Open APS system, discussed it with the regulator. And the regulator was aware, was comfortable with the way they were operating it. But the key thing here is that the regulator has been aware in the US and in the UK about these open source systems. And because they are not distributed as medical devices, they're distributed as source code, has seen fit to sit back, let people do it, and be aware that if there are adverse outcomes, then maybe it would need to step in. In other parts of Europe, we know that there has been a much less open view of the world. We know that the regulators in France, for example, prohibited people from participating in development of these systems. We know that in Germany and Poland, there's been a lot of concern about it, and that the guys who develop these things have taken a wary approach and got legal advice to make sure that they were comfortable with it. I don't know what the regulators in Asia's view of these systems is. I don't know if that's a question for you guys, actually, whether it's something that how they would support it. But I think the key thing is that you have to be aware that these are not regulated devices, even though they do provide benefits. And there is a recent study from New Zealand which looked at using Android APS with users in New Zealand and determined that using this configuration is equally safe as using a sensor augmented pump for use in type 1 treatment. There are a couple of other systems out there. AI APS actually has now evolved into something else, but Free APS X is very much available on the iPhone. And Dana has written a book called Artificial Pancreas Book, which is a good introduction into these systems and how they work. I would certainly recommend going to that website and having a read of it if people are interested, A, in automated insulin delivery, and then B, in the open source tools that are available to deal with this. There's a lot more information about this available here. Feel free to go and have a dig around on some of these websites, and I'll share these slides afterwards. But I thought I'd leave 5 minutes at the end there to open the floor for questions and to say, what questions do you have?
Excellent talk, Dr. Tim. I loved it. What I just want to know is that the DIY, how much of implementation do you see, across the globe as well as in your part of the region?
So, if you look at what we see right now, the key driver of access to DIY is access to CGM and access to pumps. So, if a region has access to appropriate CGM that is supported by one of these systems and appropriate pumps, then it seems to have reasonable uptake. And now, one of the downsides to these things is they build it yourself. So there is almost a self-selection bias there. And in the UK, I used to run living with looping workshops and build it workshops where we would get groups of people together who were interested in wanting to have an artificial pancreas system. And this was going back to even 2016 when there were no commercial options available. We'd get a bunch of people together in a room. I think our largest one had 40 people at it. Then we would help encourage them to build the systems so that they could then use them. Now, these people were coming with CGM that they either funded themselves or got on the NHS, and pumps that they either funded themselves or got on the NHS. And then we would help them build those in a room together so that they could understand the process of building it and then build it there with assistance as to how to do it. But there was nothing about us building it for them because, again, that causes liability and medical device distribution issues. So it was all about walking them through the process, helping them understand what the process was, and helping them understand how to do it in a repeatable way so that if they ran into issues, they knew what they'd gone through in the first place. And we encouraged them to write it down as they did it, to follow the manuals that people have already written and put online to help do that so that they would get there in the end. In terms of penetration across the diabetes world, there are over 10,000 people using Android APS. There are over 10,000 people using Loop. We haven't run figures precisely, but we know it's very high numbers for something that really is a do-it-yourself process that requires people to jump over the hurdle of technical fear that we know a lot of people have and have started to gain the benefits from it. So yeah, the Android APS last figures I have were in the summer of 21, and there were about 12 to 15,000 people then using it. It was mainly in EMEA with areas in Asia and Australia, New Zealand, etc., also represented.
But has there been any hardened studies done by you or the others to say that when you do a DIY versus supervised, or using the DIY, has it resulted in better outcomes or better control?
Yes. So the CREATE study.
This is the one which was monitored by the healthcare professional.
The CREATE study. So let me find the details of it and stick it in the chat. The CREATE study is one that has had, that actually Dana Lewis was involved in, as well as the Open project. It's a full, I think it was even an RC, it wasn't an RCT, but it was a study that was properly done to investigate the automated insulin delivery using, there we go. Just put this in the chat.
I'll have a look at it.
That's it there. That's a proper study that was done looking at the benefits of open source systems and how it worked. It was basically to determine the safety and efficiency of the Open APS, so the OREF1, which is the Open APS algorithm, in the implementation in Android APS with children and adults. And from what I recall, I haven't got the details in front of me of the actual outcomes, but certainly it was non-inferior to alternative approaches.
Wonderful. I don't know.
So yes, there is very much a proper piece of work now out there that says this is safe, this is effective.
Oh, lovely. I don't know if there are any more questions for you. I was just trying to ask you my thoughts, but I don't see any more questions on the chat for you. So, is there somebody from the event team? Is there anybody from the events team over here?
Yes, sir.
Yeah.
So last talk is a recorded one.
Okay.
So yeah, so I would like to request RX team to start the presentation of Dr. Praveen from Sri Lanka. The topic is diabetes and mental health.
Nice knowing you, Dr. Tim. Pleasure talking to you.
Thank you very much.
Hi, I'm Dr. Praveen Fernandopoulos. I'm going to talk to you about the link between diabetes and mental health. So I had the privilege of representing Sri Lanka at the IDF conference in Lisbon in Portugal. And I want to take this opportunity to just thank everyone for the amazing work you did. I was particularly impressed with the cohesiveness of the South Asian representatives. It was nice to see everyone just working together, trying to bring the best care and the best opportunities for the patients in the region. So as a psychiatrist, I wanted to talk a little bit about the relationship between diabetes and mental health, connecting your brain to the pancreas. There's a lot of talk about this, so I wanted to kind of explore this and give you a little summary of what we know so far. So I'll be talking about depression and anxiety, and because we know our patients with diabetes are at risk of developing mental health disorders. That's a known fact. Lately, there's been a lot of work showing there's association between diabetes and depression. Patients with diabetes, whether it's type 1 or type 2, have a higher risk of developing depression. Some studies show that individuals with diabetes are twice as more likely to have depression compared to those without diabetes. And we know this. We see this in the office when we see patients. The lifetime prevalence of major depressive disorder is higher in patients with diabetes compared to those without diabetes. So, this seems to be like a two-way relationship. Just as type 1 diabetes increases the risk for onset of MDD, major depressive disorder, MDD can lead to increased risk for onset of diabetes, especially type 2. You can see how having a mental health problem can make it harder for a patient to stick to the treatment plan. Sometimes it's even harder for them to get out of bed, let alone stick to an exercise routine, eat healthier, or stick to a diet. It just becomes that much harder for them to do all these things. So simply put, if you're depressed, you will have a greater chance of developing type 2 diabetes. That's pretty much what we see in practice. I want to talk about diabetes distress. Patients with diabetes can feel discouraged. They can often feel worried and frustrated, and just getting tired of dealing with the daily diabetes care, having to stick their finger with the needle every day, trying to control what they eat, and it's a constant thing that's always in the back of their mind. So sometimes patients tell me that they feel like the diabetes is controlling them instead of them trying to control their diabetes. So and we have to kind of empathize with that, and we have to understand what they have to go through. Does diabetes predict the development of depression? From what we know, having a diagnosis of diabetes, especially if it leads to functional impairment in a setting of lack of social skills, poor coping skills, and when patients don't have a good support system, this can definitely lead to depression. And we see this constantly in our practices. We see patients, they have diabetes. They first come to us for the treatment of diabetes, but as the time goes by, their quality of life just goes down, and they end up developing depression because it's thought that hypoglycemia itself can affect the part of the brain that affects mood and cognition. This can lead to atrophy of the neurons in the hippocampus. It can lead to even neuronal apoptosis, causing structural changes, structural damage to the brain. So, there's a big impact diabetes can have towards mental health and the brain structure itself. The studies that found patients with diabetes were at high risk for developing depression, even at a rate of sometimes at more than 50% compared to people that don't have diabetes. So it's a huge problem. But we can ask, how about depression causing diabetes? So so far we talked about diabetes causing depression, but can depression cause diabetes? And I think the answer is yes. Depressive mood, anhedonia, which means not enjoying the things you used to enjoy, can cause inactivity, which can lead to obesity, poor glycemic control, and just sitting around and not doing what they used to do, and just having a low quality of life can cause kind of lead to a whole host of health issues, mental and physical. So and because of this, diabetes is associated with more serious mental disorders as well, like bipolar disorder and schizophrenia. When we're talking about bipolar and schizophrenia, one of the things I see in my practice is the unfortunate effects of the medications that patients go through, the side effects they have to endure when they are being treated with an antipsychotic. Most of the antipsychotics we use these days unfortunately have a lot of metabolic side effects, which can lead to poor glycemic control, just diagnosis of diabetes, cardiovascular disorder, and so many other different conditions that can hinder their lifestyle. So on top of having a mental health disorder, a serious mental health disorder like bipolar disorder, schizophrenia, now they will have to deal with just metabolic disorders. So that's what we see most of the time. So hopefully we can develop better drugs that can have less side effects, metabolic side effects. So, and also as these patients get older, having diabetes increase their risk of developing neurocognitive disorder due to vascular disease, due to hyperinsulinemia, and just poor glycemic control. The microvascular changes of the brain can lead to a diagnosis of neurocognitive disorder, which can directly contribute to early cognitive decline and leading to a diagnosis of major neurocognitive disorder and dementia. I'm not going to talk about this subject more than this, because my colleague, Dr. Manel Kasumanadilka, had a great presentation, and I think he did an amazing job talking about the link between diabetes and dementia itself. So I'll move on to diabetes and mental health. Again, when it comes to the diagnosis of depression, it's not just depression that we see. We see so many comorbid mental health disorders in these patients. Most common being depression, but also you would see anxiety disorders. You would see generalized anxiety disorder. You would see panic disorder, and even post-traumatic stress disorder, which is PTSD. So when you have these conditions, especially my favorite condition where I treat a lot of patients for PTSD, all of these conditions cause chronic stress. The impact of chronic stress in an individual is immense. This can increase cortisol. It can lead to increased catecholamines and just overall increase of inflammatory markers. So not surprisingly, most of my patients with depression are at risk for developing type 2 diabetes because they also consume more calories. They have more comorbid conditions, such as comorbid substance use disorders. They smoke more. A lot of them try to use alcohol to self-medicate instead of going to a mental health provider or a psychiatrist. They would try to, self-medicate with alcohol, which is a terrible way to do it. But I see this quite a bit. Even when we are treating them with medications, they sometimes, just resort to these substances, which would make their mental and physical health worse. So these conditions can lead to more inflammatory markers, and inflammation can cause many serious metabolic issues and just overall poor health. So, another topic is the HPA axis, the effect of how chronic stress can lead to chronic activation of the HPA axis, which can, in turn lead to activation of the sympathetic nervous system, which can, activate IL-6 and which is associated with the activation of the cytokine cascade. I'm not going to go into that subject because everyone's an endocrinologist here, so I'll leave that to the experts. But there's a direct link. But this does make me think of treatment options such as neuroendocrine receptor modulation to prevent complications from these disorders. So going back to mental health and diabetes, adults with diabetes, they found to have elevated rates of anxiety symptoms, and even leading to conditions including generalized anxiety disorder. The impact of anxiety is significant for a patient with diabetes because anxiety is associated with inconsistent, care, inconsistent diabetes management, poor adherence to treatment, and just decreased overall quality of life, which can lead to a worsening A1C values, and also just having that fear of hypoglycemia, just living with that fear of hypoglycemia, or even fear of the needle that they have to use every day to prick themselves, to check themselves. So these are things that sometimes people don't really think about, but all these things that patients have to do to kind of take care of themselves is anxiety provoking, and this can lead to chronic stress and chronic anxiety disorders, and also it can complicate just anxiety disorders can just complicate living with diabetes, and it can complicate the management. We also know that anxiety can resemble symptoms of hypoglycemia, making it difficult for a patient to kind of differentiate between, they can think, am I feeling anxious, or is this my symptoms of low blood glucose? Is that why I'm feeling this way? So that itself can be so confusing, and patients can differentiate between the two. And sometimes I've seen that some of the parents of type 1 diabetics, children with type 1 diabetes, have anxiety because they are so fearful they have this extreme fear of hypoglycemia in their child. So, these are some effects that people don't really think about, but we should start thinking about the effect it has on a patient's quality of life. Also, the fear of hypoglycemia can lead to patients maintaining the blood glucose levels at about target level because they're worried about having low blood sugar, so they would actually keep the blood sugar levels about the target levels, which can obviously affect their care. So now the link, we talked about the link between anxiety and depression and diabetes. The prevalence of comorbid health conditions is higher in people with diabetes than in general population. So that's a known fact. Type 1 and type 2 diabetes is associated with cognitive dysfunction, like we talked about it, which can cause cognitive decline. This is at a higher rate, and also when patients have these conditions, they can have low life expectancy. They have reduced life expectancy, especially with serious medical conditions such as bipolar disorder and major depressive disorder and schizophrenia. Patients can have 10 to 25 years less than you would if you didn't have this disorder. So reduced life expectancy of 10 to 12 years, which is significant, which is huge. So these are some serious issues to think about. Multiple factors can contribute to higher morbidity rates in diabetes patients with mental illness. They can have, like I mentioned earlier, poor diet, sedentary lifestyle, increased use of substances such as tobacco, which is linked to insulin resistance as well as cardiovascular disease, contributing to poor outcome, including hypertension, dyslipidemia and obesity. So you can see how it affects pretty much every aspect of their life. So what can we do as primary care physicians or as endocrinologists that deal with diabetes patients on a day-to-day basis? So I think the most important thing you can do is to identify the primary reason for a mental health referral. Don't be afraid to address this with your patients, because it's important to first identify and refer them to the appropriate resources so they can, deal with the professionals that are specializing in taking care of mental health disorders. When a patient comes to your office, look for these signs and effectively communicate to the patient about how you see these patients progress and how you see these signs and symptoms in other patients. So just trying to normalize them and challenge that mental health stigma and the negative attitudes, and kind of bring that to the surface and make it okay for them to address this, make it okay for them to think about depression and kind of normalize it and then say it's okay to have these thoughts about your diagnosis. It's okay to feel anxious about having low hypoglycemia. It's okay to be anxious about hypoglycemia, and it's okay to feel bad about what you have to go through. But if it gets to a point where you need to seek treatment, make sure you tell them that don't hesitate to let someone know. If it's pretty much any healthcare provider can do a screening. You can look for signs of depression, dysphoric mood. You can look for signs of anhedonia, hopelessness, helplessness, any suicidal ideation, irritability, and just if you notice a patient is a patient that used to be good, taking care of themselves, if you notice that they're going down, they are not as careful anymore, and they, you can kind of ask what's going on. You can ask them about their day-to-day mood changes, their sleep. You can talk about their appetite. You can talk about all these things that kind of would hint at a diagnosis of depression. And if you do see that, if you identify that, and I think the best thing to do is to refer them to a mental health provider, whether it's a psychiatrist or a social worker or even a case manager or psychologist, so they can kind of delve into this a little bit more and provide the right tools. I'm not going to address the tools today, but there's so many medications we can use. We can use psychotherapy, CBT. We can use different mindfulness tactics. We can talk about changing their attitude towards the diagnosis. We can talk about different interventions they can do or coping mechanisms they can learn to cope with these stressors. So, but I think having the awareness of the link between diabetes and mental health and being able to identify is the single most important thing you can do as a provider that sees these patients on a day-to-day basis. And we can have this conversation at a later time, but I really appreciate the opportunity to kind of bring this to our attention. Thank you.
Well, that was a wonderful session. Mayank, do we go further with the discussion, or should we start the next session? Do we have the time?
Actually, we have a time, but you can ask a couple of questions. But Dr. Praveen has not joined. He has a recorded session.
All right. Okay. So let's do this. I think we are bang on time for the next session. We have Kamlesh sir as well. Sir has joined, and with his permission, I would request to start the next session then. And how does that sound?
Hi, good morning. Can you see me all right?
Yes, sir. If I could just introduce you, and then we'll have you start the session over here. Thank you, sir, for joining on time. Dr. Kamlesh Kunti, sir, has his diplomas and fellowships, MRCP, FRCP, and a lot of credentials that go on and on. He is working as a professor of primary care diabetes and vascular medicine, University of Leicester. He's a director for NIHR, Multiple Long-Term Conditions Global Research Center, and director of the Applied Research Collaboration, East Midlands. He's also the director for Leicester Real World Evidence Unit Director and Center for Ethnic Health Research. He's the honorary professorial fellow with Department of General Practice, University of Melbourne, co-director, Leicester Diabetes Center, University of Leicester. He's a professor of primary care diabetes and vascular medicine, general practitioner. He Hockley Farm Medical Practice, Leicester, and he's a top researcher globally by the publication by Expertscapes. Over to Kamlesh, sir.
Thank you very much, Dhruvi, for those kind introductions. I'll just share my screen. Can you see my slides?
Yes, sir. Yes.
Okay. Well, again, thank you very much for IDF Southeast Asia for giving me the honor of presenting today. This is the presentation I made at the IDF in Lisbon, the disproportionate impact of COVID in ethnic minority groups. So the next few minutes, I'm just going to take you a few bullet points here about pre-pandemic inequalities, the epidemiology of COVID in ethnic minority populations, potential mechanisms for disparities, and recommendations to reduce these disparities. In terms of pre-pandemic, if we look at any country outside of India, we can compare the indigenous local population with ethnic minority populations. Ethnic minority populations always have worse outcomes, whether it's UK or US, where most of the data have come from. This is looking at the proportion of ethnic minorities living in the top 10% most deprived neighborhoods in England. As you can see, it's mainly the ethnic minorities on the right-hand side, particularly Pakistani, 31%, and Bangladeshis. Indian, as you can see on the left-hand side, are in not such in such deprived areas as the other ethnic minority groups. If you look at the vulnerability to infections, if we compare again, in most countries, we'll have more ethnic minority populations working in health and social care and other key workers as well. This is data from the UK. White British is about 20% working in health and social care, and other key workers. And other key workers are people who are working in education, public services, food, public health, and transport. But if you look at the Black African, Black Caribbean, Bangladeshi, Pakistanis, and India, if you put them all together, it's much, much greater than the white population. If we look at vulnerability to infection, the number of long-term conditions that people have from ethnic minority groups, as you can see, compared to the white population, which is the on the left-hand side, with the relative prevalence of 1, compared to them, relatively Indians, Pakistani, Bangladeshi, Black Africans, and Black Caribbeans have a much higher proportion, particularly from the age of 45 onwards. So these are all pre-pandemic disparities that were already present. So when COVID hit us in February in the UK, by that time we'd heard of data from homogeneous population like China, like Spain, like Italy, but no one had mentioned a signal of South Asians or Black Africans being more disproportionately affected. And this is the tweet I sent out on the 1st of April, you'll see, because friends of mine started phoning me and said, Kamlesh, we're seeing lots of patients in intensive care unit who are young ethnic minorities, Black or South Asians, with quite severe COVID. we've not seen this before. And I put this tweet out, and I had a lot of abuse from a number of people on Twitter. But just 2-3 days later, these data came out from the intensive care unit data, showing that about 30% of people in intensive care unit were non-white. And this was the first signal that came out that ethnic minorities might be worse off in terms of COVID and being admitted at a younger age as well. So we came out very quickly into the BMJ and wrote an editorial say, why is ethnicity linked to worse outcomes because of COVID-19? And at this time, we weren't aware of any factors, but we postulated there may be a number of factors that could contribute to this. And we set about with a group of a number of people in the UK and many people in the US to identify potential associations. So this was one of the largest studies that was published. We published this with Jonathan Valabji because we have some of the best data in the UK. So this is data for the whole of the English population, 61 million people. And after adjusting for a number of factors such as age, sex, deprivation, diabetes status, and region, we saw that Asians were at about a 40% increased risk of mortality due to COVID, and Black people about 70% increased risk. So this was the largest study ever done, and I think still is the largest study that's been done. A group was started looking at a systematic review of all the published studies, and we published this with a systematic review of 50 studies, over 18 million people, showing that a number of ethnicities were at higher risk. So this is risk of COVID compared to the local population wherever the study was conducted. And we see that Blacks had a twofold increased risk, Asians had a 50% increased risk, Hispanic 70% risk increase, and overall there was about 70% increased risk in ethnic minorities compared to the local populations. But when we come to mortality, there was no difference. So this was good news, that the risk is increased, but the mortality was the same. So if people were admitted to hospital and they got good treatment, we didn't see the signal of disproportionately affected in terms of ethnic minority populations. So then, the reason is, what are the potential mechanisms? And this is where we came out very early on from the South Asian Health Foundation in the UK, that a group of us got this publication out, saying these are the potential reasons. The green are where there was some data. Deprivation, age, we know was associated with worse outcomes, obesity, having comorbidities such as diabetes, cardiovascular disease, COPD, ethnicity certainly. And then the others where there was limited evidence such as occupation, housing, lifestyle, environmental pollution, and genetics. And still, we don't have much data on genetics, and I don't think COVID-19 is genetically determined, really. Another area such as vitamin D, where there was no evidence of any benefits in terms of giving vitamin D or harms from not having vitamin D. But this data still, vitamin D, we don't have any idea about. So numbers from India and UK conducted this systematic review, one of the largest first systematic reviews, meta-analysis of 18 studies, showing the pool prevalence for comorbidities in people who were admitted to COVID was not COPD. That's what we thought. This was going to be a respiratory disease, but it was hypertension, diabetes, cardiovascular disease. And we also saw that this is the estimated pooled effects in terms of mortality of severe COVID, which was mortality or intensive care unit. Hypertension associated with a 66% increased risk. Diabetes about twofold increased risk. CVD more than twofold increased risk, and COPD as well, and CKD. These are all conditions that are more prevalent in ethnic minority populations. Obesity is a factor we know puts people at much higher risk of COVID-19, but we knew this beforehand that such as glucose, cardiovascular disease are associated with obesity. And this is data we looked at over 20 million people in England and showed that the association of mortality with obesity was much greater for ethnic minorities. So on the left-hand side, you see the bottom blue line, that's the white population, and on top are the lines for South Asians, Blacks, and other ethnic minority populations. On the right-hand side, if you look at the hazards ratio comparing other ethnic minority groups to white population, we see there's a hazards increase from a BMI of about 23 compared to the white population. So ethnic minorities were at a much higher risk of mortality from a BMI of 23 compared to the white population. And this is, again, after adjustment for a number of factors. There were a number of other reasons we wanted to explore. We knew housing was an issue, multi-generational households. We know ethnic minorities, particularly Pakistanis and Bangladeshis, live in multi-generational households in the UK. So 3 or more generations living together. And here what we see is that ethnic minorities, particularly Bangladeshis, Africans, Black Caribbeans, they had a higher risk. Pakistanis even a much higher risk. And when we look at the factors, multi-generational households, particularly in Bangladeshi and Pakistani, played a role, but most of it was explained by socio-economic reasons. That's the green shaded areas. And the blue shaded is, there were factors that were unexplained for. Seroprevalence we looked at very early on, and again the reason was that the health and social care staff were disproportionately affected. The first 9 people from the healthcare sector to die were all of ethnic minority populations. These were signals that we noticed very early on in the UK. So this is data where we did blood samples on hospital staff members, over 10,000 people, and 10% of the staff members were positive, and this was really early on in the pandemic. And what we saw was that it was the South Asians and the blacks who were more likely to be seropositive compared to the white population. The highest seroprevalence were in nurses, people working ED, acute medicine, the most deprived healthcare workers, and people aged less than 30. So again, these were signals. A lot of it was determined by deprivation. As you can see, an expected anesthetic staff and ITU staff had a low seroprevalence. And we recently written editorial, literally it's just come out in the February issue, it's out now online, of the possible reasons for ethnic minority populations getting COVID-19. This is looking at diabetes. And it could be because of poor control measures, such as language barriers and not understanding the messaging, increased vaccine hesitancy, poor access to public health messaging, and possibly structural discrimination, worse social environment, poor working conditions, poverty, barriers to healthcare access, potentially racism, increased exposure, again, key workers, overcrowded multi-generational housing, increased contact with others residing in deprived areas, and then increased vulnerability, so increased stress, increased comorbidities such as type 2 diabetes and obesity that we've talked about. So then recommendations, well, we have had an effect of a natural disaster. We've just had a natural disaster in Turkey. So these are kind of things that will have effects on people being managed with chronic conditions in a healthcare setting. You could have indirect consequences. This is organization disruptions such as staff, supply of medications, protective equipment, or individual consequences, stress, social isolation, depression, poor environment, loneliness. And then the direct consequence, because people are not being seen with chronic conditions, so they have worse risk factor control, HbA1c, blood pressure, lipids, weight, which leads to complication and increased mortality. So you could have direct effect of COVID itself and indirect because you haven't been managed as well. How do we tackle this? Well, there are a number of things that we've suggested we should be doing. Short term and longer term, we need to address vaccine uptake, collect routine monitoring of data, increase screening of diabetes in ethnic minorities, look at culturally adapted self-management resources. We need to make sure now that we're doing a lot of access through remotely in UK, US, etc., that we don't increase disparities because people don't have access to internet or they don't understand the language or don't know how to get onto the remote access. We need to strengthen the science, and we've seen that during COVID, science has helped us enormously. Longer term, we need to reduce educational inequalities, improve housing, improve quality of employment. And this is some of the data showing where things improved. So when we had lockdown, this is looking in the green bars pre-lockdown, in the yellow bars post-lockdown. That lockdown helped every ethnicity, including the white ethnicities. if you look for both males and females, the huge impact COVID had pre-pandemic, pre-lockdown, and then after lockdown, there's a reduction of all in all ethnic minorities in terms of COVID-related death. So lockdown certainly helped. Access to protective equipment is something we should really help people get. And this is looking at data we looked for the whole of England in terms of access of protective equipment. And again, we saw that it was ethnic minorities and allied healthcare professionals compared to doctors who had less access to protective equipment. We also recommended that the ethnic minorities, not just ethnic minorities, but all patients should have an assessment of their risk as they were facing patients with COVID. And this risk assessment had to be at a workplace and a workforce assessment and an individual assessment. So making sure environment is protective as well as the individuals are protected. And most of it was based on sex, age, ethnicity, comorbidities, and pregnancy. So any healthcare staff who are pregnant, really, we need to have all the measures to ensure that they're not at high risk. There were a huge number of barriers and facilitators that we recommended for COVID vaccines. The barriers are very different for each population. So South Asians, African Caribbeans, people with mental health problems, people who are homeless, all of them have different barriers. And we need to have facilitators that are directly matching the barriers to overcome vaccine hesitancy. And we're still seeing this now. Ethnic minorities particularly are getting less access to COVID vaccines. You know, COVID vaccines are free in the UK, but we're still seeing this massive barrier. Again, UK has excellent data, so we developed risk algorithms. This is one called the Q COVID risk assessment. And as you can see, ethnicity is part of this. Chronic diseases like diabetes are part of this, body mass index, age, all the things that put people at risk. And when you put them into this calculator, it gives us a risk of that person potentially having COVID and having worse outcomes. On the basis of this, we prioritize vaccinations really early on when we didn't have enough access to vaccines. Long COVID is something that we need to start thinking about. Lots of data coming from long COVID. We showed this very early on, that people who were admitted, at that time, about 30% who were admitted were dying. But if they were surviving and were discharged within 140 days, 30% were readmitted and 12% had died. This is surviving a COVID admission. We also showed that this is a case control study in the green bars of people who had COVID related new onset diabetes, MACE outcome, major adverse cardiovascular events, chronic kidney disease and chronic liver disease. And you can see that compared to pre-COVID and the controls, people who had COVID were at high risk of these conditions. So long COVID, by getting all these conditions, is important. And we also showed that ethnic minorities were at a much higher risk of readmission. As you can see, this is non-white compared to white. The risk wasn't as high for developing diabetes, but we did see that there was a risk with particularly age and non-white ethnicity. South Asian Health Foundation, we came out with a number of recommendations for healthcare workers, and we developed these infographics for people from ethnic minority backgrounds, but you could use it for anyone really, in terms of what they should be doing. We had these adapted in different languages, culturally adapted, and I think a lot of people, even outside of UK, had used these. We gave specific messaging for certain groups. So Ramadan was just about to come when the pandemic hit us. So we came out very early on with managing people with diabetes during fasting and during COVID. And finally, we came with a number of recommendations about future research. So this is a systematic review we conducted of COVID-19 studies. And data on COVID and ethnicity was still limited. When we looked at the clinicaltrials.gov, at that time, 1,500 studies were reported on there. And from that, only 6 were collecting data on ethnicity. And we came with a number of recommendations that really to improve research findings and implement research findings to reduce the disparities, we need to start thinking about participants' ethnicity when designing and reporting research. And research funders, public health and policymakers really need to ensure that research represents the whole population. We also recommended the language of ethnicity should be changed. Globally, people are called BME or people of color, black ethnic minority populations, or BME, black minority ethnic populations. And what we found during the pandemic is that people didn't want to be called BME or BME. They preferred the language that they should be called ethnic minority populations. And we came up with recommendations that these are the minimum level of ethnicity data that should be coded. And religion is something that we've talked about being coded as well. So in conclusion, there's growing evidence of marked ethnic inequalities during COVID. This was present pre-pandemic, but we also saw during COVID that there was increased risk of infection and poor outcomes, and there's no single explanation. Social inequalities are likely to have played a major role, as we've shown and others have shown. And so we need to move forward and make sure that people are not worse off as we come out of pandemic, particularly in terms of healthcare access. For the future, we need to have comprehensive ethnicity coding and a comprehensive multi-sectorial approach, both health and social care, with academic partnership, with strong policy actions to reduce all the pre-pandemic inequalities I showed you. This is in terms of the diabetes. We came out that people with diabetes, we should prioritize ethnic minority populations. So now that we're opening up, people not been seen for 2 years in some cases. So we can't see them all at once because there isn't enough healthcare access. So we need to prioritize. So people who are at high risk are people who have high HbA1cs. Surely that should be greater than 8%. People with high blood pressure, people with CKD, high BMI, who have micro complications, macrovascular complications, ethnic minority populations, people with multimorbidity. We should see these people first. And the others who don't have these, then maybe see them later on, maybe a year's time. We could wait that long if we had to. This is my last slide. This is the one I'm most proud of. And what we showed here, this was a modeling study. On the left-hand side is COVID positivity, middle is having severe outcomes, right-hand side mortality outcomes. And what we showed that if we move 25% of the population, most deprived population, out of deprivation, we would half the risk of COVID, severe COVID and mortality. If we move 50% of the most deprived population out of poverty, then we would really eliminate this risk. And this really shows that COVID is because of social determinant of health, no matter where you live. Even in India, with a homogeneous population, we saw that the people who were poorest were affected the most. Thank you very much for listening.
It's really interesting to understand that, you know, across the globe, the ethnicities are affected in all of these different manners that you just elucidated. Thank you so much for a wonderful lecture. Can we have the second speaker's lecture, please? So we do have a discussion, dedicated discussion slot at the end after the three speakers. So can I request to move further? Our second speaker today is Dr. Jyotidev Sir. Jyotidev Sir is the chairman of Jyotidev's Diabetes Research Center at Trivandrum. He is also the Central Executive Committee member and the Vice President for Kerala RSSDI. He has a number of research in his name, and he's also the pioneer in cost-effective treatment of diabetes with the use of telemedicine and technology at Jyotidev's Diabetes Care Center, and which is an IDF recognized center. So with that, can I request the team to have his lecture, please?
Thank you, Dhruvi and the dear friends, for the nice introduction. Let me, first of all, extend my gratitude to Dr. Shashankji, Dr. Benshifai, Dr. Asad Khan, and the entire IDF Southeast Asia region for giving me this opportunity. And I am given the task of discussing smart insulin pens. Are they a cheaper alternative to insulin pumps in type 1 diabetes. So these are my disclosures. So when we are recommending insulin pump therapy, when we are recommending insulin pump therapy to even affordable people, a good majority of them will have multiple concerns. And these concerns are shared by even the current insulin pump users. They are really cumbersome. And you need to train them. And they need to be there for retraining. There are multiple circumstances where you have to troubleshoot. The insulin pump blockades are fairly very common. And choosing the site for insertion, another challenging procedure, and frequent blocks and alarm fatigues. And even for the affordable, it continues to be very, very expensive. So what is a convenient and a cheap alternative? It could be. I don't say that it is, but it could be the connected insulin pens, provided the cost of the connected insulin pens are also coming down and is affordable to the common man. So are they, the connected insulin pens, are they a replacement for the insulin pump therapy? My honest answer will be, they're certainly not a replacement, since the insulin pumps are much, much more superior when compared to the conventional insulin injections. I know that there is a huge audience listening to me, and these are the doctors from different regions in Southeast Asia, IDF, and there are also the diabetes educators, dietitians, and the diabetes supporting team. If someone is asking you the question, which is the best available option for treating type 1 diabetes, earlier we could have said it is the basal bolus regimen. And later on, it was insulin pump therapy. But now we are more realistic. It all depends on the level of motivation, the knowledge, the adaptation, the resources, and of course, in which country you are living. And these are multiple factors which can influence your choices. Are insulin pens better? They are better than insulin pens, but they are better. The insulin pump therapy, when it is a standalone device, can be considered superior only when it is used along with either continuous glucose monitoring or less preferably with glucose meters. However, I will say that standalone insulin pumps are inferior when compared to the currently marketed stage 4 of automated insulin delivery devices. And this is how we can compare the different options. How can you classify the connected insulin pens? They can be classified into TIPs, and these are the tracking insulin pens. The smart insulin pens, and these are the SIPs. And then you have the smart caps. And these caps can be attached to the usual insulin pens. So you should never forget the history. You should never forget the path that you have traveled. And this has been the journey of insulin pens. And it was Novo which introduced insulin pens in the year 1985. And this was a couple of years after the launch of insulin pump therapy. A pen with a memory function, and that is with respect to the dose which is delivered, was first marketed in 2007. And in 2014, the first enhanced pen cap was available. The US FDA approved the reusable smart insulin pen only in 2017. So it has all happened very recently. All those advancements with connected insulin pens. So the connectivity can be defined as those with built-in interface technology. And Bluetooth is classically the BLE or Bluetooth low energy. And then you have the near field communication. And this can be probably considered as a prototype from the Novo family. The Novo Pen 6 for adults and Novo Pen Echo Plus for children with type 1 diabetes. And this one, the red colored one, is capable, similar to Novo Pen Echo, to deliver even half a unit dosing. And these are the pens with 800 injection memory and the battery lasting for around 5 years. And this is the same one. And you can see this in the diagram, in the cartoon you can see that data is getting pushed. The Novo Pen 6 is connected to the mobile phone via near field communication. So these are all having those inbuilt wireless communication capabilities of transforming the data. For those who are enthusiastic, those who are having the academic enthusiasm on how we develop the stages from stage 0 to stage 5 of connected insulin pens. Stage 0 is nothing. These are the currently available syringes and the pens. And we are all probably in the developing world only in stage 0 of connected pens. Nobody has recognized the potential for developing the connected insulin pens, which is probably a relatively easier one and which is probably a relatively broad market. And this is stage 1, the tracking insulin pen with a retrospective dosing data available. And this is the stage 2 of automation where there is a real-time tracking insulin pen. It has insulin onboard data, reminders and data collected and stored in the cloud. And from moving from stage 2 to stage 3 of connected insulin pens, these are the integrated devices. And these are the integrated data management systems where you have, in addition to insulin dosing, the carb, the glucose, and so on. But once you reach stage 4 of connected pens, you are now stepping on to the smart insulin pens, and these are the SIPs with a dose calculator. And this is a dose calculator even for recognizing the auto prime detection and individualized for the insulin carb ratio, the insulin sensitivity factor. You can decide on the target blood glucose and so on. And the stage 5 is also available commercially in the market now. And these are the devices with features in addition to all of those I have described. In addition to Bluetooth, in addition to NFC, it is capable of basal insulin titration. It can deliver educational modules, coaching, and with advanced decision support systems. So the stage 5 will have an advanced decision support system as well. Moving on to the Bigfoot family. This is a major player with the connected insulin pens, and FDA has granted clearance to the Bigfoot Unity diabetes management system. So this gets connected to the Libre sensors, and instead of pulling out the mobile phone from your pocket, you can use the pen cap for scanning the sensor. And instead of looking at the mobile app for the dosing information, you get dosing recommendations right on top of the insulin pen cap itself. And in some of these devices, they have temperature sensors. Some devices have age sensors. So it will detect whether the insulin is out of temperature range and will give an alert. Whether the insulin is reaching the expiry date, when exactly you have started using the cartridge. And SIPs can also provide missed dose alerts. I would say that this is a very, very important component, since I would say that many patients who are on multiple daily injections either will forget to bolus or they will forget whether they have already bolused or not. And hence they will miss a bolus or will give an additional bolus. So where is evidence? Do we have studies pertaining to the connected insulin pens? Do you have evidence which has been generated from the connected insulin pens and the smart insulin pens? I will say when compared to insulin pumps, we do have only limited data, but we do have concrete evidence available. And this is again back to Novo Pen 6 in the 94 patients with type 1 diabetes compared to a basal bolus regimen earlier without the connected insulin pens in a real world settings with CGM. All the TAR metrics have improved. The TAR has improved by almost 2 hours in 24 hours. And there is significant reduction in level 2 hypoglycemia that is below 54 milligrams per deciliter, and a reduction in the time which is spent in hyperglycemia. And what about the missed boluses? The missed bolus doses have reduced by 43%. I will repeat it. In the study pertaining to the connected insulin pens, it has been found that the missed bolus doses have been reduced by 43%. And this finding alone is a compelling evidence for adopting connected insulin pens in our practice. And this is the history of how the delivery devices for administering insulin, for injecting insulin, has evolved. And this is right from the beginning of discovery of insulin in 1921. And currently, probably the best available devices will be the stage 4 of automation with the automated insulin delivery devices with advanced either MPC or a PID algorithm. However, our argument is at least 30 to 40% of those requiring insulin pump therapy in type 1 diabetes could be supplemented, could be actually having a comfort in reaching a TAR, avoiding time below range, with acceptable time above range, just with the use of smart insulin pen. And this is the only FDA approved smart insulin pen. Earlier, InPen was with Companion Medical, and now it is acquired by Medtronic. It wirelessly connects to the Guardian sensor. It automatically captures the mealtime dosages of insulin. It can keep track of insulin on board, and it avoids insulin stacking. It avoids hyperglycemia. The app also creates an easy, accessible report combining the entire data. And this is how it is displayed on a mobile phone. You have at the top the insulin dosing, and then at the bottom, the continuous glucose monitoring. So both the dynamics are there. And it even provides a manual option for logging in the basal insulin data. InPen currently works with all the rapid-acting insulins. So this can be used along with all the other insulins. So now the question is, why should I recommending a smart insulin pen? Those patients who are on multiple daily injections, either type 1 or even type 2 diabetes, with a dose calculator, it provides dosing recommendations based on multiple factors. Not only the insulin carb ratio, individualized insulin therapy settings are available. And those patients who are on precise dose of medications, those are counting the carbohydrates, using variable dosages of insulin for each meal, the maths appears easier. The SIP can vary the insulin therapy settings, similar to the options available in the insulin pump, to decimal point precision over 4 variant time periods. And there are international standards to prove the accuracy of the device. And this is ISO 116081 standard for the pen injectors. The devices should demonstrate accuracy after being subject to the extremes of temperature, extremes of humidity, extremes of vibration, free fall drop test, dust, and even exposure to moisture. And for individuals with small dose requirements, even half a dosing allows more flexible, and that too with dosing recommendations. So what are all the overall benefits? Those are having recurrent episodes of hyperglycemia. Those are having history of recurrent admissions for diabetic ketoacidosis. A proven glycemic variability contributing to mood changes, psychological distress. Those are forgetting whether they have bolused. Those are having difficulty in doing maths for calculating the dosages of insulin. Those who tend to give doses which are different for different meals. Children with type 1 diabetes, older individuals who are finding it difficult to calculate the dose of insulin. Women with type 1 diabetes, many of them are probably recommended insulin pump therapy, but they probably will be comfortable with a connected insulin pen. And even in the hospital setting, the nurses, the caregivers, the healthcare workers working in the hospital will find these devices much more handy, much more beneficial in avoiding hyperglycemia. It reduces the number of days in the hospital. It reduces the overall mortality in the hospitalized patients when you are successful in maintaining more time in acceptable range. Look at the growth of the connected insulin market. The connected insulin pen market is amazingly growing at a faster pace. And this has been in 2021 US dollar 97.6 million. And the projected worth is around $305.87 US dollars in 2030. And in 2021, the home care segment alone contributed to 25% market share. So this is definitely growing, but I think many policy makers have probably not identified this segment. And this is Diascend and this is now Gluco. You can probably download or can push in the entire information into these platforms. The ulterior objective of Gluco is also to provide the physicians and patients with the optimal time within range. And this is the newest one which is getting added on to the connected insulin pen segment. And this is the Malia medical device. And this is just a smart sensor, which can be used along with not only the insulin pens, but also with GLP-1 based therapy drugs. So when comparing the merits, with the demerits of using pumps with connected pens, the pumps are expensive. They are more sophisticated and difficult to teach and also difficult to maintain. Whereas the connected pens are relatively cheap. They are relatively simple, but we cannot have a variable basal rate with connected insulin pens. And completely closing the loop is also not possible. And the cost is somewhere in the middle. Somewhere in the middle. They are cheaper when compared to the advanced delivery devices, such as the automated insulin delivery devices. And this is 780G, which is much, much superior. However, when compared to a conventional insulin pen, it has got an algorithm. It has got integrated diabetes management system and is capable of even suggesting the dosage of insulin and connects with CGM sensors. So in a nutshell, and this is my conclusion. The connected pen, though it is relatively expensive now, can be made cheaper for the developing world. And this can be an efficient substitute for more than 40% of those people with type 1 diabetes currently on insulin pump therapy. And with the simplicity and with the advantage of cost, it is at the expense of automation. But this is definitely superior in terms of algorithms and in terms of wireless connectivity. So thank you very much, my dear friends, for listening me and for giving me this opportunity.
Thank you. That was a wonderful lecture by Dr. Jyotidev, sir. Without much further delay, can I request the RX team to display the CV of our next speaker? Our final speaker for this session is Dr. Prasad Katulanda, sir. He's a consultant endocrinologist and diabetologist and a senior lecturer from the University of Colombo. He has graduated from the University of Colombo and has a lot of awards to his names. He's got a number of publications, and one of the leading one is the diabetes epidemic in Sri Lanka, which is a growing problem. He's got a multiple fellowships and is the member of International Diabetes Epidemiology Group, is a member of Sri Lanka Diabetes Association and member of the Ceylon College of Physicians. So with that, can I request Dr. Prasad, sir, to start sharing his screen and with the presentation, sir?
Thank you very much. And first of all, let me thank the organizing committee, Banshi and Professor Shashank and Dr. Asad Khan for inviting me. And am I given permission to share the slides? All right. So today I'm going to talk to you on the SGLT inhibition and the South Asian real-world experience. Just for the junior doctors who may be in the meeting, we know that most of the glucose that is filtered from the glomeruli, 90% is reabsorbed. And this is where the SGLT2 inhibitors come in and inhibit and leads to a lot of glucose being wasted. So this is again a similar picture. So it's not only glucose that gets wasted due to this action of the SGLT2 inhibitors. The glucose gets wasted with sodium. So sodium and glucose goes to with the urine. And you can see these data. There are a lot of studies that have shown that in patients with both type 1 and type 2 diabetes, compared to the control subjects, there's increased reabsorption of glucose in the kidney tubules. So in the people with diabetes, if they do this inhibition, the effect is more than for the people without diabetes. So based on this pathophysiology and the mechanisms, if you work out the increased glucose excretion leads to reduced fasting and postprandial glucose and the reduced A1C. Loss of energy and calories would lead to loss of body weight, and increased sodium excretion would lead to reduced sodium load and the reduced blood pressure. So this seminal study, the EMPA-REG study, published in the New England Journal and was carried across many countries in the world, where they recruited a lot of people with diabetes having more than 10 years, and many of them, almost everybody, had pre-existing CVD, so they had very high cardiovascular risk population. And also many of them, because that they were having long-standing diabetes, was on insulin, and many on ACE inhibitors, ARBs, many on statins, and many receiving antiplatelet therapy. And this study actually really stunned the world with its findings, because when it showed that the primary outcome, 3-point MACE, cardiovascular mortality, non-fatal MI, and non-fatal stroke, all were reduced within a very short period of 4 years. And this was also followed with the demonstration of reducing cardiovascular mortality, all-cause mortality. None of the studies had initially shown the possibility of reducing all-cause mortality within this much of a short time span in any clinical trial. And also it showed that people were able to be reduced in their heart failure, hospitalizations, and the postulated mechanisms were mainly along with the pathophysiological mechanism. I have shown that there's early and sustained reduction in plasma volume with the empagliflozin. And also, if you look at this postulated mechanism, the typical loop diuretics will reduce blood volume as well as interstitial volume quite in a similar way. So the loop diuretics reduces the interstitial volume by only 78% of its reduction in blood volume. Whereas the SGLT2 inhibitors, if you look at here, to the reduction of the blood volume, it reduces about twofold reduction in the interstitial fluid volume. So these are the mechanisms which are postulated for the benefit of heart failure improvement, along with the improvement of cardiac metabolism. Whereas in the typical type 2 heart, is increased fat oxidation, reduced glucose oxidation, reduction of phosphate to oxygen ratio, which gives an idea of ATP generation from oxidation. And because of all these reduced cardiac work efficiency, so all this leads to a dilated sort of a failing heart. Whereas the SGLT2 inhibitors have shown that they reduce fat oxidation but increase glucose oxidation as well as ketone body oxidation, and increases the phosphate to oxygen ratio as well as increase cardiac work efficiency, which improves cardiac myocardial contractility as well as the reduction of the incidence and progression of heart failure. So the EMPA-REG study, they looked at the effect on the progression of kidney disease. They looked at macroalbuminuria, doubling of creatinine, initiation of renal replacement therapy, or death from renal disease, and the incidence of albuminuria. And when you looked at these data again, they were very remarkable and impressive improvement in the renal outcomes when they used empagliflozin. And also they showed that empagliflozin slows decline in renal function. So people wanted to see whether this was a class effect. And there are a lot of other studies with other molecules like the canagliflozin, the CANVAS program, declare-TIMI, the dapagliflozin, and the credence, again, canagliflozin on renal events were all designed to look at the similar effects on other SGLT2 inhibitors, all of which looked at long-standing diabetic people with high CVD risk and significant nephropathy. If I show you these 4 studies, again, all of these studies showed that they improve heart failure outcomes, cardiovascular outcomes, major adverse cardiovascular events. And so they were quite similar in all these outcomes for empagliflozin, canagliflozin, dapagliflozin. So that showed that these were class effects. And then people looked at the adverse effects and disadvantages, which showed that genital infections, as expected, because this leads to a lot of glucose being excreted in the urine, were very common in all these agents. And then UTI was a bit of a question mark because some thought that their UTIs were not very common. Then reduced EGFR, particularly in the early phase. And then volume depletions. Canagliflozin, first study, the CANVAS showed increase in amputations and bone fractures, not much in the other studies. And the other issues were the cost, diabetic ketoacidosis, euglycemic ketosis, as well as venous gangrene. But now let's look at the unique South Asian phenotype. They get diabetes at younger age of onset, and they have long duration of diabetes. They have higher visceral obesity, poor beta cell function, higher cardiovascular and renal complications. They take high carbohydrate diet because of the unique socio-cultural practices, and they live in the temperate climate. And also, if I further elaborate this metabolic difference, this is the sort of the typical European ethnicity. You can see they have both high lean mass, which signifies metabolic capacity, and their fat mass comparatively is low. So the metabolic load is comparatively low. But if you look at the South Asian ethnicity, they have lower metabolic tolerance because compared to the lean mass, they have a higher fat mass. This is one of the major problems in South Asians. In addition, there are other issues, as I showed earlier, all of which can cause problems with the SGLT2 inhibition. So are SGLT2 inhibitors effective and safe in Asians? This subgroup analysis, again from EMPA-REG outcome trial, looking at South Asians compared with all the participants, had shown that when it comes to all-cause mortality, heart failure and CV death, as well as incident or worsening nephropathy, there is hardly any difference between the total study sample and the Asians, as well as when you compare different BMI groups. And again, in this data, they have looked into the pooled analysis of 4 phase 4 trials, looking at 10 mg of empagliflozin and 25 mg of placebo monotherapy added to metformin plus sulfonylurea or pioglitazone. You can see the comparison of the different groups and the effect of 10 mg versus 25 mg of empagliflozin. Looking at here you look at the HbA1c. All these groups showed impressive reduction of HbA1c. Similarly, body weight, similar to the EMPA-REG study, and also reduction of systolic blood pressure, and to show that they have higher risk of particularly genital mycotic infections compared to the placebo. There's marked increase in the genital mycotic infections. And this study shows similar data on dapagliflozin. And again, you see quite similar to the data I showed for the EMPA-REG. there's impressive persistent reduction of HbA1c and the body weight, and the initial dip of EGFR and subsequent overtaking of the EGFR to the placebo in the SGLT2 inhibitor dapagliflozin group. And then there was again not much difference in the side effect profile, including surprisingly genital mycotic infections, although they are higher, not very markedly high. In this study, they had looked at the effect of Ramadan fasting in patients without SGLT2 inhibitors and SGLT2 inhibitors. And again, even these groups, they have not shown a significant increase in the ketone bodies, the beta hydroxybutyrate, as well as any changes to the blood pressure. So even in people who undertake Ramadan fasting, the studies have shown that SGLT2 inhibitors are safe. So let me now take you through some of our own data from Sri Lanka, looking at the efficacy and safety of empagliflozin. And here we have published this study recently. This was a retrospective analysis on patients with type 2 diabetes in a specialized clinic in Colombo. And all are adults, and we enrolled 2,070, but complete data was available for about 1,500 people. And most of the people, if I show you, they are around 50 years and fairly long diabetic duration with HbA1c like around 8. And so we excluded the standard exclusions for the SGLT2 inhibitors, and also people potentially having advanced renal disease, and then previous limb amputations, recurrent genital mycotic infections, and so on. And the protocol was to use either 10, usually most of them received 10 mg of empagliflozin, so a very small percentage received 25 mg, and treatment was discontinued if people got intolerance due to the osmotic effects or infections, and if their creatinine significantly rose more than about 30% from baseline initially, and anybody who got DKA. I have shown this before. So you can see there's quite an improved HbA1c quite within the first 3 months, which was persistent up to about 12 months. And even beyond 12 months, this effect was seen. And then we looked at the various factors that may interfere with this one. And the most important thing was that the higher the A1C, the more the improvement of the HbA1c, which is generally the fact in most of the studies looking at the HbA1c versus any diabetic intervention. You can see most of the people compared to baseline were able to achieve, not most actually, many people were able to achieve a good glycemic control and persist on that good control even up to 12 months. And this is something that is unique for the SGLT2 inhibitors. And then, as I told you, the higher baseline predicts improved HbA1c reduction, shorter duration of diabetes, greater relative weight reduction, and then higher the number of anti-diabetic therapies at baseline, which again signifies generally high HbA1c most of the time. And then you can look at the effect on body weight. Again, body weight comes down and does not go up usually as they continue the empagliflozin. The mean the body weight reduction is about 3 kilos, quite impressive reduction of body weight. And then this was irrespective of baseline weight, BMI, A1C, and EGFR. Again, you can see compared to baseline, those achieved better BMI were able to maintain the BMI all throughout the study period. Again, similar to the curve that we saw for the EMPA-REG and other studies, there's initial decline of the EGFR followed by improvement, and then perhaps improving further with time. The EGFR again very reassuring and also impressive. And again, systolic blood pressure, there's reduction quite early as well as the persistent maintenance of blood pressure control was also seen with the empagliflozin. The mean systolic blood pressure reduction was about 5, and then there, irrespective of other factors, the blood pressure improvement was quite sort of uniform. So unfortunately, since this was like a retrospective analysis, we could not get cardiovascular outcomes, which was a bit of a drawback in the study. And these were the adverse events documented in our patient group. The genital mycotic infections, as expected, was the commonest, followed by the other standard ones. We saw quite a number of patients getting hemoconcentration, and as a result, we had to stop the SGLT2 inhibitors. And then there were no amputations, no significant DKA. Actually, there were 2 mild DKAs, and then we did not have any patients with furious gangrene. See, you can see the adverse events that needed discontinuation, quite common during the first period when we start the treatment, particularly the genital mycotic infections are commonest during that period, gradually comes down. And then the other issues like the weight loss and so on becomes important as time passes, and people are a bit, reluctant when they get too much of weight loss. And then hypoglycemia. Actually, we saw hypoglycemia, particularly because these patients were on polypharmacy. And however, the good thing is that none of the people had very significant severe hypoglycemia needing hospitalization and very major, hypoglycemic coma and so on. Mycotic infections, as I told, about 10 per 100 patient years got mycotic infections, and about 58, that is 6.7 per 100 patient years needed treatment discontinuation. The risk factors for the male gender, younger age, higher baseline EGFR, and then the lower baseline A1C. These were the risk factors for genital mycotic infection. So selecting the right patient is very important if you are to get the maximum benefit and to have the least harm. So most likely to benefit are people who are obese, non-insulinopenic people, established cardiovascular disease, heart failure or heart failure risk, and also having or at high risk of CKD, and also poorly controlled glycemic status. And then we need to be cautious, avoiding people with DKA and people who are insulinopenic, possible LADA or others with insulinopenia, history of genital infections, recurrent UTI, quite low EGFR, elderly, and particularly those who are on drugs like NSAIDs, diuretics. We have to be cautious to prevent volume depletion. So SGLT2 inhibition in Asians, if you go back again to this diagram, so since people have sustained efficacy, this is an added benefit because people with type 2 diabetes in Asia, they get young onset diabetes. So having something with sustained efficacy is very important for them. And then we have higher visceral adiposity. And since the SGLT2 inhibitors reduces our adiposity, again, particularly beneficial. And then we know that we have low beta cell function. And since the SGLT2 inhibitors act independently of the beta cell function, again, that is an added benefit. And also, we know that our people have higher cardiovascular and renal complications. Again, these agents particularly having benefits on cardiovascular disease and renal dysfunction, also particularly beneficial. And then we know that we have a lot of cultural issues like Ramadan fasting, high carb diet, and because it has been shown to be safe even during Ramadan fasting, and also because it leads to a lot of glucose wastage with urine for South Asian peoples with particularly high carb diets as well as some of whom go into Ramadan and other types of fasting, this is safe as well as beneficial. Again, although we thought that because of the temperate climate and whether this can be harmful for South Asians, so far, luckily, we have not been able to see very adverse outcomes in terms of side effects. So we have comparable safety data to the people living in the Europe and North America. So this is again reassuring. So ladies and gentlemen, with that, I would like to end my presentation and again thank the organizers for inviting me on this talk.
Thank you, sir. Thank you. That was indeed wonderful. We can take up 1 or 2 questions, and we do have 10 minutes before we start the next session. RX team, do we have any questions?
Not as of now.
All right. Dr. Katulanda, if I may ask you, it's always interesting to learn how SGLT2s are affecting us Southeast Asians in a different manner. But can you just enlighten a little bit about the gender disparity, or how may I say, how do the SGLT2s affect the different genders differently?
Actually, what we have noticed is that because particularly South Asian non-Muslim males, because the Muslim males, because they have circumcision, a lot of them tolerate the SGLT2 inhibitors without much problem. As far as my experience from Sri Lanka, actually, almost nobody gets major mycotic infections in this population. And it is universal generally for the Buddhists and the Hindus and Christians, particularly the genital mycotic infections. For males, you mean the balanitis. For women, actually, this is little less common, but still we see some women also get vaginitis and vulvitis, and again some of them they get recurrent infections. And the unique thing is that people who get this problem sometimes go on getting, and whatever the hygienic measures they practice, sometimes they cannot tolerate. So that is something very unique. So if somebody gets recurrent infections, particularly, it's very wise to leave them alone and find some alternative therapies.
Thank you, sir. If I may also ask a question to Dr. Kunti, sir, it was really I did not read any papers wherein COVID-19 and the Southeast Asian minorities, how they are getting affected everywhere. If I may say, the data that you presented, so the disparity, and you said 25 to 50% of that could be prevented or with proper sort of knowledge, with proper sort of education. Am I understanding correct when I say that? That's what one of your slides said, that we could prevent that from happening and prevent the exposure from happening if we have the proper sort of resource.
As I showed you, the relationship between COVID-19 ethnic minority groups is quite complex, and we will never get to determine what exactly causes this. What we do know, and there's a number of factors, which includes education, jobs, housing, predisposed conditions. But a lot of this, if we get people out of deprivation, this is whether they're ethnic minorities or non-ethnic minorities, you will reduce that risk significantly. So most of this is because of the wider social determinants of health, rather than anything per se about ethnic minority groups.
Can I come in for a minute on that?
Yes.
Actually, we have got some very interesting data, which is almost in print like. We showed that cigarette smoking and alcohol is a very significant risk factor for getting COVID. So as understandingly, because people, when they smoke, they don't wear masks, and then they drink in groups. So this was found to be very important risk factor. And the other thing that we found in our studies in Sri Lanka is that people with actually diabetes, kidney disease, they get COVID less because people are more careful. They stay at home and so on. So that is another thing. So I think again, as you said, it is mostly because of their the being not careful and not following the good practices of disease prevention.
As I said, smoking and alcohol, they're again very socially determined. Deprived populations are more likely to smoke and have high intake of alcohol. So, if we get them out of deprivation, as we've shown, you're less likely to get COVID as such. In terms of diabetes, chronic diseases, majority of the studies, so we did the systematic review, majority of studies are showing that people with chronic diseases have a much higher infection rates and worse outcomes as well. But there may be particular groups who are, again, well educated if they've got diabetes and they may not have as high exposure because they're taking the prevention measures.
Yeah, definitely.
Yeah, thank you. Thank you. It has been a wonderful session and a very interesting one for that matter. I take this opportunity to thank all our esteemed speakers, Dr. Prasad Katulanda sir and Dr. Kamlesh Kunti sir for their wonderful lectures, and also Dr. Jyotidev sir, who sent us his recorded lecture. So with that, should with your permission, should we close the session?
Thank you very much.
Thank you. Thank you so much, sir. So I again take this opportunity to thank our organizers and the brilliant idea, idea of the person, Dr. Banshi Sabu, sir. And I request Dr. Sanjay Reddy, sir, who's a leading diabetologist and a physician, to take forward from the city of Bangalore to take forward the next session.
Hi, thank you, Dhruvi, and nice seeing Prasad after met him at Lisbon. Welcome to the session. And the session, I have the CV of all the speakers. Are they present? Am I audible?
Yes, sir, you
RX
are.
event, can anybody say that I'm audible and visible?
Yes, sir, you are audible and visible both. And we have
can I get Dr. Apurva Gambar, Dr. Sana Jmal, and Dr. Emma Clackman? So to introduce Dr. I was going through the CVs before I could get to what to ask them in this panel. And I'm really impressed by some of their CVs, which were different than what I generally come across. So Dr. Apurva is a physician from India, interested in global health, centered around pediatric diabetes, health equality, disease epidemiology, and improving access to care in low and middle income countries. She is a Global Health Equity Research Fellow in the Division of Global Health Equity, Birmingham and Women's Hospital, after graduating with a Master's in Public Health in the Department of Global Health and Population from Harvard Chan School of Public Health. She has worked in type 1 diabetes with global organizations. Research interest focused to health system, strengthening to overcome health disparity, diabetes care globally, and looking for solutions to complex problems using evidence, data, and cross-sectional collaborations. She also serves as one of the WHO Advisory Committee group experts on diabetes for WHO's leadership and coordination role in promoting and monitoring global action against diabetes. Though it's early hours for you, welcome to this program. Can I have the next speaker, please? Can I have the CV of the next speaker? Dr. Sana Jmal is the founder and executive director at Meeti Zindagi in Pakistan. Sana has been living with type 1 diabetes since the age of 15. She also PhD computer is a certified diabetes educator, worked extensively volunteering, partnership, and consultancy experience with various national
Sorry, Sanjay, I can't hear you. Is it my internet or?
No, I cannot hear Dr. Sanjay either, Sana. I think there's an issue with the network there.
No worries.
Mayank, could you call up Dr. Sanjay and
he's a public health professional, has been living with type 1 diabetes since 1999. Okay, we have two type 1 diabetes people living with type 1 diabetes. None other better than them to explain to us all the three. Even Apurva, are you a type 1? I can't. Okay. I'm sorry. I've been working with type 1 diabetes children for the past 22 years. We run 33. We coordinate with 33 centers in the state of Karnataka with Dr. Prasanna and the team, and we run one of them, but with settings which are very limited, and probably Dr. Sana will understand what type of resource, and you being from India and read here, and you know what are the challenges. And I think Dr. Emma knows all of this because she's been working with them too for a long time. Now I'll start with Dr. Emma, trying to ask her to go, since she's been working with the IDF and the global indices of type 1 diabetes in children and adolescents, and what IDF has to say about it, and what are the recent JDRF which were released on type 1 diabetes indices. So can we have a small spotlight on that, please, Dr. Emma?
Sure. Thank you so much, Sanjay, Dr. Sanjay, for the introduction. And it is such an honor to share this spotlight with Sana and Apurva. Sana and Apurva have taught me so much about being an advocate, being a health professional, and encouraging the global community not to stay in their own lanes and to push boundaries and to all have a seat at the table. So it's just an honor on this Sunday to share the spotlight with Apurva and Sana and to be with you also. Thank you so much to Dr. Sabu for the invitation as well. It's an honor to represent Life for a Child here. So, Dr. Reddy, I think you asked about the way that I interpret your question is really about all of the data that is coming to fruition around type 1 diabetes globally. And I think, for a long time, we've, in the last 2 years, I think you could say that we've seen at least type 1 diabetes have a spotlight on the global agenda that really has been unprecedented. But that still is to say that the messaging around type 1 diabetes in the global agenda is nothing new to this community here. We have been in the same echo chambers for decades, actually talking about what we're talking about on the need for data, on the need for cost effectiveness and health economics arguments, and on the need for advocacy and, to an extent, task shifting of healthcare professionals as well. But I think that, in the last 2 years, particularly since 2021, we have hit this incredible pinnacle of global attention and a window of opportunity to shine light really on the true number and need of type 1 diabetes around the globe. And so Together, Life for a Child and JDRF published the T1D index, which, contributed to massive holes and massive gaps in data. And of course, it is modeled data, but it opens up the precedent for the need for more country level epidemiological studies to go ahead and to take place. Because one of the reasons I feel so excited about all of the data and the T1D index is because if we look around the globe and we do a landscape of health systems providing aspects of very basic aspects of type 1 diabetes care, like just test strips and insulin, we'll find that provision of these very basic supplies against the backdrop of AIDs, CGMs are grossly undersupplied. And so, one reason I think for this is because countries and national stakeholders have traditionally never had access to numbers and data and understanding the true need. So I think that when country level policy advisors and those who can make decisions when the rubber hits the road in terms of procurement of medicines and supplies see the need out there, it would be incredibly inhumane to not act on that. So I think there's been so much produced in the last couple of years, but now is the time that we really need to push that data into the hands of those who can make decisions. Thank you for the question.
Thank you, Emma. That was passionate answer, I would say, and that comes with a lot of insight into say, and a lot of care you have type 1 children across the world. Thank you very much for that answer. And I move on to Dr. Sana. Dr. Sana, you've been a diabetic educator. You're one of a kinds in the country, in your country, to start off an initiative. Though you've been a technologist, my question to you is: we've been educating type 1 diabetes children. How do you see this educated type 1 child has changed over the years from the time you practice to what you foresee in future? And I see the biggest gap still remains there in spite of training the children, the parents, especially in countries where the social, cultural, economic disparities are huge. And I think we share similar, or all of us have experiences in our countries with the level of difficulties we face in this education. Can you throw us more light and what you would foresee for children to do better? Or
Thank
we
you
do
so
better?
Much. Thank you so much, Dr. Sanjay. And again, it's a pleasure to be here. And thank you so much to Dr. Sabu for this invitation. And it's an honor to be presenting here with Apurva and Emma, who I've seen over the last decade do a lot of work related to type 1 diabetes and advocacy. And because together we are stronger. So I would like to start with echoing what Emma was talking about, was the data. And when we talk about education, as you just questioned me, I think the education in itself cannot do much till the time the disparities, the inequalities are there. So, for example, talking about a child, and I've told this a couple of times at international fora. There's a child, for example, living in remote Tharparkar Desert in Pakistan, and the nearest road to that his straw hut is, let's say, a 20 minutes drive away, a 20 minutes walk away from, and this child, all he has access to is pre-mixed insulin. Now, the child has access to only one meal a day, and that too might be picking some berries from the bushes that they're eating. Such a child on premixed insulin, whenever you try to understand the clinical outcomes, they're always going to be poor, because he'll have a hypo once, he'll have a hypo twice. The next time the family will stop giving him insulin, no matter how hard you try to educate him or her. The disparity, the inequality between the haves and the not haves needs to end for anything to be successful. And this is worldwide. I'm just sharing a story which I know firsthand. I've gone to the house of the child, and it was actually painful to even try to understand how this child is managing with a premixed insulin while a month. So having said that, when we talk about education and when we try to knit these stories into the data, sometimes the stark realities of life get hidden in that larger data set. And one thing that I think is very important for all of us to understand is that when we're carrying out studies and when we're trying to bring out the clinical outcomes, we must not forget the stark realities of life and the quality of life that has to be built into that treatment option that we're trying to investigate, or even when we're trying to educate these people. One thing, one opportunity lies in, and that COVID has taught us, is the use of digital platforms. So one thing that can be, and of course, now this child that I'm talking about might still not be able to access a digital education platform, but a larger percentage of people would be able to access a digital education platform as compared to what we can provide through centers in the country. If I talk about Pakistan, the public healthcare accounts for only 30% of the healthcare. Now, these 30%, of course, does not cover the whole country. You provide a digital education platform which is free to use, and the internet penetration stands around 70%. There's a huge gap that you're filling, at least a 40% gap that you're filling by just providing this digital education platform. So these are the kind of things that we need to look at. The second thing that is very important in education is the community perspective. So many a times, the education needs to be able to speak to the community and address the concerns that they have on a day-to-day basis. It's very good to have a structured education course, but many a times, in my personal experience, they're probably not talking to the person who's being educated. So we really need to build in the community perspective into the educational programs, whether they're structured or more organic. And we also need to build in the community perspective into any digital platform as well. So I don't know, but it might vary from place to place. I might find it easier to be educated by a fellow type 1, or some people might find it better to be educated by a doctor, but that would vary. And the kind of diversity, this kind of diversity needs to be there to make sure that everyone has access to some level of education so that they can manage their type 1 diabetes well. And I just hope this has answered your question.
Yes, thank you very much. That's a very practical view from where I come from. And then what we do is education can be, as you told, technology can be used. You have certain things which are common, but in a country where there are different, like a research force setting, where you don't have food, forget about insulin, the second part. And then second comes the insulin, not the type of insulin, nor a monitoring device. So there you individualize and tailor this education. That's the key to take forward, but nevertheless need to talk about this education. And I'm very happy that we have people across the world trying to look at it. I've been working now for a short period of time to live for insulin, LACF, and I think they're coming to Bangalore on the 15th we have a meeting so that we get a registry for the first time in India, starting with the state of Karnataka. I don't know, that's the first step forward because we have the largest database of that in the state. Now, moving forward, and I want to talk to Dr. Apurva, who has been in the country where there is limited resources, and moved to and been working in the United States where there are resources. I understand that the resources for type 1 diabetes are much better than anywhere in the world. But at the same time, she's been working with the WHO and been an advocate of healthcare disparities. I was talking 10 years ago to Dr. Samuel Plain, not Dr. Samuel, Sam Degago-Jack, who was the president of the ADA, and he told me there was no insulin manufacturing plant in whole of Africa, except for South Africa. And suddenly it hit me very hard. I said, then what about the whole African subcontinent? And there was somebody from the WHO sitting there, and I asked them, does WHO look into this? I'm not sure. That's not my work. But I just asked this question. This was 10 years, a decade ago. And I want to ask Apurva, what WHO, as an World Health Organization, and you've been member or collaborating or giving your expertise on this, what is WHO trying to do for trying to do some sort of gap, bridging this disparity gap in terms of insulin availability, supply, distribution, or probably anything to do with type 1 diabetes care to at least save a child, forget about, I'm not looking at other things, to see that insulin is available to certain parts of the continent or certain parts of the world where it's very difficult even to access insulin.
Thank you so much, Dr. Sanjay. And I think this aligns very beautifully to what Emma and Sana really plays the background of, that yes, we need data. We don't have information about that. And then there are existing disparities even within the countries. But if you see from a global lens, all of these challenges kind of point down to the health system inequities and the fragmented health systems. Like I can give you an example of India right now, because I did my training, my medical school, and I was born as a person living with type 1 diabetes, surviving in a country like India, where I was going through the similar challenges as well. And I totally understand when I was treating patients in one of the busiest hospitals in Delhi, I realized that we ultimately come down to the existing social determinants of health when we are treating type 1 diabetes. We can't just prescribe a patient insulin and just leave it to that person to find out insulin education, which Sana pointed out really well. And ultimately, the person is all by himself, even if we try to give the support system. So I think the fragmented health system really puts a huge background here for us to think that yes, there are challenges existing, and we think that yes, US is a very high income country, everything is available, but we have to see that there are existing disparities even in a health system, which we think is supposed to be covering up all type 1 diabetes. It's not about getting access to high technological devices, but there are existing inequities, even when we see racial inequities, even economic inequities. So all of them are health system challenges, and we often forget that when we are seeing it from in a one room clinic. But when you see globally, when you see the data globally, the challenges across all countries are varied. It comes down to access. Yes, you clearly pointed out Africa does not have any its own manufacturing site. There are challenges because insulin pricing has a huge monopoly in the market. That's another big challenge. And yes, we've been fighting for that from a high income perspective, but also people in India, when we do have our own biosimilars being produced, there are still challenges. Even if you reduce the price of insulin, there are still 70% of the population who cannot afford those insulins. So the challenges are at all levels. And if you see from a WHO, from a policy perspective, we often think we have to think about diabetes from a top-down approach. But what we are seeing is just a very small lens of what diabetes is doing. And I think Sana has worked on really grassroots level. She's seen people having inequities, even accessing food. Like there's food insecurity. And like she clearly pointed out a story about that, yes, WHO sitting at the top is trying to like do so much about making the health system strong, but it is just a advisory committee. It's just advising countries to implement policies, but it's not implementing it on its own. So yes, we can make the best of the policies, we can make best of the advisory, but the implementation comes down to the countries and people like Sana who are working at the grassroots, and youth, Dr. Sanjay, like who's seeing patients every day at the grassroots in clinics, prescribing insulin. And also Emma highlighted the point that yes, you can have the best of the technology. Coming from like Emma and I am representing a high income country right now, from UK and US, we know even within the country, people cannot access insulin, cannot even access resources. And she also pointed out that in Africa, you could provide free insulin to people, but it comes down to the basics. They cannot even test blood sugars. They're not even getting one test strip. And if you think about type 1 diabetes, which policymakers think that, yes, we are trying to build up a health system. It comes down to so many layers within the health system, which need so many gaps to be filled. And I think that's where all of us are sitting here today to help us bridge those gaps. I think we are all doing our part in that big puzzle, solving pieces, but it has to be synchronized. We are working in silos right now, and that's why our health system is super fragmented. Coming down to WHO's policy about like what is being done. Yes, everybody realizes there are challenges. That's why type 1 diabetes is a super complex condition. And over to that, overall diabetes is coming to be a pandemic now, I would say, at all age groups. So it is rising. But from a WHO's policy perspective, for the first time in 2021, WHO realizes there was a window of opportunity. And like in policy, we say that yes, COVID did bring a huge window of opportunities, highlighting the fact that people living with chronic diseases, especially diabetes, are at higher risk for getting COVID-19 pandemic or infectious pathologies for that matter. So I think what WHO started was something called the Global Diabetes Compact, where the attention of diabetes care was highlighted from a healthcare system perspective, highlighting about data, highlighting about the existing access to insulin and existing disparities, which are at huge levels. We never had targets set up. Like, what are we trying to achieve? Yes, we can make n number of policies, but till when do we want to achieve? So I think it was the first time in 2022 that WHO highlighted that these are the 5 targets we want. And I think Sana and Emma, please echo what the targets look like, because they've been involved in the decision-making process. And we had to really fight through the fact that for years, there was no target for type 1 diabetes access. For the first time, WHO made it a target that by 2030, we want 100% access to insulin for all people living with type 1 diabetes. It's a very, very far-reached target, I would say. And because a lot of people we know, I think Sana would know, cannot even get insulin, and we try our best to give them free insulin. Even Emma, through Life for a Child, knows the existing disparities within Africa. That 100% is a very far-edged target. But if we don't reach that 100%, we are actually reducing. If we don't make it 100%, we are actually not taking care of our children who are living with type 1 diabetes. We are actually making things miserable for them to not get insulin and just let them die. So I think I am a very strong advocate for that yes, if you give the best to the children, it all comes down to how we can build an environment around it. But then they have to get the resources first. They have to have their toolkit in their hand, and then we can we can modify, we can tailor based on their individual needs. I think Dr. Banshi is also here now, and thank you so much, Dr. Banshi, to invite me, Emma, and Sana here and share our stories, our individual journeys with type 1, and also our experiences working in the field. So it's a huge honor to be here. So I was just building up from Dr. Banshi's stories as well, because I've worked with him as well. And he's highlighted so many times that, Apura, yes, we can provide free insulin to everybody in the country through our initiatives. But it all comes down to what are we going to do about the food? What are we going to do about them checking their blood sugar? There are children who are so scared sometimes of their doctors that they basically change their logbooks and come to the clinic saying that I have perfect blood sugars. This is me, but then
110, 130 really focus.
I think the policymakers don't see all of that. And these are things which implementers see it. So I think what I said in the beginning, it beautifully highlights to what Emma pointed out about disparities in the data, and Sana pointed about the access to the challenges. And WHO has set up targets, but ultimately, yes, we can set up the targets. It comes down to implementation. And implementation are people like you, Dr. Sanjay, Dr. Banshi, Sana, and Emma. And I'm trying my best to work in Africa right now through implementation policies where we can actually build up better models of care. And we are the people closest on the field. We understand the inequity challenge, the social determinants of health, which Dr. Kunti also pointed out in the previous session, that yes, we can give technology, we can give best of the things to the patient, but it needs to be an empowered, educated, and a patient or a person living with diabetes to feel more confident so that he can thrive, or he or she can thrive living with the diabetes condition he's been living with. So I think there's a huge scope here, and echoing from what Emma said, that yes, there's a window of opportunity. It's for us to unleash and make the best use of the window of opportunity. And WHO is trying its best, but implementation comes down to us. So
yes.
That's
Thank
how
you, Dr. Purva.
Dr. Reddy, can I make one quick comment on something Apurva said? It was just, and Sana mentioned this as well, it was just on the aspect of silos in this space. And I think, as I mentioned, there's never been a time where more collaboration has been prioritized between different stakeholders. It is the best feeling when I see meetings or events bringing together different stakeholders, because we don't want to continue shouting into the same echo chambers that we already know. But I want to say this point, which is that just because things have gotten better in terms of reducing silos and increasing collaboration doesn't mean that it's even at a level that is acceptable yet. It's getting better. It's heading towards good. But in my view, on this particular subject, good is the enemy of great. And I do not want this community to stop at good. And what I want to see more of is actual policymakers present. So let's say non-diabetes experts, let's say general, representatives from ministries of health or ministries of finance even, being present at global meetings so that, okay, let's say they say, okay, our government can start procuring adequate test strip supplies so that young people and adults who need to monitor their glucose levels can test their blood sugar. But I'll give you a story from Rwanda when we started to supply test strips into the country. We started supplying test strips in, but nobody was testing their blood sugars because they didn't have the education, they weren't empowered to do so. And that's just a small example of how, education is not the cherry on top. It's not this extra little dessert to add on the side It's part of the whole package. It brings everything together. You can't have good mental health without education. You can't have decent monitoring or empowered self-management without education. And on the point about the WHO targets, the WHO targets do not include anything about education. And I can understand why, because education is a very difficult thing to monitor. But just because something can't be measured doesn't mean it shouldn't be incorporated. This kind of ties into some themes on quality of life and how that is so important. But I think that education really needs to be placed at a place with much higher priority from the get-go, and various healthcare professionals who may not be as woke to the need for education. They need to hit that great target. We need to see great targets being hit, not just good targets. So thanks, Apoorva, for
let me summarize till what happened till date. We don't need good people. We need great advocates like you three here. We need great politicians. We need great countries. We need countries without war. We need countries without conflict. We need great finances, great system, not good ones. I like the word great.
Can I share a joke,
and we
Dr.
need
Reddy?
great infrastructure. And I think that's where we are headed. And thanks for that statement. We need great initiatives, not good ones. So at least great initiatives will come. We need all great initiatives, great advocates like you, great politicians, great countries, great financiers. I think we need all the great things to be done. But thank you very much, Emma. And I had a question. Now, we all have this resource poor setting. We're working in different countries across the world. There's access to insulin. Some of them is not there. Access to STIP. What is the bare minimum? I saw you work on cost and outcomes of individuals with minimal care. Now, I know we need great care. We need great outcomes. What is the minimalistic? And I like Dr. Apoorva's statement. Say, yeah, we're going to give insulin. What is that great we have achieved? Yes, properly prolonging the life of the child for longer. Or what are we trying? We're doing something. But to do great and to do, what's the minimalistic care would you recommend for a type 1 diabetes child?
So I think Dr. Reddy might be referring to a paper that we published on the cost effectiveness of type 1 diabetes care ourventions. And within that structure, we refer to a levels of care framework that Dr. Ogle and colleagues had developed. But within that framework, we define minimal care, intermediate care, and a sort of advanced level of care that you might see in, possibly affluent parts of India or in the UK or in the US, some parts of the US, and in Europe as well. And an intermediate level of care is what we argue for in countries who have resource constrained settings. So minimal level of care would be 1 or 0 test strips a day, an insufficient amount of insulin, no complication screening, but the health system ultimately paying for complications that do arise later in life. An advanced level of care is, what you're seeing in terms of CGMs, pumps, modern insulin in high resource countries, but with intermediate level of care, which we kind of see as the holy grail to aim for, is about 4 test strips a day, access to insulin, access to complication screening, and access to a skilled multidisciplinary care team. And I know I might sound like I'm contradicting myself here, but I did talk a lot about the word great in my previous answer, and it is important to aim high. especially when it comes to global movements. But when we're talking about sustainable progress that can be made on a country and local level, it is important to be realistic, and it is important to not have a wish list that is just totally unrealistic. And so it is for that reason that, within the health economics model, we didn't model interventions based on that advanced level of care. And data shows that good outcomes and serious reductions in HbA1cs and improvements in quality of life can be reached with that intermediate level of care. But again, education is so critical there.
Thank you, Dr. M. This is what we did the last 20 years. We started with 2 patients. Now we take care of 3,500 patients across 30 different centers. We started with minimal care 20 years ago. Somewhere in between intermediary care. I wouldn't say that, okay, but access to all of it is there, but my children still don't test 4 times a day. In spite of so the question comes down to education. Now, we come to this intermediate level of care in some parts of the country, in some parts, not that we're able to reach everybody who's there within that defined population, but yes, and this is all done individually with collaboration. As you told, the individual should be responsible. We have a fragmented care, people doing all this, and the greatest thing which has happened is probably collaboration, but it has to go on to a great extent to make sure this happens. I have a question to Dr. Sana Ajmal, who has a similar, I think, a similar setting as that which we work on, and many countries in the world have settings that are similar than what I deal with. And I want to ask Sana, Dr. Sana, how difficult and what's the crucial role of the caregivers of the type 1 diabetes? That children, when they diagnose, until what age you handhold them to say that they're educated enough that they take care of themselves. So this depends on many factors. I'm not going to get into it. I want to hear from you, your stories and your experience, and what you try to overcome these difficult aspects of educating caregivers, especially mothers, parents, or whoever is the caregiver is. Sometimes it's not the parent, could be somebody else here. Over to you, Doctor.
So, thank you, Dr. Reddy, for this question. I would really want to start this with what Emma and Apurva were saying about access to either insulin or test strips or education, and all of this is somehow related to each other. So, when we talk about one of the WHO targets, as Apurva was talking about, is 100% access to insulin. Now, when we talk about situations like the ones in Pakistan and like the ones in India, we're very similar in terms of our healthcare structure and very similar in terms of our social and cultural challenges as well. So one challenge is, how do we actually define that access? So how can we say that this access is 100%? So, for example, I have gone across the country, talked to so many hospitals, and there's a stark difference between what is being said by the system and what is being said by the community. The system will tell you there is access. We provide insulin to 100% of the children. We also provide education, right? But on the other hand, what happens is, now the child would be, the family would be saying, the care provider would be saying, I'm a daily wager. I can't go stand in lines every 15 days or every 1 month for a whole day to get that one vial of life for my child. I've got 10 children. Literally, we know that families, specifically in our rural areas, can be very, very big. I have 10 children. If this one dies, doesn't really matter. And that's where you were pointing out educating the caregiver. Now, our caregiver probably looks at the family, the children, as an investment into the future. Like, these children are the ones who are going to harvest the farms. These are the children who are going to sow the seeds. They're going to water the farms. They're going to be breadwinners in the family. And this is very important when we think about not just the big cities, but the smaller towns and the villages, areas like these. They have to really think about, am I investing the time that I'm investing, the sheer amount of care that I have to give to this child, and the cost of insulin and the cost of the test strips, or the cost of trying to access all these resources, does that really give me an advantage when he or she would grow up? Would he or she be able to earn like the other children? And the answer, sadly, is no. Because, and I'm not one for, apart from being realistic, I do think that we really need to lay the map down, and we really need to define where we want to start. When we start at minimal care, the answer to this question would be no. When we start at intermediate care, yes, maybe. When we go a little above intermediate care, then these things might actually start making sense to the caregivers. And that's where education is also important. So education is not just about trying to educate them about how to manage the insulin levels. Education is also about how will this child be able to become an earning hand for the family when he or she grows up, if you provide all this care. And I think this is one of the areas where we really need to work on. And probably the policymakers need to see the long-term benefits of going of at least starting with intermediate care and bring down a roadmap of when and how they want to go to advanced care for these children. Now, a child with type 1 diabetes can be a very, very good resource for the family if they're provided proper care, if they have their insulin, if they have their test strips. It would be very good if they have their CGMs, because it will save them from a lot of difficult episodes. But at the same time, another thing that needs to go into the training is the health professional training. That's also something that's missing, because the specialists are very few, and it's majority of the general practitioners who probably don't know much about type 1 diabetes, who are treating type 1 diabetes in smaller cities and towns. And a lot of attention needs to be paid to that as well. Also know that there are issues with gender inequities and stigma related to type 1 diabetes. So people really don't want that to happen. And for that, we need to probably look at changing the key messaging around diabetes in general, because that creates a lot of stigma, not just for people with type 2, but also for people with type 1. Also need to look into how to ensure that we don't discriminate between the two genders when it comes to providing diabetes care.
Dr. Ajmal, Dr. Sana, I definitely echo your points. I've been through this same story on and off over the years, but it's changing for the better slowly. I hope it will do great things in future. I've gone to homes of parents trying to tell them the gender of the child is very important. They didn't want to disclose this child as type 1 diabetes because of social reasons. They say they couldn't get her married. They won't send her to school. One of the biggest determinants was stopping them from going to school just because they had type 1 diabetes. So we had to incentivize them. I said, okay, now let's work through it in a different way. So you send this child to school, and this is the incentive. We will take care of whatever the small logistic fare, and we try to open an account on mother's name and say, okay, this is the amount of money we're going to give to you if you stop sending this child. Another important question to address is, now, not many of them, those who excel, many people like all of the type 1s, we want them to excel, but with the resource for setting them, a lot of other issues which come in. Then how do we make them self-independent? So we started employing them, started telling people who dear, but say, okay, you're an industrialist. There's somebody who needs a job, who can be very good, who can take him. And these are small things, but just wanted to share the same thing, and echo the same in this part of the world. And I think Apurva would agree. And these are the things which we keep doing, and at a small level, and hope they can change over the years. Now, I just wanted to go back to Apurva. I think I have a list of questions. I don't know where to ask and where to stop, but I will try and see if I can ask you. Now, one of the biggest challenges with type 1 diabetes in terms of, or chronic type 1 diabetes especially, is we talked about insulin first, then education. The other thing was the basic care or the intermediary care and how we go on from there. Now, how far and what, I know you work on advocacy. I'm talking to you, all of us know, and it's not easy to deal with governments, to deal with organizations, to deal with policymakers. Throw some sides where we as individuals, doctors, educators, can come through and take it in a way to do some sort of advocacy to change policy. Now, for example, I'll tell you a small thing. Type 1 diabetes child going to an examination hall is not allowed to carry a snack. See, UPSC exam. I know you've similar. How do we change this? So we need to fight for it. We need to get legislative. Tell us some ways to go through this.
I think that's an excellent question, I would say, because I often sit alone and think about this. How can we start doing this? And I think I feel free to jump in, Emma and Sana, on this. I think as a person living with diabetes, for years, we've always thought that advocacy means like going to the policymakers and making changes at the level of like the places where things take years to move. But for people like who are living with type 1 diabetes, like me, Sana, and Emma, advocacy for us starts from the day we get diagnosed. For us, we are the people who understand what's happening in our body, what we need, what works best for me. And when we think about individualized care, it starts from us. And we have to keep advocating from day one to understand what would work best for us. And that's where partnerships come in. We need to partner with our medical providers, with our health team, with our dietitians, with our mental health workers, with our therapists to think about how we can make things better for us. Now, I missed a very important piece there. Comes down to peer support. For years, and you would agree to that, Dr. Sanjay, for years, people with type 1 diabetes have felt alone living with this disease. And that's one of the reasons even in our country, in India, like when I was diagnosed as a female, and you highlighted that, as a female, I was told to hide my disease. And I was from a city, from a city which is considered to be diverse and considered to be very, I was from Delhi, and Delhi has a lot of resources, but still that stigma made me hide my disease throughout my medical school. And medical professionals who were working and studying with me had that misconception that Apurva is not going to survive for after a few years. So it doesn't really matter if she studies or does anything. So even as medical professionals, we're totally unaware of it. And I had to keep advocating during that time that, see, it's us who are going to deliver care. We are the future doctors of our country. If we don't provide that narrative that people living with diabetes can survive, can thrive if they are given all the resources around it. So that's advocacy. We as healthcare professionals need to also advocate at each level within our health system, because it's difficult. Our system's overwhelming. I understand doctors don't have time. We see hardly we see 100 patients in one day sometimes, and we have to see all the type 1s during that time. And it's very difficult to advocate. But advocacy doesn't mean it happens only at policy or legislative level. It happens from the grassroots. It starts from the houses of people living with. It starts from our doctors' appointments. It starts within our closed echo chambers, but it also involves partnerships, and it involves us to come out of our silos to really collaborate and understand that policy can only be moved when we have opinions and responses and advocacy movements from all directions, so that there's no way the legislative agenda will not move. So I think moving the legislative agenda, yes, that takes years, but it's possible when we start. And right now, I feel that only very selected areas are advocating for it, because right now people feel, oh, why do we advocate? First, we should just see our patients and just get rid of it. Like as healthcare professionals, we just want to get over with the burden of diabetes. We just want to, I heard this, and I don't know if I should bring this up, but from one person, like a healthcare professional within India, I heard that, type 1 diabetes, I do it for charity. What gets me money is type 2 and the complications. And I felt miserable because as a person living with type 1 diabetes, I felt like I'm charity. Like, for you would not spend time with me, you would not spend more than 10 minutes with me for my clinical care, because I'm charity. I'm not getting profits. I'm not getting money for your consultation. But I know you, Dr. Banshi, have been seeing patients for free, and you've been spending more than 30 minutes. And I think you've been advocating for it. You've been advocating and doing such platforms is because you realize that people living with diabetes have to be on the table for discussion making, for decision making, and to move the policy or legislative agenda, which is difficult right now, but there is a window of opportunity. WHO is doing from a top-down approach, but we as healthcare professionals, as people sitting on such platforms, can move the agenda from a bottoms-up approach, so that both approaches can help us move the agenda. And finally, people living with diabetes and also physicians who are working in the diabetes space can sit together on that table and understand that this is what we need and this needs to be done. It's been years. It should have happened long back. It took us 100 years to even talk about, since the insulin discovery, about access to insulin. But yes, Emma put this in the talk. Yes, stronger together. We don't have to work in echo chambers. We have to come out and make sure that the legislative agenda moves, and we can make the best use of the windows of opportunity that keep coming up in different health systems as well.
Apurva, so nice discussion, which I'm listening since long. And Apurva, you are really too good. Sitting in US, also try to do a lot of advocacy work in our country. I'm also thanking Sarah and Itma. But the more point is here important is for Ima and Sana to understand that Sana knows, because she is from Pakistan, then India and Pakistan situations are more or less same. And as Sanjay was talking, that we need strong advocacy, we need, big people, we need multiple things. But I think only one thing which is required, the change of mind in the society as well as for the doctors both. It is the awareness, and since last 1 decade, we are working very hard, and I'm sure in coming decade, as she was talking, that by 2030, insulin for all, should it become possible, I think it will be. And from India point of view, I can tell definitely, Apurva, that at least insulin will be available to each and every child of our country who is developing type 1. That much we can tell from the platform of IDF, from the platform of Diabetes India, and probably from the Indian industry also. But maybe whether they will able to get a good education, will they able to survive normally, will they not develop the complication, will they have access for a 4 times glucose monitoring, will they have the access for a basal insulin analog with a rapid acting insulin analog, that I can't say, but definitely at least insulin will be available to each and every child of our country. We have now district coordinators, we have now taluka representative, 10,000 taluka representative to whom we are training them for basics of type 1 diabetes care. And I'm sure probably in coming years, maybe in 5 or 10 years, many of our type 1 diabetic patients will have normal life. And from Diabetes India, we are thinking that more than 1 lakh children should be supported. Already more than 15,000 children are supported by different organization and NGO, but it will become 1 lakh in the coming 2 years. That's much we can tell.
Thank you, Dr. Bansi, for that update on what's happening across in our country. I'm trying to get an advertisement on type 1 diabetes in the national news channel. Hope I succeed. I'm not till now. I'm raising my voice wherever possible. Say, please give an ad for type 1 diabetes. Tell people with this, get this one here. Yes, enough. We have seen enough of tuberculosis ads, enough of cancer ads, enough of ads on no smoking, alcohol. Please get one diabetes ad. Anyway, one of the days the government is going to say, okay, these ads on diabetes are going to be free on all channels, and at least we'll get to educate a lot of people. I want to hear Emma's perspective and Dr. Sana's perspective on the same. This is one of my small goals. Hope I can succeed sometime, and will definitely do it probably in the coming years. I try every year. This time I'm going to make somewhere, go and make a hartal and say, can you get this? Please go ahead. Yeah, Dr. Emma and Dr. Sana, your views and how we can, I heard of Purva's view that it starts from the day 1. I like that. Everyone should be a type 1 diabetes advocate. How many people can you gather around you? to make this a real global movement for people. It's never, though it's been 100 years, only the last 3-4 years, this is an attention towards type 1 diabetes. It's always a surrogately discussed disease, because the amount of, say, it needs the maximum number of people, maximum number of care, maximum resources, and it should be given a priority. And I see all of you achievers, why there should be anything called charity there. No, whether they get it in anywhere, it should be on the front. And I think, I don't know how many countries advertise type 1 diabetes. Maybe, I'm not sure across the world, there's any advertisement on diabetes. Yes, maybe in the US, a commercial ad in diabetes followed by something, but I've never seen ad in other countries coming on national TV. Yes, radio talk shows are there. There's on social media. There's on everywhere else, but not a front paper ad. In Times of India, the largest selling paper saying, oh, I can see only reality ads or something on Meta or anything else, but there's nothing like something of hope a day will come where I can see that. And people are aware, become conscious of this is there. This is part of it. So any other comments on Dr. Emma?
Just one really small comment, and it goes back to what you were saying about a larger advocacy issue in the community, which is students sitting in exams can't take in, what they need to be successful during exams, which may be a snack, a juice, whatever. And I think Apoorva's response to that was really interesting in about, when you get diabetes, you become an advocate on that day of diagnosis. And I think for myself, I can just share something quite personal. I've been used to working on advocacy in a really big way, in a very global sense. But sometimes I forget that I have to be an advocate for myself, even though I live in a very fortunate situation where I don't have to worry about cost of my care to a large extent. I still have to advocate for myself in the health system that I live in. I still have to advocate for myself as an individual living her daily life. And I had a big reminder of this in the last couple of weeks, and I had to kind of pull myself back from the kind of big advocacy level to advocating for myself. We have to advocate for ourselves. And I think bring this back to your point about not being able to bring in a snack or a juice to an exam. I think when we have more awareness of type 1 diabetes, which is kind of, I guess you could say, niche in the NCD space, when there is a public service announcement or an ad about type 1 diabetes, or somebody famous within your country talks about having diabetes and what is needed to be okay on a day-to-day basis that maybe other people don't need, then we have, those who are designing those rules about not being able to bring in snacks during testing. We have a more generic population listening and going, oh, this type 1 diabetes thing, people with type 1 diabetes need things that others don't. So I think that Dr. Reddy, keep going with your advocacy, keep pushing to try and get type 1 diabetes awareness injected into the general space. It will help. It's hard, but it will help.
Dr. Emma, now I think we are at 6 o'clock. We have still time. I can still prick your brains and probably your experiences. Now we have, I understand, but it's a little out of, it's a little, we just go away from advocacy, and we have a technocrat here, and I don't want to pick brains because there's a lot of technology happening around. I know this is, technology is there everywhere to help patients. Now, most of us in many countries with the access to a phone, phone is like more accessible than anything else in the world at this present day scenario. It could not be medicine, life-saving medicine or anything, But phone, yes. I think 70% of the world population will have, I don't know, maybe my data is not, a phone. Now, with technology, with social media being so prominent, so I'm not a part of any social media site, but want to explore the fact and how technology, social media can play a part. They play a part. Can they play a valuable part in improving? I know we have used a lot of technology, especially for pumps and so on, in the minimal and the intermediate care patients. Social media and technology play a part in improving life of patients with type 1 diabetes. I want comments from all three of you.
I'll start with a really quick one, and then I'll pass to Sana because I think that she is the expert on what I will hint at. But essentially, with CGMs, with pumps, with AIDs, obviously smartphones are crucial and super beneficial in helping improve monitoring and diabetes care on a day-to-day basis. But until access to CGMs, is ensured for everybody equitably globally, I still believe that the power of social media and the power of peer support groups, whether that's on WhatsApp or Facebook or Instagram, can be so, so, so powerful. And it's not a crazy expensive intervention, but it can work well if it is supported. And so I want to pass to Sana to talk about that because I know she'll have experience with peer support.
Oh, thank you, Emma, and thank you, Dr. Sanjay, for this question. This is vitally important. So I'll begin with that peer support on social media has changed my life personally. And so as per the testimonials of so many other people that we have established this peer support platform for, it has changed their lives. It is a medium for not just providing the social and the emotional support. It is also a medium for relaying the education. So some of us may know a lot, while some of us may know nothing. When a person, social media groups are usually very non-judgmental. So anyone can come in and ask a question without being afraid, without being afraid of anything, without even being afraid that they're different and they might be asking something that's entirely different to the rest of the people in that group. So one thing that has ensured is that even if someone is not asking a question, even if someone is not really interacting, they're still reading what other people are talking about. And they're getting a lot of passive education from that social media platform. So social media can be a very good tool if utilized properly. I'll say this with caution, and this is a concern that has been raised by many health professionals, and it is something that is discussed globally by health professionals about the safety of the medical information that is being there. That is being discussed there. So one thing that we experimented with and has been very helpful was to lay some level of monitoring on the content that is being shared. So every 6 months in Meet Zindagi, we train 25 community members as peer leaders. And their task is to make sure that there's a day assigned to each and every one of them, and their task is to make sure that the information, that the conversations that are being held include safe medical information that do not go beyond a certain boundary where people may start experimenting with their insulin dosing or something like that. So that has actually helped us gain the trust of the health professionals as well, who actually recommend peer support and our platforms to people under their care. But it has also helped us be sure that whatever we are conveying here is something that is safe. And something that people have learned either through their health professionals or through their life experiences, and they discuss that. A lot of things that I have learned today, including carb counting, I've learned from the social media platform. and many other international social media platforms as well. So yeah, I hope that answers that's just one of the ways social media can be used for improving education.
Thank you, Dr. Sana. Dr. Apurva, your comments on the same?
Yeah, I'll just add on to the comments from Emma and Sana. And I think I echo to what Sana said, that yes, social media did change my life too. I would say that I thought, like, while I was, when I was diagnosed with type 1 diabetes, while I was looking for answers for my own condition, I was looking for people who within the city, like, who were living with type 1 diabetes, because I was hiding it, like I mentioned, and I didn't want people to judge me. And that thought of, like, social media being a non-judgmental platform where I don't have to really show my face to anyone, and I can just be there and listen to people and gain peer support, was actually what made me get out of my own overcome my own stigma and finally understand that, yes, I need to let it out and I need to be a voice for others who are still overcoming that stigma around the diabetes space. So yes, social media did do a lot of, like, it made me who I am today, I would say that. But yes, also echoing to what Sana said, yes, social media needs to be taken with caution. And yes, it does have a huge potential, but like everything has a side effect to it. I would say there is a lot of misinformation around social media as well. And we would have seen that Dr. Sanjay and Dr. Sabu would definitely echo to this, that we've seen a lot of misinformation even within India in our medical field, where people don't want to start, they don't want to start insulin because they feel it causes addiction. They don't want to do insulin because they feel, yes, we can stop it. We have herbal medications, we have allopathic, and we have lots of, like, big people even within India who are promoting that, oh, they can cure type 1 diabetes. They can completely stop diabetes to be like a global health problem. So I think we need to be careful about that side when we are dealing with. And I'm sure you would come across so many patients every day who've done this once, twice, stopped insulin, landed up in DKA just because of that social media misinformation they were exposed to. So yes, I think there's a good side, but there's also misinformation around it. Also highlighting there is a misinformation around the type of diabetes and why people feel that, oh, diabetes cannot happen to children. So I think that's where the point of education and awareness comes into picture. And with education, like Emma said, that we cannot measure education, but we can start educating our patients from the doctor's appointments, from the peer support groups. We can use the good side of social media to bring effective models of education to overcome that misinformation. And I think it needs to go, that balance needs to go hand in hand. And that would actually help us overcome so many misinformation around it. And also adding one more layer to it around the misinformation about the diabetes type is a lot of us have felt that the type of diabetes makes us into two different, like the type of diabetes we become into, oh, type 1 diabetes has better work, better noise around it. Type 2s they are blamed for doing it that to themselves. And I think we need to overcome that siloed approach there as well when you're typing the type of diabetes. And that's where we need to make sure the social media doesn't, instead of making people more inclusive and like people who feel more fit and feel more inclusive, it's actually segregating our own diabetes community. So we need to play that really well. And that's where education, awareness, and peer support starts. And I think even within India, there are a lot of peer support groups. And I would like to mention a lot, because India is so diverse, misinformation spreads like fire. And we need to emphasize that people who are closest to the grassroots can be targeted through these peer support groups who understand their culture, language, and can identify how we can do social media better, how we can deliver information better, more safe, and make it more inclusive for people. And I think that's where the peer support groups, like ones in Bangalore, I think I can name a few of them, like Blue Circle Diabetes Foundation, we have Diabesties who are working in Gujarat. all of them are doing fabulous work, and they're tailoring to overcome this social media misinformation so that we can understand what people are going through on a daily basis. And as physicians in the hospitals, we can overcome this by building trust for our patients so that they don't land up in stopping insulin and coming to with DKA, which we could have just avoided just with misinformation. So I think that's what I would just want to add there. Yeah.
Thank you, everybody, for the information and usage of technology and social media. Those social media and peer support groups really help every type of disease, more so with type disorders, more so with type 1 diabetes, but immediate reactions to false information by people who advocate and strongly write scientific evidence and share their experience on type 1 diabetes should be immediate. You see a message that's misinformation, I think we should jump into it and make sure that we kill that, we give the right information and tell this is false, this is how it is. Need not wait. It's like a vote. And if you find that's going to trouble us, I think we should act fast. Thank you very much. That was very insightful. Now, one last question to all of you. Now, this we've completed. We have 5 minutes on type 1 diabetes. We've been talking about advocacy. We're talking about disparities. We started with disparities, the challenges, disparities, advocacy, social media, different countries, different socio-economic, cultural barriers, how gender also can play a role, education, how we can get it onto the media, how we can improve the country, ask our people in our country to be good advocates and start being advocate for yourself from the day one. That's something which I learned from all of you. Thank you very much. The last question, how do we improve lifespan of all our type 1 diabetes like everybody else? You know, we have the medalist study, and if I know Apurva knows the medalist study from Harvard, and that's something which really I've been talking how they could prevent complications even for 50 years of diabetes. It's a model by itself. I think it's a great model. I don't know if that I thought it was a good model. So how can we do this across different platforms? Viewpoints from all of you for one minute, snapshots, some take-home messages, and then we wrap up the show. First, start with Dr. Emma. Go ahead.
I think it's hard to pick one way that will increase the lifespan of people living with type 1 diabetes. But I will pick one that is, in my mind, both the hardest one to crack but the simplest, maybe. I think don't underestimate the power of empathetic healthcare professionals from the get-go. From the moment that a young person is diagnosed to the adolescent years to them growing into adults and to later in life, the power of empathy within the clinic visit is so important. I cannot underline that enough. Positive associations with managing your diabetes when the resources are there are so important. And taking the fear away from the clinic visit makes a person with diabetes feel empowered, listened to, and like their healthcare professionals are on their side. Early messaging in a young person's life with type 1 diabetes stays with them for the rest of their lives. And if they get good messaging early on that is empathetic, caring, and that really values listening and being on the same team as the patient, I think that is a very sustainable approach to keeping somebody with type 1 diabetes feeling like they have power to be healthy. I could talk a lot more about that, but I'll leave it at that for now.
Dr. Emma, Dr. Sana.
Yeah, as Emma said, it's very hard to pick. I would just cut it right here by not dwelling into it is personalized healthcare, and what Emma said is a part of that as well, which also means that the treatment that we're providing and the education that we're providing should be tailored to the person's life instead of the other way around. That can probably go a long way into ensuring a good, healthy life for that person.
I think Sana and Emma have spoken what I was thinking about, but definitely that's where we all come in here for. And I think to actually picturize what your question meant would be, would Emma, me, and Sana being here sitting on the panel, who are also people living with type 1 diabetes, are examples of what lifespan looked like. For so many of us, we would have heard that she wouldn't have survived beyond 13 years of age. And I think we are examples. I think we being here should actually set that example. Yes, people living with type 1 diabetes, if given the resources, the toolkits, and if given that proper education, can actually excel anything in their lives, irrespective of where they come from. And we have to ensure that we maintain that environment around them for our children to actually thrive. I don't want to go into scientific information around it, but I think empathy would definitely start from our doctors' rooms, and also empathy from the peer support groups. I think that's where people living with diabetes wouldn't feel alone. And I think we sitting here are telling you that if we can actually, there are people living with diabetes even beyond 75 years of age for whom who had heard that, oh my God, you will not survive even beyond 13 years. And like parents had to actually give away their children just because with that thought that, no, this child is just worthless, useless. But I think we are changing that narrative. Emma, me, and Sana are here to tell you that, yes, we can change that narrative. And then there are even more inspiring examples of people who have achieved way, way greater than us, if given that environment and that toolkit to basically be able to thrive and not just survive, I would say, with diabetes. And I think that's where
Thank you for answering this question beautifully, all three of you. It's a very difficult question for me to ask first, knowing the background of all of you personally, as well as a doctor. The empathy which I showed to my patients, more than being a doctor, and the care and being human about it, being open about it, and talking everything about you three have made my day and made day of all the type 1 diabetes are listening to this program. Probably it's recorded, it's available sometime in archives for people to say, thank you very much. I really appreciate you three coming forward and sharing your thoughts so beautifully today, and well thought of. And all of you three are working in type 1 diabetes, being yourself a diabetic. And I really appreciate it. And I like all four of us, probably, even if I'm alive, we have the discussion 20 years from now. And that would be the icing on the cake. With this, I'll leave you a picture of the mango blossoms, like the cherry blossoms. Sorry, I cannot take you outside and show this. It's wonderful to have a look at mango blossoms, and the fruits are very delicious. I know if that's my favorite, and it's our national fruit, and you have so many varieties of it. And I hope all the type 1s will live to enjoy them if they can manage the diabetes better and eat the fruit as sweet as a mango and have the life as sweet as that. Thank you very much for being on the show. Really appreciate all of you. Thank you very much.
Thank you, Dr. Sanjay.
Thank you so much.
Thank you so much for inviting us. It was an honor.
Thank you. Thank you.
And it's always good to see you, Emma and Sana. Like, it's amazing to be on the same channel.
Likewise. Thank you so much.
Same here. Yeah, it was wonderful seeing you, and thank you so much, Dr. Banshi Sabu and Dr. Sanjay, for this invitation. It was very nice talking here today and very insightful as well. I've learned quite a few new things from Emma and Apurva. Thank you for always inspiring me.
Thank you, everybody, and I hand over to the organizers. Mayank, we have the next session, or we're closing now?
Sir, there is a closing ceremony.
Okay, and thank all of you. We'll be closing the ceremony, and what a way to close. On a Sunday evening, talking about type 1 diabetes. It's been a real eye-opener for me in some of the aspects. To be dealing with type 1 diabetes children for a long time. Thank you, the three of the best global advocates I have here on the panel with me. Thank you, Dr. Emma. Thank you, Dr. Sana. Thank you, Dr. Purva, for sharing your thoughts. And what a way to end the IDF SCA meeting. Thank you, Dr. Bansi Sapu. Thank you, Dr. Ajmal. Thank you, Dr. Asad Khan. Thank you, Dr. Shashank Joshi, previous chair of SCA, and all the members of the Southeast Asian Federation. Oh, I've missed seeing you all. I was there in Lisbon, probably the next IDF meeting, but in between we can meet in any of these forums to come. Thank you very much. Thank you, Mayank. Thank you.
Thank you, Dr. Sabu.
Thank you, Purva. Thank you, Sana. Thank you, Emma. Thank you, Sanjay.
Thank you, Dr.
For a
Bansi.
fantastic session.
Thank you for inviting us to this panel.
Real interesting. I'm very happy to share this news that we were having more than 7,000 delegates from all across the country, as well as from other Southeast Asian countries. And what more is, at any given session, there were more than 70 doctors every time, and up to 700 doctors were there today and afternoon. So that was, I can say, the success story of this IDF Southeast Asia Learning Program. I'm very happy, and I'm thanking our IDF Southeast Asia Chair, Dr. Azad Khan. I'm also thanking immediate past Chair, Dr. Shashank Joshi. I'm thanking RX Event for executing this program. I'm thanking all the faculty members and all the chairpersons who were there for last 2 days. I'm thanking all the coordinators. Because of them, we could execute this program. Thank you once again. Thank you, everyone.